and researchers looked for a relationship between pain and morphological features such as disc degeneration. What key findings came out of this study? Every patient showed morphological changes in at least one disc's appearance when comparing the not loaded with the loaded MRI scans. Most of them explained or experienced concordant pain during the axially loaded MRIs, and there was no significant difference in disc morphology between the discs that were concordantly painful during discography and those that were not, regardless of whether a conventional or axially loaded MRI was used. So what's the conclusion? Both discography as well as axially loaded MRI can provoke concordant pain in patients with low back pain, suggesting that pain is definitely load dependent. However, applying an axial load during MRI does not reveal any distinct or clinically useful morphological changes that explain the pain provoked by discography. However, the study concluded, therefore, that while both methods frequently provoke pain, axially loaded MRIs did not reveal anything specific, useful, or morphological features to explain the pain induced by discography. Therefore, more sensitive diagnostic tools are needed to fully understand the load-induced discogenic pain. What are then the current recommendations for provocative discography? Now, this is something which all of us has been mostly reading or talking about in conferences. Do we follow, or does anywhere in the world provocative discography come in the realm of treatment? The procedure has limitations, including its poor validity to prognosticate treatment outcomes of surgeries or interventions, poor specificity and high false positive rates, a questionable risk-benefit ratio, considering that there is potential for harm accelerating disc degeneration. So there are very, very scarce and very limited scenarios where it might be considered, which could be when MRI has not identified a specific cause of severe persistent pain and clinical findings still indicate a moderate to high suspicion that a disc is the source. Others, when multiple intervertebral discs appear abnormal on imaging and it's unclear which one is to be targeted or which one is responsible for the patient's pain. Lastly, to identify which specific discs are generating pain when a major procedure like spinal fusion and surgical procedures like total disc replacement is being considered. Now this again is not followed widely in our country or worldwide, but in US the insurance governing agencies make it mandatory. So it's one of the procedures that is being done over there. A step off about vertebrogenic pain. This type of chronic back pain results from a damage or degeneration of the vertebral end plates, the layers of bone and cartilage between the spinal discs and the vertebrae. The pain is transmitted via the basivertebral nerve, which is found within the vertebrae. Now, diagnosis of vertebrogenic pain, this can be done by correlating a patient's symptoms with specific MRI findings on imaging studies. The clinical presentation includes symptoms like deep ache or burning pain in the middle of the lower back. It's often made worse by sitting, prolonged periods, standing, bending forward, or physical activity. Here, the key diagnostic marker is the presence of modic changes, which are inflammatory or fatty changes we see on MRI films, T1, T2 weighted images. Initial treatment may involve conservative measures like NSAIDs, physical therapy, muscle relaxants, and if the conservative treatments fail, then basivertebral nerve ablation is a potential treatment. This is a minimally invasive procedure and involves radiofrequency ablation of the basivertebral nerve. So, The therapeutic avenues when we look at the discogenic back pain and vertebrogenic. Now, this provides us with a bouquet of dilemmas. The treatment landscape of discogenic back pain is equally complex. Current management strategies range from conservative approaches such as physical therapy, pharmacological interventions, to minimally invasive procedures like epidural steroids, IDET procedure, RAM communicants, bicoplasty disc denervation, annuloplasty, and lastly, surgical options including discectomy and spinal fusion. What would impact our outcomes is how precisely we demarcate our territory to invade, which means calling a spade a spade. Discogenic pain on internal disc disruption pain, often seen as a hallmark, which is the high intensity zone on T2 weighted MRI images, annular fissure, is thought to arise from the disc or the annulus. Does the high intensity zone of lumbar intervertebral disc, as seen on magnetic resonance image, have diagnostic value for discogenic low back pain? The correlation between the high intensity zone of lumbar disc MRI images and discogenic low back pain has been widely very controversial. Few meta-analyses systematically evaluate the correlation between the high intensity zone of lumbar disc MRIs and positive discography, as well as its diagnostic value. Searches were made in the PubMed, Embase, Cochrane Central, Science Direct, China Knowledge Network, Wanfang database, China Biomedical Literature databases, and Scopus from January 1992 to overall covering till June 2024. The outcomes were diagnostic values of high intensity zone for diagnosing discogenic low back pain. And two investigators independently screened the literature, extracted information, and evaluated the risk bias for the included studies. So a total of 25 studies, including 5,889 patients, were included in this meta-analysis. The meta-analysis from the available evidence suggests that high intensity zone has acceptable sensitivity and high specificity in the diagnosis of discogenic low back pain. Research using stringent inclusion criteria has found very clear link between modic changes when we come to vertebrogenic pain. Studies have shown strong association between modic type 1 change, where bone marrow edema, and modic type 2 with fatty infiltration, with pain during provocative discography, and with patient-reported pain and disability scores. So specific, more homogeneous patient groups have shown positive responses to targeted interventions like basivertebral nerve ablation and discogenic block procedures. Now, basivertebral nerve ablation is a minimally invasive day care procedure using radiofrequency energy to ablate the basivertebral nerve, which transmits the pain signals from inflamed vertebral end plates and shows significant pain relief, particularly in carefully selected patients with type 1 and type 2 modic changes. So the biological basis for this is targeted therapies. They work by addressing these nerve ablation, which carry the pain sensations. So what is then the evidence? We go by evidence for treatments that would go a long way, and we are safe as well as our patients are safe. So when we look at different treatment options for low back pain, particularly the discogenic as well as vertebrogenic pain, we have treatment options like intradiscal bicoplasty, intradiscal electrothermal annuloplasty, the IDET procedure. We have platelet-rich plasma and fusion or total disc replacement. Now, what does the evidence suggest? When we look at intradiscal bicoplasty, there have been randomized controlled trials which have shown promising results resulting from pain ablation or pain emanation, lasting benefit from 6 months to around 12 months. when we look at intradiscal IDIT procedure, it shows mixed results to negative results. And the evidence is overall inconsistent, considering that there is potential for further disc degeneration, so it not really is advised for future use. When we come to intradiscal platelet-rich plasma, again, we know that it involves injecting the selected or concentrated platelets, but again, there's very low certainty, and the body of PRP evidence is characterized as very low certainty. So again, has to be used with a bit of, you can take it with a pinch of salt, but still, it's not confirmed. So selected cases requiring more informed consent can be used in research purposes only. Fusion or total disc replacement is into negative recommendation solely if there is discogenic low back pain without any signs of instability or deformity. So this is the recommended and the evidence-based treatments that we have. Coming to basivertebral nerve radiofrequency
Mechanism action, again, mechanical decompression of adhesion fibrosis. You dilate the epidural space, improve the nerve fluid mobility. So that's a key here. With the balloon, I basically uses the balloon to push the nerve away from the herniated disc and use steroids to bring about the anti-inflammatory effects. And thereby, by doing this, you can get a good delivery of drug to the nerve root. Complications, again, it has to be very careful. People who are doing this procedure must know that it is a procedure carry risk. There's a risk of dural puncture, CF leak, epidural bleeding, hematoma. Infection is rare, but this has to be done under antibiotic coverage. You can get neurological insult, okay, and you can get systemic effect due to steroid. Okay, so because it's minimally invasive, the procedure requires smaller incision, resulting in reduced recovery time, less pain. Immediate post-procedure care is very crucial because you want to pick up, especially any neurological problems. So you need to make sure you follow up the patient closely, and you must have a plan for a proper recovery period. I mean, this procedure is painful. I mean, a couple of first few days you can give them some paracetamol or COX-2s. Okay, so the quick anatomy, I'm sure I don't have to go too much over this. Basically, there's 3 routes you can do. You can do the caudal, interlaminar, or transforaminal. The one I always use caudal because it's the best way to get into the thing. Unless I cannot get into transforaminal, then I use a specific, the two different catheter. One's for the epidural route, one for transforaminal. So caudal route is important that you can look at the you're inserting into the caudal route and make sure the catheter the needle has to be somewhere around S3 level. Don't push it too forward because you can injure the filum terminale. All right. So again, this is what we're trying to do because we're trying to there's a nerve root compress. We are using this approach and then we're going to introduce the catheter from that space. Okay. All right, so this is, again, you can do under ultrasound, just a locate, but of course, this procedure, or for that matter, any procedures using caudal, if you're going to do steroid, I would strongly recommend that you must use fluoro together because you need to see the contrast runoff. You cannot see a contrast runoff in ultrasound. You can only see the dilatation, but you need to see a contrast because if you don't have an X-ray to guide you, you can land up in trouble because you don't know where is the dye actually going to the right space. Okay, technique, patient in prone position. This has to be done under purely fluoroscopy. Okay, epidural access via sacral hiatus, steerable balloon catheter at once. You perform the dilatation, and then you inject steroid and hypodermic saline. I don't use hypodermic saline. I use steroid and local anesthesia. Okay, this is quick. This is a quick. I just did this case about 2-3 weeks ago. So this is the first case. A 50-year-old British male. He's an avid traveler. He presented with chronic low back pain from 2023. There's a radicular pain, deep buttock on the right side. Posterior thigh, calf correspond to right L4, 5S1. Visual angle score was 8. He has claudication pain, can't walk more than 200 meters. He was in South America when he did the MRI, and that shows a intervertebral disc prolapse at 2, 3, 4, 5, and 5-1. And there's a big ligamentum flavum and fasciculum hypertrophy. So this was the MRI, okay? So you can see he has a big disc at L5. All right, and there's one or two smaller one, as you can see. So blocking the entire, on the right side. Okay, so this is what I do. Is the first procedure usually, this is known as a standard epidurolysis, where I put a epidural needle, 2E needle, and I push up the catheter. So what I want to find is get the contrast flow. If you can see the contrast runoff, there's no runoff to both the nerve root at the alpha level. So I couldn't get. So what I did a transforaminal on both sides, and I usually do something called pulse radial frequency of dorsal root ganglion. Right, I did that, and with that patient had a good relief. So I did he had a reduced pain of 60%, but only lasted about 12 months. Then the pain came back, and this time the pain was more L4, 5, and because he also travels a lot in a lot of long flights, So the second MRI was about, this is the MRI again, so you can see that indenting L5 disc, and now he has also L4, L5. And you can see that this is really pushing the spinal cord, right? This is one classical called foraminal stenosis with, herniated disc compressing the exiting nerve root. Okay. So what we did, balloon is a procedure basically, again has to be done under prone position. This is the needle is big. It's a 10 gauge needle, 10 gauge needle. So to get in the caudal space, you must be make sure you give lots of local. I do all my patients under monitored anesthetic sedation. I give them midazolam, fentanyl, and paracoxib injections. never do under GA because you need to be patient awake. Okay, so you get a needle in. First, you give a contrast, and this is a catheter. This catheter is about size 13. So the idea is to go initially. When I give the contrast flow, there was no runoff here, right? There was no runoff on both sides. So what I did, I go in there. So I steer I show you the video. You can steer the catheter, and once I'm in at the foramen exit where the nerve groove coming on, I open up the balloon. You inflate it about 3 to 5 seconds. You inflate, deflate, inflate, deflate. So our whole idea is to open up and move the compressed nerve away from the disc, and you must get the contrast flow like this. So usually we need to. So there you can see that the balloon. This is known as the retrodiscal space. Okay, retrodiscal space. So you get a good contrast flow, both the anterior and posterior. I think in this case you need a both contrast flow because that's where you know the success of the procedure. Okay. So again, you can see that once a balloon, you see the contrast flowing up very well. Then I went up, and you can see contrast flowing on the left side as well. So anyway, this patient has done is very well. His pain is reduced up to 80%. He's happy. He has no more claudication pain. And based on procedures which is done by Professor Shin, he's done almost 10,000 cases. This is an excellent outcome. You can pain release anywhere between 1 year to 5 years, even longer. Second case, a 50-year-old banker. He had unfortunately, this was one of the cases. He had a classical failed back surgery, lumbar spinal fusion 4 level for a very minimal disc bulge. So he's now my long-term patient. I've done 3 procedures over the last 10 years. Each time it lasts about 2 to 3 years. So I usually do I do another procedure known as RC, pulse RF epidurolysis, using a Boston Scientific catheter. So, so as he grows older, the duration of pain relief coming shorter. This is less than 2 years, he started having pain. So that was the MRI. Okay, so you can see the fusion bones, and he has the problem he has at the level of fusion, he has a slip disc, the disc bulging at about L2. Okay, and you can see the fusion level there. So this was the first procedure I did. This is known as a Rex procedure. I mean, Rex epidurolysis I did. Okay, we use hyaluronidase, right? And you can see the catheters had a bypass where the fusion is. So got a good contrast flow there. That gave him but good relief. But eventually the pain came back. So that's you can see a lot of epidural fibrosis in this area. Okay, there was a recent MRI. So again, this time I did the balloon. So I need a big needle in. So get the contrast flow. And this is because of lots of addition. So I use hyaluronidase to break. And I also use a lot of normal saline to flush. You can use about 10 to 15 mils of pure normal saline. I don't use hypertonic. All right. So the idea is to navigate the catheter. You can see the navigate catheter because of lots of addition here. So you must have lots of good skill to navigate the catheter, bypass the addition. And the real important thing is not to force, because force you can cause dural puncture. So you see, I got a very nice contrast flow. This is what you want, anterior epidural space contrast flow. Excellent. And then I managed to navigate the balloon. I went to this level and I went higher. So as I go down, the balloon you use the balloon, you inflate it and bring it down. So the whole thing is like dilating. It's like it's a very simple concept of like a clock drain. So the whole idea, you use the balloon to keep it, you bring down, so it dilates the entire epidural space. Okay. So what happens? The nerve root becomes free, and it's a very good procedure. I think it's going to be one of the key procedures in the future. And now the new procedure is coming up with a radio frequency built in, so you can do the RF together. Okay. So okay, this is the next picture. Sorry, my next picture. Okay. All right. So you can see I managed to get the needle right. That's a balloon right up there. That's where all the problems are managed. So it's not easy to get from it. So you don't need to navigate a lot. Once I get there, I open up the space at L2 level, and you can see a very nice contrast runoff. Okay. So basically, you must understand in lumbar spine it's a bit different because the herniation protein into foramen in the low back will typically does not lead to radicular symptom unless you have the lateral recess is compressed. Remember your nerve comes out here, and this is where your slip disc, this is where your nerve gets compressed. So this is what you call the retrodiscal area. So you must be very, very clear, right? And if there are clinical signs of herniation in positive SLR or Lasix test, then you know this patient will benefit from this procedure. So this is show you the needle, the 10 gauge needle. I have a video, hopefully can play. Okay, I think you have time, right? So there's no sound. I'll just try to explain it. So this is how the catheter looks like. It's a catheter, white color catheter. You can see that there is 2 steerable devices. Okay, there are 2 ports. Okay, There's actually there's another new bigger one where you can even put epidoscope. So this is a guide wire. That's a 10 gauge needle. Okay, we call it a cerebral balloon catheter. Okay. So this is where you done. All right. Okay. Well, I will just 3 more minutes. I'm done. Okay. So you can steer left and right. So the idea is to steer at the tip. Okay. So what you do? This is for the balloon. This is for the guide wire, and this is for the balloon. Okay. You can use the guide wire. All right. And this is a balloon. The balloon, you can push it away. So the idea is when you inflate, it's about you need to inflate about 1 to 2 cc. You see the balloon. It's not the elastic balloon. Okay, it goes in. The balloon is designed in such a way it's not too tight. Does not damage the structures. But the key thing is you cannot make it inflated more than 3 to 5 seconds. Okay, so this is what we have. Okay, this is what is an elastic balloon. This is an inelastic balloon. Okay, doesn't dilate too much. So this is a pathophysiology. Just imagine patient having back pain. Okay, so you have a spinal cord of nerve root there, and you have a inflammation of the dorsal ganglion of the nerve root there, and that causes adhesions, scarring. Okay, so that irritates the nerve and causes radicular pain. Okay, or radiculopathy when you get weakness. So traditional steroid can cover release that, but you cannot go to the site to get the drug really into the nerve root. So you perform at a sacral hiatus. Sorry. All right. So you get the needle in. It's a 10 gauge needle, goes inside, and you must do an epidurogram to make sure you have the right flow. And eventually, after epidurogram, I'll give my local and a steroid together because to get some of stipulated release, because this catheter is painful, right? It is definitely painful. So you guide along. You try to get into anteriepidural space, and you can curl it, you can tweak it whichever side you want. You can clear it. Once you're there, you apply the balloon, you remove the adhesion, and you deposit the drug. So the drug exactly lands on where the pathology is there. So you get that. So that's where the balloon is. Huh? So exactly like my figure there, the balloon. Yeah. So they've done studies, and they've done MRI, fMRIs, and they show that increase in the blood flow. The entire blood vessels there is increased. Okay. All right. Okay, so this is, I do it under full aseptic technique, and I do it in a cath lab, so I make sure. And then all my patients get antibiotic. This is how the catheter looks. You got to prime it before you insert it. Okay, so this is all the current evidence, and this is paper published by professors. So they've shown that it's got a good evidence to last up to 12 months and above. All right. Okay, so conclusion: balloonplasty is safe, minimally invasive, effective for lumbar spinal stenosis and failed back surgery. Growing clinical evidence, and obviously require a lot of skill, and this is advanced procedure. Okay. All right. Thank you so much. I'm more than happy to take questions.
Thank you, sir. So hall may be empty, but your lecture is full of facts. So please stay back for the questions at the end of all the speakers finished. Now I'll invite the Karthik Babu Natarajan. He doesn't require any introduction, so he's going to enlighten with us regeneration therapy in disc degeneration. It is in his own area. Welcome, Karthi.
Thank you, sir. Thank you. Good morning. So today my topic is on regeneration therapy for disc degeneration. Now, since both my topics were on regeneration, some of my slides may overlap, right? Now, I am from Chennai, so this is my clinic, so these are my folks there. And today we are going to be talking about disc degeneration. Right, so in principle, disc degeneration is very difficult to treat, right? So as pain physicians, about 60 to 70% of patients who walk into our pain clinics are back pain patients. So we do see a fair share of patients who come in with predominantly disc degeneration. Sometimes they come in with disc herniation as well when they come in with radicular pain. So predominantly somebody comes in with only disc degeneration is going to be having axial back pain. So these patients, male, female, young, old, both you're going to see. More likely you're going to see a younger patient who comes in with disc degeneration, and these guys are going to have axial back pain. Right? So what goes wrong in disc degeneration? So the primary primary thing seems to be there is an annular tear. Now, this annular tear seems to kick off what is called as a degeneration cascade. So a lot of changes happen during the degeneration cascade. One, there are a set of inflammatory reactions. There are inflammatory mediators, TNF alpha, all those thingies that come in. So essentially, for us to know, what all happens is, after the annular tear, one, the nucleus tends to lose water, so there is dehydration of the nucleus pulposus. Second, new nerves, new blood vessels are formed. Sometimes as a result of this inflammation, the inflammatory changes may produce gases inside the disc, and these gases, even though microscopic, may accumulate in one part of the disc. So some of these gases may include things like sulfur, and this gas may look like a white specule in a predominantly black MRI, black disc in an MRI. So a typical disc degeneration patient, if you take a T2 weighted MRI, you're going to see a black disc with a white spot. This white spot is something which we call as a high intensity zone or a His sign. So your diagnosis of disc degeneration is going to be a T2 weighted MRI, which may show a black disc with a His sign, high intensity zone. So coming back to what's going wrong, so annular tear, degeneration, new blood vessels are formed, new nerves are formed. There is a white spot, which is your high intensity zone. On top of it, this inflammation may affect the end plates above and below. So these changes typically we call as modic changes, modic type 1, type 2, type 3 changes. So this is classical disc degeneration. So predominantly a young patient, 20 to 40 years. The history could be somebody who lifted something heavy, he had a jump, he had a long travel, so jerky travels, lifting something heavy, or some sports activity. So these patients come with back pain, and if conservative treatment fails in this, you're going to get your MRI, you're going to see a black disc, and these are the typical changes that you're going to see. Now, in principle, like Dr. Das keeps mentioning, whenever somebody says only back pain, it's more tricky to treat. Whenever somebody says radicular pain, so whenever somebody says my back pain is going down the leg or your neck pain is going down the hand, so radicular pain is relatively easier to treat for a pain physician than only axial spine pain. So in principle, back pain is more difficult to treat than back and leg pain. So this is what you're going to see. Now, typically a normal disc is completely avascular and very minimally innervated. When I say normal, uninjured disc. Now, the moment there is an injury, these patients tend to have a sensitive disc, and this causes a lot of problems. Now, as a physician, what are you worried about? You're worried about some of these maneuvers that can aggravate this condition. So typically in disc degeneration, whenever the intradiscal pressure increases, you're going to have more back pain. So compared to a patient who's supine, when they stand up, the pressure increases. When they sit down, it increases further. Bending forward, lifting something heavy increases the pressure. So you may find a patient who comes into your clinic and you are saying the patient to sit down before you start, and the patient says, no sir, I'm happy standing. So once in a while, when your patient is saying they prefer to stand compared to sit, some of the things that should ring a bell are, one is disc degeneration, sometimes coccydynia and sacroiliitis can make them hesitate to sit. And once in a while, your attender is going to tell you a history where they say this patient is actually standing and having lunch or dinner. So whenever somebody says they are standing and eating, that should give you a clue, because typically in this group of patients, standing, the intradiscal pressure is less compared to sitting. Right, so this is the typical patient, and how are you going to diagnose them? You may diagnose them for conservative treatment with just an X-ray, but if your MRI is going to be there, you're going to confirm a black disc with a high intensity zone. Now, your pattern of pain is going to be predominantly axial. So this axial back pain is going to worsen when this patient bends forward and lift weight. Now, typically only disc degeneration, there's no reason for them to have any radiating pain pattern. I've actually borrowed one or two slides from Dr. Das's old presentation. So this is something that we were discussing long, long ago. So I've borrowed a couple of slides from this presentation, so some of his students may recall this. So typically, as time goes, you're going to see the nucleus pulposus being gradually more and more dehydrated. And as the nucleus pulposus becomes more and more dehydrated, your MRI is going to become gradually more black. Now, this is significant only in a younger group of patients. This is not very significant. So you may find somebody with a disc like this when they are 70 or 80. But if you see this in a younger patient, this becomes significant, right? So typical disc degeneration, black disc with a high intensity zone. So this is your clinching diagnosis for disc degeneration. So I told you I borrowed some slides from Dr. Das. So if you're going to do a confirmatory test, you have an option of doing a discogram. Now, this discogram used to be a very common test when earlier, so 2005 to 2015, we used to do a lot of discograms. I used to get referrals from surgeons because there would be a case where 4 discs are degenerated. The surgeon is going to fuse 2 or 3. So I'd give you a call and say, boss, this is the situation. Do a discogram and tell me which are most affected so I can fuse them. So you may get a call like that. So we used to do what is called as a provocative discogram. So this is used to be a very popular test. Now at this point of time, it became a little controversial because for doing provocative discogram, you have to do a normal control. So in normal control, you put your needle, and that itself can cause disc degeneration. So at this point of time, we don't do too much provocative discograms. We will touch the disc for a discogram only when we are 100% sure that we are going to do some procedure. So in my practice, I do discograms only if I'm planning, let's say, prior to an endoscopic disc procedure. So if I'm 100% sure that I'm going to do a endoscopic disc procedure, I may do a discogram prior. Routinely, I don't do discograms, right? So based on the pressure, you can find out which disc is degenerated, and you have mechanically sensitive, chemically sensitive, so on and so forth. And also post-discogram, if you do CT, so post-discogram CT you get your Dallas and modified Dallas discogram. So you not only confirm disc degeneration, you also know where the annular tear is. So as a young pain physician, you're worried about 2 pathologies in the disc. So one is disc degeneration, disc herniation. So if you're going to be seeing predominantly about what's there on the left side, so these patients do not have nerve pain, so there is no radiculopathy. This pain is non-dermatomal, predominantly back pain compared to the leg pain and a herniated disc. And these patients, pain is axial, the SLR is negative, they don't have sensory motor deficits, and you can do a provocative discogram, and you will see a His sign in the MRI. So this is your typical patient. So you're going to treat these patients conservatively, lifestyle changes, basic medicines, back exercises, see how they come along. So in principle, as a pain physician, or any physician for that matter, whenever you don't have anything solid to offer in terms of treatment, you should not jump and do intervention. So you treat them conservatively because there are no very promising procedures that are there for disc degeneration. So treat conservatively as much as possible. Lifestyle changes, back strengthening, this is okay. And then you have an option of going for some type of an epidural injection or a caudal or a transforaminal or an interlaminar. Now, the caudal, transforaminals and interlaminals do give short-term relief. If they don't come around with this, you have an option of going for the next level of treatment. Now, broadly, for degenerative disc, you can divide this group into regenerative therapy and denervative therapy. So the regenerative therapy, which is my topic, is intradiscal PRP, intradiscal BMAC. Denervative therapy, you're going to do your IDID, you do your intradiscal RF or your biaculoplasty. Now at this point of time, which to do in which patient, not clear, and which is effective, not very conclusive. So you have growing evidence for both groups, probably considering the RF has been there for longer period of time, we have slightly more evidence towards the denervative than the regenerative group at this point of time. So if you realize I did, which is intradiscal electrothermography, has been there for almost 10 years now, and it's almost out of the way. So I did at its peak had a relief of about 1 year. So even these procedures which are denervative basically burn the new nerves that are formed in the posterior part of the annulus, and it's possible that these nerves can grow back and the pain may come back in this group of patients. So at this point of time, we don't have any perfect solution for disc degeneration. So that's why focus should be on conservative, focus should be on prevention, right? Anyway, so my talk today is going to focus on regenerative part of disc degeneration. So what do I do in my practice? I do intradiscal PRP, I do intradiscal BMAC. I do these procedures reasonably routinely. Probably my success rate is hovering somewhere around 50 to 60% in this group of patients. So how we do this? So this is my BMAC routine. So considering this is bad, so usually what I do is I take BMAC in a 35 or 40 ml kit. So the concentrated part of the BMAC, which is about 4 ml, so 40 ml or 35 ml of blood will give, 35 ml of bone marrow would give me about 3.5 ml of BMAC. I would inject that BMAC into the intradiscal or surrounding the disc. The remaining part, which is what we call as the platelet-poor plasma, that still contains stem cells. I would take that and I would inject that in the caudal epidural route. So I would do intradiscal BMAC, and then I would do a caudal epidural with the platelet-poor plasma. So for disc degenerations, disc herniations, I do BMAC. We can also do transforaminal caudal, cervical epidural also. You can do in lumbar facets, sacroiliac joints, coccydynia, once in a while in failed back surgery as well. So the protocol is fairly consistent. The BMAC technique is fairly consistent. So I told you I usually like taking BMAC from the PSIS. So this is my usual technique. So this is a picture of me taking from the anterior superior iliac spine. So patient is prone. But if you're going to be doing for the disc, it doesn't make sense to make the patient supine and prone. So you might as well make the patient prone and then take it from the PSIS. I told you the previous lecture, the advantage with PSIS is you can do fluoroscope guidance, so you are very accurate. So this is the technique of choice, 11 gauge jump shady needle into the PSIS, vacuolock syringe, depending on which kit you are using, 35 to 40 ml of BMAC, do a filtration, and then do a centrifuge. So the concentrated BMAC intradiscal, the remaining, I do it caudally. So this is, patient is prone, so right side, PSIS, so the uppermost part of the ilium, just beside the sacroiliac joint. So that's my point of entry. So this is the way I position the C-arm. That's my jump shady needle, which has got multiple orifices. So that's my entry point. Once I get inside, I don't use a mallet. It's pretty much by hand. One good advantage with PSIS is there is a soft spot in the posterior superior iliac spine. So relatively, it's easier to take from the PSIS than ASIS because it's hard cortex in the ASIS. So that's PSIS. Okay, so that's the vacuolock syringe. I'll be requiring 2 minutes, please. And that's the vacuolock syringe aspirating from the PSIS. So that's more aspiration of bone marrow. And so if you're going to be using a PRP-based technique, it's possible that may require repeat shots. And repeat shots in the intradiscal is not ideal. You know there is always, disc is considered a reasonably sacred place. You don't want to be causing any infection intradiscally. So you all know about the double needle technique, I presume, and cover with antibiotics. So this is aspiration of BMAC. So BMAC is better than PRP because you don't want to be repeating PRP in the intradiscal space. So once you take the BMAC, you filter it. So this is normal nano filtering of the BMAC. Those of you who saw my lecture yesterday must have seen this. And once this is done, we go ahead and do a normal centrifuge. You know this is the protocol. Use whichever system you're using commercially. And once this is done, you get pretty much like PRP. So I use a triple chamber kit. I use ACDA as the anticoagulant. And then first spin is a soft spin, so we do it at 3,500 RPM for about 6 to 8 minutes. Once that is done, we lock the first chamber with the RBC out, and then we flip it around and do a second spin. And the second spin, again, 3,000 to 3,500 RPM, and we get roughly about, for 35 ml of BMAC, about 3.5 to 4 ml of concentrated BMAC, so BMAC concentrates. So once you have this, your injection is going to be fairly straightforward. So you know which level is involved, and then go ahead and do an intradiscal injection. Now, sometimes it may be easy to do an injection into the disc. Sometimes it may not be so easy. Depends on, at that point of time, whether there is an annular tear or not. So if you are not able to inject intradiscally, you can inject around the disc in the posterior epidural space. Now, typically, somebody with an annular tear, you may be able to inject into the disc. If the annular tear is partially healed, you may not be able to inject, so inject around the disc. So that's the solution. And once I do this, the remaining platelet-poor plasma, or whatever is remaining in the BMAC, I inject caudally. Okay? Once in a while, I may also do, this is more in a patient who's herniated, I may do an endoscopic discectomy. After I do the endoscopic discectomy, and I've made the place reasonably dry in terms of saline and irrigating fluid, after the endoscopic discectomy, put your long needle through the trocar, get into the disc, and inject, after endoscopic discectomy, BMAC intradiscally. So this is also possible. So, but this is not for only a disc degeneration. This is for degeneration plus herniation. So on top of it, once in a while, you may also do sacroiliac joint or facet joint intra-articular PRP or BMAC. Sometimes you will have multiple procedures. So on top of this, you may also do intra-articular PRP in the facets, intra-articular PRP in the sacroiliac joints as well. So this is pretty much what I do in my practice. So at this point of time, my success rate, I told you, is somewhere around 50 to 60%. It's going to take a little bit more time to know if denervative or regenerative is better. So that's my team in Synapse. So thank you very much.
Thank you, sir, for your enlightening talk. You truly gave us points to think and ponder. So moving on to the next session. Minimally invasive spine endoscopic pain procedures are revolutionizing pain management. With this in keeping in sight, I would like to welcome our next speaker, Dr. Pankaj Surange, sir, who needs no introduction and has trained so many pain physicians all around the globe. So please come and share your valuable insights.
So poster presenters are supposed to gather at 10:45 a.m. at the hall Nova 1. Any poster presenters? Please note.
Okay, guys, so here's my presentation. Okay, so this is basically a new terminology what we have introduced, and we have published it also in our Indian Journal of Pain. That is MISAP procedure. So basically the idea is that endoscopic procedures, everybody is claiming that it is their, right, they have a right on this procedure. And we also, as a pain physicians who started long back, right, so we also want to claim this procedure as our pain procedure. So that's why we introduced this MISAP as our terminology what we use, and we have already published it. And I would request all of you whosoever performs this procedure, we must promote this as a pain procedure. So that is the idea, so you must see that. Okay, so these are the kind of cases what we normally get in our day-to-day clinical practice. If HIZ is there, big extrusion is there, big extrusion, migrated disc, down migrated, up migrated, huge bulge. So these are kind of cases for what we get clinically. What is the solution for that? We have to look for the, we are sitting in now to 2025. We are talking about pain medicine as a super specialty. We already have DM, we already have PDCG and other DNB also. So we are talking about the super specialty as a pain medicine as a super specialty. So we have to also progress. We have also had to give definitive solutions to our patients. So when they come to us as a super specialist, we have to get the definitive solutions. So what is there for all these conditions? Obviously, our transformal and other procedures are not going to work in such conditions. So we should not go for that, let me try this. Trial is not a patient's, they come to us for the solution. So we cannot just say, okay, let me try transfemoral. So we have to give the definitive solutions. So that is what we also try to do with this endoscopy procedures. So we have moved from conservative to supportive treatments to definitive interventions now. Initially we were like very conservative. Then we were like some facet is there, you kindly perform the facet, epidural kar do, right? These kind of things were there for the many years. But now we are moved to the stage where we have a definitive interventions. So when we talk about the back pain with radiation, without radiation, we are talking about disc hernia pain, facetal, sacroiliac, myofascial pain syndrome. We have multiple procedures for that. We have bacoplasty, we have PRP, BMAC, just Karthik mentioned about that. We have ozoneclasis for the contained herniation, for the non-hydrated disc, small bulges, we can do percutaneous disc decompression. Transfer neuroplasties, yes, patient is having radicular pains without much herniation, without much compression, we can go for the transfer neuroplasties. But what happens to these? And majority of the patient who comes to us nowadays, they are coming with these kind of MRIs. Big extrusions, sequestrations, and migrations. So what is that? The solution is your MISAP. So this was what we published in our Indian Journal of Pain also, the rising importance of minimally invasive spine endoscopic pain procedures in modern pain practice. So we all must adopt this technology and we must include this in our clinical practice. Before we move on to this MISAP procedures, it is very, very important that it is not that easy also. It is a long learning curve. We must know the anatomy very, very well. We are breaching multiple tissues. We are reaching our target areas. We are playing around the disc. We are playing around the nerves, around the dura, vessels. There are so many important structures. Peritoneal, retroperitoneal structures are there. So there are so many structures. We must know the anatomy very, very well before getting into the spine endoscopic pain procedures. We must understand the challenge that every level is not the same level. So we must learn how to negotiate at each level. What are challenges at each level? It's not same. L1, L2 will have some different challenges. L2, L3 will have different. L5, S1 will have some different challenges. So everywhere it is like angulation, everything will change. Also with the position of the patient, everything will change. So we must understand the anatomy well. We must understand the MRIs very well. Because that will also change with our position. That will also, everything will change with the, where is the fragment lying? Our target is a fragment. Here we are not just going inside a disc and we are putting something inside. Remember, we are targeting the fragment. So when you target a fragment, we must understand where is the fragment lying. So accordingly, we have to select our procedure. So there is no single thumb rule for the, like L4, L5, I'll go for 10 centimeter, L5, S1, I'll go 12 centimeter. There is no such rule. This is mentioned in the books. It is taught in most of the workshops, but that is actually wrong. Every level will have different challenges. The position will change. If you have reduced the lordosis, the position will change. Your centimeter from the midline will change. Right? What is like 10 centimeter is a paramedian approach, maybe it is far lateral approach if you reduce the lordosis. So it makes a lot of difference over there. We must understand this anatomy for the fluoroscopic anatomy also very well, because for interlaminar especially very, very important, because when we do the interlaminar, mostly we do for the L4, L5 and L5 S1. L2, L3, L3, L4 is very difficult to perform through interlaminar approach. For that, transfemoral approach is really very good. We can even target the central herniations in the transfemoral approach. For L4, L5, L5 S1, now my practice is more towards the interlaminar. Whatever it is central herniation, paracentral, or even for the foraminal herniations, we are doing mostly interlaminar approaches. But we must understand this anatomy also, fluoroscopic anatomy. There are multiple important structures, vessels are there, which we may not encounter with our other interventional procedures. But with endoscopic procedures, we must understand there are multiple arteries, multiple vessels, multiple epidural veins are there. Veins is okay, we can coagulate them. Artery is an issue. Fortunately, we don't encounter these arteries. But at times, we may have these aberrant vessels over there, so which we may encounter during our endoscopic procedures. Reading the MRI, understanding the MRI is the most important, another important part. So clinical anatomy, then fluoroscopic anatomy, then your endoscopic anatomy, and your MRI anatomy. So all these are very, very important when you try to go for when you start going for the endoscopic procedures. So here you can see that it is not just the axial images or the sagittal images. Here we have an importance of the MR coronal sections also. So we must know how to read the coronal sections, how to read the sagittal sections and the axial sections. Here we can see not only that the fragment, where the fragment is lying, but that also gives us a clue what is my safe entry point. Because depending on the fragment, where it is pushing your dura, where it is pushing your nerve root, all these we can see with the coronal sections. At times you may not have any coronal sections with you. A lot of times when we get MRIs, we have only axial sections and the sagittal sections. But on sagittal sections also we can see where it is exactly pushing the dura or the nerve roots. So we must understand the relation of these fragment with our dura, with our nerve roots. So which is the safer entry point to enter. Also, depending on the site of the herniation, whether it is central herniation, paracentral herniation, foramen herniation, or it is extraforamen herniation. Look at this. Okay, so we had to change our angulation. So from centimeter from the midline, that is what we see that 8 centimeter, 10 centimeter, 15, 12 centimeter, 14 centimeter, whatever it is, it will depend on the site of the herniation. It is not fixed. Let's say this is L4, L5. This may be for central herniation, you may have to go around 14 centimeter from the midline. But if it is a paracentral herniation, you may go from the 10 centimeter from the midline. But if it is a extraforamen herniation, you may be going just 8 centimeter from the midline. Maybe 6 centimeter also. So it will change with the site of the herniation also. So that side is important to understand your anatomy also well, or the MRI anatomy of the disease also. Invest in your instruments. This is very, very important. Buy your instruments. This is what yesterday in the panel discussion I mentioned about this, right? In my initial 2 cases, second case and 6th case, we had an infection. Only reason was I was borrowing these instruments from outside. I stopped doing that. Okay, I invested in my instruments. Don't borrow the instruments. Okay, bring your own instrument, invest in that. So this is very important. Understand these all have a lot of significance. They may look horrible to you, right? What is this? Kerosene punches. Why we should use kerosene punches? But once you start using these punches, you start loving them. It's so beautiful. They make your life so easy. Okay? So this is just a video so that you can understand what we are talking about, what kind of cases we can do. Now look at this. There's a big herniation over here. Right? There's a big herniation compromising with the exiting root and the traversing root. It's completely obliterating the paracentral, the lateral recess and the foramen. So such kind of herniation, obviously we cannot do anything with the transferal approach. So in this case, we did a transferal. You can see here, that's the approach. This is how we go inside. We anesthetize the entire area with a 20 gauge needle, followed by our something else. So after putting the dilator, we put a working channel over there. And this is a grasper. And look at this, through the transformer approach, we have exactly landed over the fragment. So this is a big fragment, which we are holding this with the grasper, and we can remove it. This is all done under local anesthesia. We don't give any GA or any sedation to the patient. At times, just midazolam or some fentanyl is required. But most of the cases, we just do under local anesthesia. So such big fragments, obviously, they need decompression. Look at this fragment. So these fragments we cannot reduce with the other techniques, right? We have to remove them. Another, I'll just show you this. This is again, you can see here, this is up migrated disc, big, huge herniation, up migration. Okay, in this case, we selected our interlaminar approach. We go to the interlaminar window. Same technique. We can go with this, with the retractor. Now you can see there's a big herniation over here. We don't have to do a lot of bone cutting here. It's not required. If you know your anatomy well, if you know where is the fragment lying, you can exactly land over there without cutting much bone. So this is how we are removing this fragment under the dura. This was under the dura, migrated upwards. So we had directed our working channel towards the cranial side. Once we identify them, and then we can remove them easily. Look at the size of the fragment. And what we have done, we have just done a small hole in the flavum. That's it. We have just removed small portion of flavum on one side. Okay, so with these kind of definitive interventions, more invasive interventions, definitely we may land up into complications. Complications are possible in these cases, but we must, that is why it is important to learn these techniques very well. It is not just workshop, attending the workshop and start getting into this. This is what mistake I did long back in 2014. But after that, I went for the long-term fellowship and then I started doing again. So complications may happen. So you must understand this complication. You must treat this complication. Don't leave your patient after any complications. Whenever there is a complication, write down everything. Mention everything. Whatever has happened, mention everything. Investigate and try to treat the patient. Involve other specialists if it is required. If surgical intervention is required, you must involve other specialists. Because neglecting a case will go into the negligence. It will not be considered a complication then. So we must understand that. So there is no shortcut in learning. Just workshops are not enough. And take help of the senior pain physician. Now you have this, you have this facility available. That you have many pain physicians who are doing these endoscopic pain procedures. So involve them in your initial few cases, maybe 20, 30 cases. You must involve them and call them and do it under their supervision. So that is the best way of learning these spine endoscopic pain procedures. So I'll just take 2-3 minutes more. We just did the study. So where we collected our 2 years data, we did around 268 cases in 2 years, 23 and 24. Out of that, we have 240 cases follow-up. So Dr. Gopi is my fellow who has done a retrospective study for 2 years, and he's going to present that study where we have included 240 spine endoscopic pain procedures. Gopi.
I thank Dr. Pankaj Surangi, sir, respected chairperson, dear pain warriors. I'm here to talk about a study which we did in IPC Delhi Center, when we looked at about 240 patients who underwent interventional spine pain procedures. And we found out, this is the demographic details as well as the age group of the patients who underwent surgery. You see the distribution curve is skewed to the left, indicating that the majority of our patients were below 50 years of age. So which indicate the patients with radicular pain and disc herniations are mostly the younger population. And we looked at the level of herniations. As you see here, the predominant lesions were at L5 and S1, as well as L4 and L5. So these were the discs which were herniated quite often. And we looked at the MRI finding, and we found the the common zones of herniation. As you see here, the lateral recess was found to be the major zone affecting, with disc herniations, followed by the central herniations. And we also found that most of our patients had more of left-sided herniation. And this is the pain score. As you see here, the baseline score was almost close to 9, and which dropped down to almost 2 by day 1. And then it's slightly went up and then dropped almost to 2 by 3 months. And this indicates the type of approach. So as you see here, the interlaminar approach was mostly done for the L5S1, wherein if you look at the L4, L5 region, the both interlaminar and transforaminal approach was preferred. And this shows the perioperative complications. We noticed about 4 patients had raised intracranial pressure, and 1 patient had the epidural bleed, and then we noticed 1 patient having jaw tear. And this is the postoperative complications. The recurrence of disc herniation was noted in about 11 patients, and the failback syndrome was noticed in 4 patients, and discitis was noticed in 2 patients. And post-endoscopic pain procedure, there were 9 cases who underwent microdiscectomy. So this is to show that the endoscopic pain discectomy is a definitive treatment, and the outcome is quite promising. And I think as young pain physicians, we should be daring to do such discectomy procedures. I thank Dr. Das sir and Dr. Pankaj Surangi sir for giving me this platform to share the data. Thank you.
Thank you so much.
I think you completed. Thank you so much.
Yes, sir.
Question answers will be in the last. Now I will invite the next speaker who will be talking about CT guided overview of CT guided interventions by Dr. Kasinath Bangar. So Dr. Kasinath, please.
Good morning, everyone. It has been always a nostalgic feeling at Kolkata and Daradia. I thank Das sir, Smriti, Sushma, and whole organizing team. As we are going to more and more, we are evolving. We should be evolving our gadgets, our instruments, whatever we are using, and we should be using what is the best for the patient, the best instrument, best technique. And for few of the challenging cases, what I found with my experience is the CT-guided interventions are the best. So the topic will run like this, some introductions, some different MIPSs perform, advantages, disadvantage, a small video, and take-home message. All these photos, a small video is of our patients. So in selected cases, definitely it is safe, very accurate. In CT-guided performance or blocks or MIPSs, we visualize actual structures. What does it mean is, in fluoroscope, we visualize the bone and we assume the structure is near to that bone, right? But in CT, we visualize the actual structure, where and what we want to perform. For example, we anticipate that there is a nerve, we anticipate that there is a vessel, and then we put a needle in a fluoroscope. Of course, we confirm with the contrast. And as I said, few procedures are always better to be performed under CT guidance. Almost all the procedures which can be performed by the fluoroscope can be performed under CT guidance. Again, the views or the approaches, could be, for example, the approach I wrote over here is for ganglion import, we can have a lateral approach. What does it mean? In most of the malignancy patient, if there is a post-radiation or if there is some issue posteriorly, we can go little laterally right from the buttocks and go directly to the ganglion import. So most of the procedures can be performed, but The procedure, what we must perform is technically difficult, challenging procedures, and where the chances of complications are more. So few steps like pre-procedure preparation, positioning are same as other procedures. Scanogram, that means you scan whole the patient and you decide your target area. For example, if your target area is celiac or splanchnic or T2, T3, you take a detailed scan of that area, right? You mark the area, mark your entry point, take all our aseptic precautions, put the needle, take repeated scans, confirm the tip, and then ship the patient to the recovery room. Pre-procedure preparation is nearly same for all. One thing is there, you please make sure that there are adequate resuscitation material available in the CT scan, because this is one thing which comes in a little bit of disadvantage. Position, monitoring same. So this is a scanogram. So initially what we do is you take the scan of whole of the body, right? And then after that, wherever you want to enter, right? If it is splanchnic, you ask the technician to take from T11 to T12, or if you want to celiac, then ask him to take from somewhere around T12 to L2 and find not the vertebral level, but your celiac axis. If it is T2, T3, ask him to scan that much area. Once you scan and you decide that, once you scan and you decide that, okay, this is celiac axis, I want to put in my needle over here, you can mark entry point from here, right? Now, once you mark entry point from here, you see the distance of your marking, you mark it into the console and you see the distance from either midline or if you have put some marker, and just mark that area, okay? You mark it onto the patients. Once you mark, advance the needle. The disadvantage is you have to go inside the CT room suit and come outside the console 1 or 2 times. And these are the few MIPSs we perform. See if it is in splanchnic, you go inside gradually. Once you go inside, you put your contrast, and once you're happy with your contrast, you're done. Every structure is nicely seen, okay? This is probably a tumor, small part of kidney, you can see the muscles, the ribs, and everything is seen. Okay, this was one of the interesting case. This was an old case, we did another recent one, but as the presentation was ready. So there was a big facet cyst. See this image, this is a cyst and these are the nerve roots. This hole is cyst, and that was putting a pressure onto the nerves. This hole is cyst. So we tried to aspirate. The patient was high risk for surgery, so we thought let's give a trial. So this is cyst, if you can see. So what we did is we enter under the CT's guidance into the facet joint, and then we tried to aspirate. But after aspiration, we couldn't aspirate a lot of stuff. So we decided to go from the posteriorly and then enter into the cyst. So now, entering from the posteriorly and going into the cyst was a little challenge. That there is a chance that we can puncture the dura. So what we do is we put a small amount of contrast. Okay, note please one thing: if it is a facet cyst, please do not put a lot of contrast, or please do not put a local and steroid inside the cyst. You are going to inflate it. Okay. So we put a contrast, and you can see that cyst is nicely delineated. Once the cyst is delineated, we know where should be our needle. We enter into the needle, we enter into the cyst and did the multiple pricks. Small amount of fluid was removed, and after we had almost follow-up of 3 years, and the patient right now is pain-free, not due to the cyst. Few procedures which we should perform under the CT guidance, and that what I feel is: one is T2, T3, splanchnic, anatomically challenging cases. See, you clearly can see the lungs. You clearly can see the lungs, and what happens is, in most of the patient, if the patient is very thin, the lungs are very much adherent to the vertebral body, okay? Not here, but in most of the cases. And what happens is, once In fluoroscope, you don't know, you can see the pleural line, but whether you don't know whether it's attached to the anterior part of the vertebral body, middle part of the vertebral body, or little on the posterior side. So, right? So, this gives a clear idea that you are not, your needle is not going into the pleura, and it gives a clear-cut idea where you should be entering, right? Celiac plexus, this is an anterior approach. Patient was not able to lie down prone, so splanchnic plexus, as we know, splanchnic RF is preferred in most of the cases. So let's see. Now, boil preparation is must for all the patients where we use an anterior approach. You do the scanogram, and then you see the celiac axis. Celiac axis was little bit 1 centimeter away from this area, and it was full of the metastatic tissue, metastatic lymph node there, so we couldn't go there. That's why I selected this place nearly half centimeter away. You go from anteriorly, you can easily see what structures you are piercing. Now I'll tell you one thing, this is stomach shadow. So we have negotiated the stomach shadow because we have gone a little bit inferior to the stomach. Even if we encountered, that was not an issue. And then we entered, seen the celiac very nicely, and we put the contrast. Contrast is very nicely spread. And here every single structure is, nicely seen. Now, imagine at this level, if we had to go from the posterior side, a lot of structure we do encounter. This is a small video of 3 minutes. So how you mark is, once you have decided that this is my entry point, what will happen is on the CT scan, on the console, you'll see some numbers there, and that is a slice number, right? So, you'll see the slice number. Now what happens is, that means if you have decided once that your entry point is at this level, onto the console, onto that screen, you will see that there is whatever slice number is. In this case, it was 187.5. Now when you go back into the console, you bring this patient to 187.5, and this will correlate this slice over here. Right? You can see that this is line over here, and this line correlates with 187.5, the one which you have decided into the console. Then you will see the marker, and there onto the screen you can easily see how much distance from the your marker you should be entering. So just that centimeter from here, you mark it somewhere here, and then enter. So we have measured, it was somewhere around 3 centimeter on 187.5. This was marker, then we removed, and then we mark it there. Marking is the most important point. Understand that the good marking is depend not on your anatomical position, but actual your position of your MIPC. For example, for celiac, you go at the level of celiac, not at the vertebral levels. Once you have marked, you do all the aseptic precautions, right? And then you can, this is our fellow who is performing the procedure. So once you have done aseptic precautions, you enter it. The disadvantage is, so once you put the needle under a fluoroscope, you can immediately see where you are, right? Here you have to come out of the CT suit, you have to go into the console, and then you have to check where you are. So now, another thing is, your tip, hold the needle near the, any MIPCs you are performing, hold it, your tip near the needle, because you had a control. How much you will be go inside, it is in your hand. If you, so again we came to the console, and see, my needle is, you can see the needle over here. This was a marking. This is needle going fairly in correct direction. So nextly what I'll do is, I'll just go into the same direction. Always hold the tip over here, not over here. Here you are supposed to hold, but one finger should be here, that That means you had a control how much centimeter you will be going inside. Again, we have, inside the needle inside. You can see the kidneys, okay? We are, this is my target. Needle is fairly inside. I'm going inside. Wonderful. Should go into the same direction, right? Might hit little, to the anterior border of vertebral body, but we are okay with that. Always hold out here. Right? I'm hitting the somewhere anterior 2/3 of vertebral body. Slight negotiation is needed. Right? So you just have to enter it here. She will change the angle. So the disadvantage is you have to go in and out. You have to take 3-4 shots. That becomes a disadvantage, which is not a disadvantage of the fluoroscopy guided procedure. We'll reach there nearly. She'll move a little bit. And I will show you the contrast speed. Okay, this is final, I think. Right? Wonderful. And we'll see this contrast spread. Now again, disadvantage is continuous contrast spread is not possible to see into the CT scan. I will see how to, find that challenge. Wonderful. And then you see, then the drug is given and all that things. So what are the disadvantages to sterilization? Continuous contrast spread is not possible. So intravascular spread is seen if it is big vessel, but very much time we know that you are into the very small vessel and we don't see. So what we prefer is we give a lignocaine with adrenaline, right? And as we give it in anesthesia. Advantages is more accurate. It has a very less complication rate. It is useful in metastatic diseases and early diagnosis of complication is possible. Now, if one of the relative contraindication for the fluoroscopy guided procedure is anatomical variation, and that can be easily negotiated with the CT scan, right? Radiation safety, availability, no real-time entry, and sterilization. These are the few of the disadvantages. Radiation exposure in fluoroscopy-guided procedure is more to the physician. Radiation exposure is more to the physician in fluoroscopy-guided procedures and less in CT-guided procedures to the physician, right? So whenever you find there is a challenging and few cases where I always feel that T2, T3 splanchnic and celiac and usually in malignancies, CT-guided procedure is must. Thank you very much.
Thank you, Kasi. So now may I invite all the speakers on the dais. If you have any questions, we'll take 1 or 2 questions if time permits. Karthik, Pankaj. Gopi sir. Otherwise, we'll close the session with the customary photo sessions. Any questions from audience?
I would like to ask from Dr. Gopi.
You have the privilege.
Do you have some historical background who actually invented this balloon?
Historical background?
Yeah. Who invented this balloon? Conceptualized this balloon?
It's a very, very nice question. I don't know because...
I must tell you then. Yeah. It was in year 2013 and one of our colleague, Dr. Jain, Neeraj Jain, who was talking about this balloon concept with pioneer of the epidurolysis, Mr. Gaber-Rex. And he was literally humiliated. I vouch for my words. He was humiliated with the concept that how one can dare to put pressure on the nerves. And now, after, say, down the 15 years, we are discussing the same thing. So it is something surprising. I think all the people standing there, Dr. Karthik and other people were there, standing and seeing that scene. So see, this is for everyone, that how science changes, and we should not take any situation as a standard or gospel. This might change in the coming time.
That's very true. See, everything started when we started doing gasoline balloon. That balloon came to, so the evolving, our science are evolving. And I think pain physicians, we're getting more and more, the research base is going to come much more. I'm sure much more newer device is going to come. I think it's going to make much more better outcome for the patients. That's
one more question. What is the cost there?
Okay.
And how it is available?
All right, this catheter will cost you about $600 to $700 per piece. I think about 700 plus. All right, that's all the cost only for the catheter. The rest is usually I admit patient one night because of insurance coverage, just to be safe. So because my friend's company has imported it from Korea. It took a long time, took more than a year to register. It comes as a medical device because it's just like any other device. We are trying to see whether we can get it into India. So I'm actually trying to ask my company.
So we have one question from the floor, please, ma'am.
Yes, I want to ask one question from Dr. Karthik Babu. When you took the BMAC from the iliac bone, you have given some additional analgesia because this is very painful? Or?
So the question is how to give anesthesia for bone marrow aspiration. Yeah. So usually what I do is I give a bit of fentanyl, which is about 30 to 40 mics for an average Indian patient. I give good skin and I give good periosteal infiltration. So if you can infiltrate the periosteum, so what is a good idea is, if you're doing the PSIS, patient is prone, first under C-arm, choose your trajectory, right? Yes. So you, just like any other nerve root injection or something, so use skin infiltration, put a normal spinal needle, 22 or 23, hit the iliac crest, infiltrate the periosteum. So once you have infiltrated the periosteum, you can do it, you can put your Jamshedi needle. I don't remember giving spinal or GA for any of my BMAC patients.
Yeah. Okay, thank you, sir.
Thank you for that. It's a time to close the sessions. Thank you very much.
Steroid or PRP inside the space, or you directly opt for BMAC, sir, for annular tears and also?
See, there is steroid you cannot put into the disc, so it's going to be a little controversial because you can cause a discitis. Probably considering the chance of discitis, rather not try a diagnostic procedure or a steroid procedure. You know the diagnosis, probably I would straight away go for a BMAC. Normally, the dictum is you do a diagnostic and then you do the actual procedure. But considering there is a risk of infection in intradiscal, it's better to go for the BMAC. And also, all these regenerative products, PRP, BMAC, they have some anti-infective thingy. It's not very clear. So there is some antibacterial action. That's why they work very well for these non-healing ulcers. Okay. So in principle, you will never get infections. Yeah.
So how after the procedure you start rehab?
How after rehab for disc, is it?
Yes, after doing this BMAC procedure.
Usually my review time is 1 week later. After 1 week, you can start your rehab for most conditions. Disc, nothing hard and fast. Yeah, 1 week to 2 weeks.
There is no worsening of pain or something, sir?
It is possible the first week they worsen.
And
because the pressure is going to increase, one, and second is you can't give any NSAIDs or COX-2 inhibitors. Okay. So it's possible after any regenerative procedure, especially the first week they worsen.
And you see clinically effective results, sir, after few months?
Yeah, probably after 2-3 months.
till that time you continue them with the painkillers, sir.
So
we will finish the things. Kazi,
Sorry,
I
sorry.
mean, Karthik is having the 12 o'clock flight only. You can catch up.
Okay, okay. Sorry,
Thank you very
sorry.
much.
Good morning, everyone. I'm Dr. Deepak. I will be taking over this session. So as we are soaking in the tide of knowledge, let's continue it. Sorry for the inconvenience, but we'll not be officially giving a tea break. You can grab your tea and continue the session. So from the diagnostic blocks to neuromodulations, from injections to minimally invasive procedures, pain interventions are shaping the future of relief. So let's get soaked in this knowledge. So our next session is pain interventions and more. Now I would like to invite our esteemed chairpersons for this on the podium for this session. Dr. Rita Paul, ma'am is expert in musculoskeletal ultrasound and interventional pain management. Our second chief guest is Dr. Amna Goswami ma'am, respected clinician known for patient-centered care and clinical excellence in pain medicine. Dr. Piali Mondal Basak, specialist in neuro rehabilitation and interventional pain management, with extensive expertise in spine procedures and regenerative therapies, and also Dr. Mosami Datta, expert in chronic pain and quality of life. I request all the chairpersons to come onto the podium. Dr. Rita Paul ma'am, Dr. Amna Goswami ma'am, Dr. Piali Mondal Basak ma'am, and Dr. Mosami Datta ma'am. I again request our chairpersons, Dr. Rita Paul ma'am, Dr. Amna Goswami ma'am, Dr. Piali Mondal Basak ma'am, and Dr. Mosami Datta ma'am, to please get onto the stadium so that we can start the session. To ease the pain of our curiosity, may I invite Dr. Shalini Chandra to shed light on the topic of PRP in TFCC injury. Currently, she is working at Proactive Clinic Trivandrum and GC member of ISSP Kerala chapter. Her area of interest is MSK ultrasound and fibromyalgia. She has done European diploma in pain medicine also. So may I invite Dr. Shalini Chandra.
This one? I got it. It's here. So good morning. I'll start by thanking the organizing team of ICRAPAIN 2025 for this opportunity, and also special thanks to Dr. Gautam Das sir for his trust in me. So good morning, everyone. I am Dr. Shalina, and I'm from Trivandrum, and I'll be speaking on the use of PRP in TFCC injury. So TFCC injury is a common cause of ulnar side wrist pain. The mechanism of injury could be traumatic or degenerative, and it's mainly due to fall on outstretched hands, violent traction or twisting motion of the wrist or forearm, and repetitive pronation and supination or axial loading activities, which cause degenerative injuries. So what is the TFCC? It's a triangular fibrocartilage complex. So it's a major stabilizer of the distal radio-ulnar and ulnocarpal joints. It is a load-bearing structure, and it is placed between the distal radius and ulna, lunate, and triquetrum. So from the name, it's a complex structure, and it is composed of various components. These are the articular disc, the dorsal and volar radio-ulnar ligament, the meniscal homologue, ulnar collateral ligament, extensor carpi ulnaris tendon subsheath, and the ulnotriquetral and ulno-lunate ligaments. And this is a pictorial representation of the wrist in pronation and in flexion. And you can see this whole area is composed of all these structures. So the main component of the TFCC is the triangular articular disc, also known as the TFCC proper. So it is a major component and it's composed of fiber cartilage with a thicker peripheral region. It originates from the cartilage overlying the distal radius and it inserts into the fovea of the ulnar styloid process. And there is also fibrous tissue connecting the disc and subsheath of ECU tendon. The disc is surrounded by the dorsal and palmar radio-ulnar ligaments and it's a primary stabilizer of distal radio-ulnar joint. These ligaments have superficial and deep limbs attached to the ulnar styloid and the fovea respectively. It's separated by a fibrovascular tissue known as the ligamentum subcruentum, and the other structures are also all placed around this. So in this cross-section of a cadaveric study, you can see this is the TFCC proper. This is the ulnar radius, the lunate triquetrum. This area is the articular disc, this is the meniscal homologue, and this is the pre-styloid recess. And in this, you can see this is the TFCC, the articular disc, and you can see it's surrounded by the radio-ulnar, palmar and volar radio-ulnar ligaments. Here is another section in which you can see all these areas are the cartilage, and you can see this much area is the articular disc. So when you get a patient with usually with ulnar side pain, wrist pain, the physical examination, what do you get? A tenderness over the palmar side of the extensor carpi ulnaris tendon. That's a positive ulnar fovea sign. And there's also pain at the ulnar aspect of the wrist during passive forearm rotation. There can be decreased hand grip, limited range of motions, especially pronation and supination. And also it's frequently accompanied by dorsal radio-ulnar joint instability. There are some specific tests to check for TFCC injury. Of these, the ulnocarpal stress test, or the TFCC grind test, that is pain on passive maximum ulnar deviation, and the screwdriver test, that is rotating the forearm from full supination to pronation. Both of these tests elicit dorsal wrist pain. And then there's the Ballottement test for checking the distal radio-ulnar joint instability. And you will be able to elicit the instability by this test. So physical examination is not really, it's not very conclusive because it's a large area, the TFCC, there's so many components. To see which area is actually affected, if you want to do a procedure, you have to rely on imaging. So X-rays, they do not have much role. We only get to know about the ulnar variants or if there's any fractures or dislocations. It's ruled out. Then arthrography has been used, but now has been largely taken over by MRI and MR arthrography. Nowadays, high-resolution ultrasound scanning is also being used. So how to scan for the TFCC? So you can check in both the long axis view and the short axis view. For the long axis view, the wrist is placed on a pillow, the forearm is pronated, and the wrist, there's a radial deviation, and you place the transducer between the ulnar styloid and the triquetrum parallel to the extensor carpi ulnaris tendon. When you place this is the long axis view, this is what you're going to see. This is the ulna, the triquetrum, the lunate. This area is the articular disc. This is the meniscal homologue. And you'll see the extensor carpi ulnaris running over it. So all the other structures will be around here. There's a tendon subsheath here, the ulnar collateral ligament here, and the lunate triquetral ligament right here. This you can see, actually they're showing the intervention. I'll come to that. So, so the long axis, that what we saw earlier, that was at the location of the styloid process. And if you come radially to that, you'll be able to see the fovea. So this is the fovea view, the ulnar fovea view, where you can see the deep radio-ulnar ligaments attaching to the fovea. So this is a very critical area in terms of anatomical and functional. So now coming to the short axis view, you place the transducer at the ulnar wrist above the ulnar styloid process, perpendicular to the ECU tendon. Radial deviation can be helpful. And you move the probe proximal to distally, so you visualize the different structures. So this is the first scan where you see the ECU, and as you come down, you'll be able to visualize the different structures. So this is the articular disc, meniscal homologue. and that ulnar collateral ligament. And as you come further distally, you'll be able to see this. This is the articular disc. So these are the findings on the ultrasound. So you can see the tears actually. This is a very peripheral tear, so this is what it is. And here it's a more central longitudinal tear which can be seen. So based on the MRI, there is a classification. The injuries are classified as traumatic or degenerative. And type 1 is traumatic. There is 1A, which is central, 1B ulnar, when there's avulsion on the ulnar side, 1C is when there's a distal avulsion, and 1D when there's radial avulsion. And type 2 are the degenerative types. So classically, 1A, it is a central one. So there is not much chance of repair. The blood supply is less. So traditionally, it used to be, only debridement used to be done by the surgeons. And the other 1B, 1C, 1D is what used to be repaired surgically. So coming to the treatment, non-operative treatment, it includes rest, immobilization, NSAIDs, rehab, and even in the acute phase, you can try corticosteroid injections. Operative, as I said, arthroscopic repair if it's 1B, 1C, and 1D. Arthroscopic debridement if it's 1A. And if there is any positive ulnar variance, and ulnar shortening will help to decrease the stress on the TFCC. So nowadays, regenerative therapy is largely taking over this. So unless there is a major instability, you can go for PRP or prolotherapy of the TFCC. So coming to PRP in TFCC injury. So I first got a case of TFCC injury around 3 years back, and then looking through the literature, I was looking to see, there were a lot of anecdotes about giving it, the orthopedicians were giving it blind, but looking for studies, I couldn't find any proper study on the use of PRP in TFCC. This is actually a poster presentation, which I found. It's just a preliminary report, and they reported the use of it in 12 patients, and they gave quite good results. This is a group of radiologists actually, and they went in plane. They showed the tear and the needle coming, and they followed up with an ultrasound after 8 weeks, which showed the tear healing. So there are so many other, if you search through the literature, there is no proper RCT on this. But there are many other, mostly case reports, not even case series. A lot of case reports are coming. Somebody said about being an adjunct to arthroscopy, so that's also, they're divided on that. And this is again another case report from Bangladesh. So these are all just, single case reports, and it doesn't have much level of evidence. So this is a study which came out recently in 2025, and it's a retrospective analysis, and it was conducted on just 6 patients over a period of 4 years. It was a retrospective study, and they concluded that USG-guided PRP injection is safe and well tolerated, but of course it required further studies. So this was done by Hung, Wang, Stanley Lem, Kevin Chang from Hong Kong. So what did they do? They took 11 ml of peripheral blood without any anticoagulant and centrifuged it for 3 minutes at 3000 RPM at room temperature. The upper fraction was discarded, and 1.5 ml of the concentrated leukocyte-containing PRP was taken. And they gave the injections in the through the volar and dorsal approach. So they described a new approach for this, and they based it not only on the MRI findings, but also on patient-reported soreness. So as they guided the needle where the patient reported soreness, that's where they gave it. And why they took the volar, so they gave for all patients through the volar and the dorsal approach. This is the volar approach, and this is done in the short axis, out of plane. So the advantage is that you're not going through any of the major structures. And also the importance of this is that you're targeting the radioulnar ligament, and especially the fovea. As I mentioned earlier, the fovea is a critical anatomical and functional importance, and it's rich in blood vessels, and when you inject it here, it goes into the radioulnar joint also. So they found that injecting into this fovea gave best results. So these were their demographics. Few patients had repeat injections, but almost all patients had, they only measured the outcome based on the decrease in the VAS scores. And 3 patients had more than 80% decrease, but all the rest of them actually had a significant decrease in the VAS. So how I usually do it, I've done around, I think maybe 10 to 12 cases now on TFCC. So I take 2 ml of ACD and peripheral blood, and it's made in a preformed kit to up to 25 ml, centrifuged at 3000 RPM for 12 minutes, that's the first spin, and 3300 for 5 minutes, the second spin. And 2 ml of PRP is taken, and ultrasound guided injection is given. I started off doing in plane following that poster, but I found that difficult to manipulate the needle because of the radial styloid, and so now I prefer to go out of plane in the long axis view. So this is how it's done. The wrist is placed in the pillow, the forearm fully pronated, wrist radially deviated, the ulnar styloid process facing upward, and the linear transducer is parallel to the ECU tendon. So this is how it's seen, the ulna and the triquetrum and the needle coming in plane. But this is very, very difficult because you can't reach, your structure of interest. And this is easier. You can see my needle tip here. So you can give it anywhere you want to give it. I haven't tried the fovea approach because I just came across a study right now. So that's something I would want to consider. Post-procedure, as usual, after any PRP, rest, give ice compression, give some immobilization or the wrist arthrosis, and oral paracetamol is usually enough, maybe for 2 to 3 days. Oral tramadol, SOS basis, some patients require it, and most patients require some soreness. Apart from that, they are usually fine. So graded physical therapy started around after 2 weeks with range of movements and gradual strengthening over 4 to 6 weeks. So most patients by 4 weeks have, significant decrease in their pain. Few patients took up to 2 to 3 months. But out of these 12 cases, I think 2 patients had some radial joint instability. Apart from, they had some residual pain, maybe was 1 or 2. Apart from them, everybody went back. And we had a few sports persons also, and they went back to regular activities. So this is one of the a paper which I came across, Ulnar Pain Revisited. So it's a very good article. It gives you how to scan for the TFCC and how to give the guided injections. It's a very comprehensive article. So these are my some of the pictures have come from these books. So thank you. And I bring you greetings from Kerala. It's our festival which is going on now. And thank you.
Thank you, Shalini, for your beautiful presentation at the same time, finishing it by time. Can I invite 1 or 2 questions? Or there is shortage of time?
In the end, we'll ask.
In the end?
Yes.
Okay.
Thank you, ma'am.
Thank you, ma'am. That was both enlightening and energizing, better than coffee. So let's dip into the next topic. I would like to invite our next esteemed speaker, Dr. Gaurav Sharma, sir. He is professor in the SMS Medical College, Jaipur, with a special focus on chronic pain interventions and cancer pains, has been at the forefront of advancing pain medicine, has contributions including 26 publications, 6 book chapters, and prestigious honors like Pain Ambassador of the Year Award 2019 and Chikitsa Ratna Award, IMA 2013. Welcome, sir.
Thank you. So my topic is still at ganglion interventions. It is not visible, huh? So stellate ganglion is one of the earliest intervention which is a pain physician learned, and doing the starting practice. So it's a very, you can say it's a easier intervention. Previously, when we started the practice, we used to do it by the landmark guided technique, and then C-arm fluoro guided, and now the USG guided. There are 3 approaches. Yes, now it is there. Thank you. So it's a sympathetic plexus block, sympathetic plexus intervention, which is cervicothoracic ganglion fuses with the first thoracic, so that is called star-shaped. That's why it's known as stellate ganglion. It started and it has been published in 1923 by Salem and the Cappies, and in 1924 Brooms and the Mendels. And so it's a very old procedure which is being practiced even in anesthesia, regional anesthesia, and now on the pain. So anatomy wise, I already told it's a fusion of C7 and T1. At the level of C7 and T1, in front of first rib it's found, and it's around 2.5 centimeter long, 1 centimeter wide, and 0.5 centimeter thick ganglion. So we all know that the sympathetic ganglions, they are moving around carotid arteries. So preganglion fibers from the interlateral horn of the spinal cord, and the supplies which caters is the T1 to T2 and upper limb T2 to T9. They all used to go through this sympathetic chain at the level of stellate ganglion. So that's why it's a major relay center for the head and neck and the upper limb. So anatomy wise, we should know what are the structures in the vicinity. So medially, it's an important thing: prevertebral fascia and the vertebral body, esophagus, thoracic duct, and longus colli and anterior scalene muscles. It's just in the posterior and the lateral and the brachial plexus sheath and the neck of the first rib. This is the important thing. And another important relation is vertebral artery. So vertebral artery traverses of the stellate ganglion and enters the vertebral foramen, and it is located posterior to the anterior tubercle of the C6. So whenever we are going to the initially like the landmark technique or in the USD technique, C6 chest neck tubercle is the very prominent tubercle. So it is a, you can say, safety also, because the vertebral artery usually goes behind that. But there is a lot of anatomical variation whenever we are going in the USG and or cadaveric study. That has been found. It may or may not follow these rules, but general rule is the C6 tubercle is anterior to the vertebral artery. The nerve roots of brachial plexus C6, C7, C8, T1 lie posterior to the respective tubercle. This is the important landmark. So indication wise, stellate ganglion intervention has been used in various pain syndromes as well as vascular insufficiency. So pain syndrome is CRPS1, CRPS2, vascular headaches, acute herpes zoster, PHN, phantom limb pain, Paget's disease, CA, various CA cases that involves the head and neck or upper limb, post-radiation neuritis, intractable angina pectoris. This is also an important thing when the medication management and all other things are not relieving the chest pain or angina. So that is also a good indication. Diabetic neuropathy and pain from cranial nerve disorders like Bell's palsy is associated with this facial pain. Then you can try this stellate ganglion intervention. And in vascular insufficiency, to increase the blood flow in the periphery, you can, like in Raynaud's disease phenomenon, frostbite, vasospasm, occlusive vascular disease, or scleroderma, you can use this intervention. And hyperhidrosis, where the sweating is quite high, so you can use this block or use intervention successfully. There are a few contraindications, like all procedures. And mechanism of action, how it works, it blocks the sympathetic outflow, and due to the vasodilation, blood flow is improved, and pain modulation can also worked with the central and peripheral pathways. So I already explained that there are 3 major type of techniques. One is blind, which is not advocated now. Another is fluoroscopic guided, and then USG guided. So USG guided is the or the hybrid technique is the best, because you can see all the soft tissue structures with this. Dye spread can be seen with the C-arm. That has the advantage. So it's important how you learn, how you practice. My practice is basically fluoroscopy guided. Whenever the USG procedures has been done, I used to take help of my fellow colleagues. So equipment wise, First, whenever you are going for the procedures, you should go for the diagnostic intervention followed by the therapeutic intervention. Diagnostic and therapeutic, they may need the separate things. Diagnostic, you need preservative-free local anesthetic, needle 22 to 25 gauge, 5 to 10 centimeter needle you can use, and there should be always, there has to be some image guidance. Either it can be fluoroscopy, it can be USG, and the resuscitation equipment has to be always ready, and you should have the whole facility if any complication arises. Informed consent, IV access, monitoring, emergency drugs, these are the preparation pies. Positioning had a little bit of head extension and with the head fixation. In USG, there might be some tilting on the one side might be needed. So landmark, I would not discuss. The fluoroscopy guided, mainly there are 3 types of approaches. It can be at the level of C6 or C7. There are the 2 approaches, paravertebral and anterior approach. Another is the oblique approach, and third is the RF techniques. So in fluoroscopy, we should know the fluoroscopy anatomy, level identification at the level of C6, C7. Anterior approach, there has to be, entry point is at the junction of the vertebral body and the transverse process. So you have to check the dye spread in the AP, oblique and lateral. Dye spread has to be linear dye spread. There should not be any vascular uptake. It can be venous, it can be arterial. So this is important thing. Then there might be chances of seepage into the epidural space. So these things has to be taken in your mind. Now comes the modified approach, is called oblique or lateral approach. You should know where the uncyanotic process. You can see the uncyanotic process, and just below the uncyanotic process, the entry point, and you have to take hit the bone and just little bit of withdraw, and then the dye spread is coming like this. So this is oblique approach. So you should little bit of differentiate between the longest coli spread and the sympathetic spread. So again, the confirmation has to be done in all views, AP, oblique and lateral. Then RF ablation, another techniques, and RF ablation has to be done unilateral at the level of 3 level identification has to be done. This you can see either right side or left side at the desired level. 5 mm active tip is required, and you can use 5 centimeter or 10 centimeter according to your comfort zone. Stimulation has to be done, sensory and motor stimulation. Important thing is you have to rule out phrenic nerve and recurrent laryngeal nerve stimulation. There should be no motor stimulation, and you have to be very, you can say you should tell the patient before the procedure that what is needed, because the cooperation during the procedure has to be there. So patient, you can see the recurrent laryngeal nerve involvement, and the patient has to make the sound, and patient should not move the neck, and these are the important things and how you should proceed. Lesioning can be done for the 70 degrees centigrade for 60 seconds. Then comes the ultrasound guided techniques. So ultrasound is, the anatomy is the same. You should be thoroughly prepared for the manipulation. So visualization of the carotid, vertebral artery, thyroid, esophagus, and all the longus coli, this has to be done. So how you get the successful intervention? So the signs of successful intervention are, there are venodilation and vasodilation, so visible engorgement of the vein, diminution of the psychogalvanic reflex, then there is temperature increase on the local area, and the Horner syndrome. So Horner syndrome is a sign of successful, but if you are giving the repeated procedures, then it might not that common. So what are the signs and symptoms of signs of Horner syndrome? The ptosis, meiosis, anhidrosis, enophthalmos, and loss of ciliospinal reflex and conjunctival congestion. Now comes the complication part. It seems to be very rapid, 2 minutes, 3 minutes, 5 minutes procedures, but the complications are little bit, you should be aware what can be done. It may be due to their faulty position, it may be due to your faulty spread, it may be due to the infection. So there are the different things. So anatomy is very important. If you are giving the intravascular, it may lead to the seizures and cardiac arrest. So whenever you are giving the drug, it has to be preservative free. That is the important thing. The preservative-free lignocaine, bupivacaine, ropivacaine, whatever you are using, that has to be preservative-free. If you are using steroid for the diagnostic or some therapeutic procedure, it has to be non-particulate steroids. Then hoarseness can be a common occurrence because the drug has spread to the recurrent laryngeal nerve. Phrenic nerve blocks of the unilateral, that might be some difficulty in the senses or in the perception of the respiration, because the opposite side is working normally, but the patient may say that I am feeling difficulty in respiration, though might be saturation is not affected, but the feeling of losing the respiratory feedback by the muscles, it is cumbersome in some patient, in anxious patient especially. And the lungs is in vicinity, so pneumothorax, esophageal puncture, and vascular injury may be there. So I've already covered this, yes, this is neuroaxial and brachial plexus spread, because the dural sheath is in continuity with this. If you are doing the more local anesthetic, more volume of the drug, there might be some this, and if your positioning is displaced, then it might lead to the epidural or intrathecal block. So that may lead to total paralysis, paresis. So the resuscitation equipment has to be ready. And if brachial plexus anesthesia, then you should be aware how to deal with. Infection can occur if you are not using, as Pankaj told in the previous lecture or in the disc, because he was using the different of sets. So this is important. Soft tissue may lead to the abscess. Neuraxial infection may lead to the meningitis, and the bone infection can osteoarthritis. These all are reported. These are because it's a very old intervention which is being in practice in the pain practice. So these all are the lot of cases has been reported. So evidence-wise, there are different evidence published by the various guidelines, various societies. The most commonly, maximum best evidence, level 1 evidence is in CRPS. So CRPS of upper limb, stellate ganglion intervention has been very positive. Ischemic and autonomic dysfunction, yes, it's a mixed bag of evidence. You cannot say that it is very much recommended, but it can be tried definitely with the all consent, and plus and minus has to be explained. So in conclusion, stellate ganglion intervention is safe and effective if done with the proper technique and imaging guidance. We should be aware what are the common complications and common consequences can occur. So it has been widely used in pain medicine and vascular insufficiency. So we have to be equipped to handle all. Thank you. Thank you very much.
Thank you very much, Dr. Sharma, for your wonderful presentation. Just there is time, that's why I am asking you, which level do you prefer? Are they C6 or C7?
Sir, in my personal opinion, I used to practice at C7 because I used to do at the fluoroscopic guidance. Yeah. But in blind as well as USG guided, C6 is preferable. So it's based on own practice and own comfort zone.
Have you faced any complications while doing the C7 level?
Complication per se, if you are talking about, then not very frequently. Only in last 15 years, I have only 1 or 2 episodes of hypotension, especially that can be easily managed. Horner's is a very common occurrence. We will not say that it is a complication. It is others equally to this.
Thank you, sir.
Thank you.
Thank you, sir, for that wonderful speech. You have managed to treat our confusion better than any intervention could have. Thank you so much, sir. Now, let's move on to our next topic. I would like to welcome our next speaker, Dr. Ravishankar Sharma, sir, on the topic of when should we consider intervention in cancer pain. Sir is an assistant professor at AIIMS, Gorakhpur. I'm sorry. Sir is speaking on cervical nerve root intervention. So let us travel with Ravishankar Sharma, sir, on this topic. Thank you.
So, good afternoon, everyone, and sorry for the confusion. So, according to the latest schedule, I'll be presenting on this selective cervical nerve root intervention. So, before moving ahead, there are nothing to disclose, and I would like to definitely acknowledge my department, that is Department of Anesthesiology, Pain Medicine, and Critical Care, AIIMS Gorakhpur. Along with that, I would like to definitely acknowledge the team ICRAPAIN 2025. So coming to introduction, so basically there are 8 cervical nerve roots from C1 to C8, and most of the patients who are coming to your OPD, they usually present with the more than 50% cases present with the C6 nerve root compression, okay? And apart from that discogenic cervical nerve root intervention, other indications which might be presenting to your OPD, that might include isolated nerve root pain, like the cases of sometimes phantom limb or this post-herpetic neuralgia, okay? So why this cervical nerve root intervention is required? So basically, what was this prior idea? Prior idea was it is the disc that is causing only the pain. But nowadays, we have got cadaveric dissection, and you can see this C7 nerve root, and just middle to that, what is this TFL? Anybody? This is, no, transforaminal ligaments, okay? So most of the time when you give epidurals, cervical epidurals, the results are not there because these transforaminal ligaments are compressing your nerve roots, and these are spreading vertically, okay? And you can see how it is getting related with this particular nerve root when it emerges from the spinal cord. So indications, I told you, isolated nerve root pain. Other indications like the radicular pain that is non-responsive to your conservative management. So coming to procedure, what would you like to prefer? Anybody? House? Ultrasound guided, yes, the picture says it all, okay? The vertebral artery just lying ahead of this, okay? But sometimes you will need that when you are performing this pulse radiofrequency ablation of the radicular arm, okay? So I will show you both those procedures, don't worry. So why ultrasound? Radiation-free imaging, short procedure time, and the most importantly, it is you have to avoid the vessels in the trajectory of the nerve. And most of the studies, this was the studies done in 2011, and almost 114 patients were, 1,014 patients were included in the study, and they compared both ultrasound and fluoroscopy, and found that the ultrasound is better when compared with this cervical nerve root intervention. These are 2 studies. Most of the authors you might be knowing. This Michael B. Furman et al., okay? And they found out there was 19.4% chances of vascular uptake while performing this fluoroscopy intervention. And you might be also knowing Samir Narose. So when he did this study, he also found that there was no vascular uptake while you were performing the ultrasound-guided interventions. So coming to extraforaminal. So if you are using Siam, where are you injecting? In the foramina. So it's going to be transforaminal injection. On the contrary, when you are using ultrasound, where are you going to inject? It's outside the foramen. So it's extraforaminal. So it's basically cervical selective nerve root is a basically extraforaminal selective nerve root block, okay? So coming to this position. So how you are going to position this patient? Lateral decubitus position with the neck slightly flexed up, and the side we have to face upward. So what are the anatomic structures you must be looking towards? So this is somewhat anteriorly we have got anterior tubercle, this is posterior tubercle, and the nerve, and the nerve is coming from here, okay? And the most importantly, these 2 vessels, one is vertebral artery and this common carotid artery. These are not only 2 vessels, I will show you the most important pictures. So this is how you get the sonoanatomy pictures. Coming from medially or anteriorly, this is carotid artery, the vein, the longus coeli, the anterior tubercle, the posterior tubercle, and there is a nerve in between, okay? And if you'll see that upper part of it, another nerve. So if it is C6, then it is going to be your C5 nerve, okay? Coming again, the next nerve root. So always try to start scanning from the medially. You put the probe over this cricoid cartilage, the move ipsilateral laterally, then you can ascend up or go down, okay? So at C7, what you will get? From medially, the carotid artery, and there is a directly linear plating, okay? This is your transverse process, okay? And you will get two anechoic structures, okay? So this is your C7 nerve root, but vertebral artery is not seen. I will show you in the next video, so it will be more clear. So go through this. Sorry for the poor picture. I am having this a bit older machine. So the carotid artery, the vein, you can see this linear plating, that is your transverse process. Now the two anechoic structures, okay? One is the medial structure and one is the lateral structure, okay? Now the color Doppler mode is on, so you can see this. So this is your vertebral artery, okay? And this is your C7 nerve root. So coming to the next, okay? Now what I have done, I have moved upwards slightly. So what you can see now, a longer or bigger anterior tubercle and the smaller posterior tubercle. And you can see something like that, an anechoic structure. But the difficulties come here. When you are performing this intervention now, so anterior tubercle or posterior tubercle come in between. Or the most importantly, in the next picture it will be better. So this is where the vertebral artery is lying, somewhat anterior and inferior to your anterior tubercle, okay? And now just focus on the next picture. So I'll showing you this where this is C5, C6, and C7. So from medially, from midline, I'm moving laterally. Okay. So you can see this picture. Now something is here, something is here, here. One nerve root is here, one nerve root is here. So this is C6, this is C5. Now I'm moving to downwards. So you can see this one vessel over there. Okay. And something is coming out here. Just wait a second. Yes. Okay. So this is your C7 nerve root. C5, C6, C7, and again, the color Doppler mode is put on. So this will be your vertebral artery. Okay? So injection technique, you have to take a consent, you have to monitoring system should be there, as recommended by ASA. And this IV cannula is mandatory. Antibiotic prophylaxis can be as per the institutional protocol. And agent for asepsis, yes, almost important. Other is, this was our place. This picture was taken from AIMS Rishikesh only. So ergonomics, yes. Next thing is, once you have identified this nerve root, if I'm doing intervention on C7 or C6, just what you can do, if you are going economically or you don't have echogenic needles, you can go with a spinal needle, okay, 22 gauge spinal needles, or you can go with the cannulas, okay, pink cannulas. So attach a line over extension over there and put on the midline, then move laterally, okay. So this is how we do it, okay. So see this. So where we should be injecting, important thing. Don't try to go posterior to the nerve, or don't try to go just here, this area, okay? I will show you where are the vessels located. It's not the vertebral artery, it's not the carotid artery, it's the radicular arteries, which are important here, okay? So where I have placed my needle, it's the apex of the nerve root, okay? I have not placed here, I have not placed here, okay? So why? See this picture. This is the nerve root. What is this vessel? Radicular vessel. This is the anterior part. The radicular vessel, the vertebral artery. And this is the posterior part, okay? So again, a vessel is there. So many of times you won't see it, okay? That's why we are preferring ultrasonography. So where should be the needle? I told you, it should be on the apex of this nerve root, okay? And it's the procedure called is hydrolocation, okay? You just use 10 cc of saline, you try to inject 0.1 ml, 0.0 ml, then hydrolocate it, just try to reach the apex of it, and then try to inject 2 to 3 ml of drug over it, okay? So post-procedure steps, like any other steps, you have to provide sterile adhesives, monitor in the recovery room for at least 2 to 3 hours, then ice sponging on the injection site. Yes, and if you are doing this pulsed RFA, the patient should be having at least more than 50% pain relief in this diagnostic procedures. So adverse effect, apart from those localized nerve pain, localized pain, the bruising, and the hematoma formation, the most devastating complication is one which I am worried about is intravascular injections. That's why I am preferring this, again, I'm saying always use color Doppler mode, okay? So how you can avoid these procedures? There's a whole book of debate is regarding how to where to use this particulate or non-particulate state. Just for beginners, I will definitely recommend go with this non-particulate steroids, okay? Coming to this you should always have the anatomy in your mind. What are those vessels? Where are those vessels? Okay, where is carotid artery? Where this is, what is this vessel? The most medial one. So you don't have to worry about only vertebral. The second is your ascending cervical, and third is your deep cervical. So other three vessels are also there along the nerve root. See this nerve root. C5 nerve root is coming from here. Okay, three arteries are there. Okay, next picture will be more. So what is this is actually a safe zone had been taken from this one of the fluoro picture. So where the needle tip should be as per the CT guidance. The posterior half the foramen and the lower half view. So oblique view is foraminal view. Okay, so you locate that foramen. So first thing for locating that foramen, PA view. So PA view, you will get something picture like this. Okay, the craniocaudal tilt, the squaring, everything need to be done. Next step is, now what you do, almost 45-degree oblique. So what you will get in 45 degree is your trajectory view. So that is the point where your needle entry should be taken. Okay, so where should be the needle entry point? So what I should do, I should be hitting the upper part of superior articular pillar in Siam. Okay, and once you have hit, without hitting, don't go into the foramen. I'll recommend you. Okay. And don't try to go just in the anterior part of the foramen. Otherwise, you are going to hit definitely this vertebral artery. Okay. So this is a picture on the left side. It has been taken from Michael B. Furman. Okay. So you hit this SAP, just enter this foramina. Okay. Now what you'll do? I told you where should be the needle position. Posterior half and lower half. Okay, that is quite relatively safe as per books and the literature. So next thing. What should be the final position in AP view? So you take one side, articular pillar, other side, you take this uncinate process. The needle should be in between those processes. Okay, that should be the final position in Siam. So always use the contrast agent. Okay, so you can see that definitely this is the dorsal root ganglion. Okay, the bulge, the medial bulge. Limitations, yes, Siam, definitely the fatal complications, as I told you, the vertebral artery and the ischemia of this, when you inject into the anterior spinal artery, definitely it's going to hurt you. So what are the radiolucent structure? You can see this. This is the nerve roots, especially the nerve sleeves. Don't try to inject when you are getting some resistance, especially not only the bone. It can be the dural sleeves also, okay? So you get something like that, contrast. And what are the suboptimal, this is the actual optimal contrast, how you get? Suboptimal contrast. So this is the picture. Can you see any vessel over here? First on the left side, can you see? No? See this. You can see clear vessels, this is the vessels, okay? For some people it can be, then one more vessel. Can you see it? Anybody? This one. This is not a nerve root, this is a vessel. This is the vertebral artery, okay? So again, here, this is a nerve root, here on the end plate, particularly on the horizontal side. Again, this is coming here, then this is not a good picture, but again, on the other side, we were getting this vascular spread. So coming from horizontally and then ascending upward. So avoid this, okay? So what is this? This again picture has been taken from Michael B. Furman. Intentionally, I have put this. What is this? Anybody? This is the vertebral artery. But how it is getting located? Because the dye, this is a vertebral artery, and you have injected dye somewhat outside the vertebral artery. So it has encapsulated that. Okay? So you take the both view, this is the AP view, and this is the oblique view. You can see this structure, vertical structure that's going. That is vertebral artery. Okay? So how you can increase the patient safety in the Siam? Preferably don't use Siam for this procedure. If you want to do this procedure, like pulse radiofrequency ablation, you can do it. So in the next step, I'll show you how to do it. So I told you how to place the needle, okay? So these are the pictures, AP view. This is perfectly foraminal view. The needle should be hitting SAP, going inside this. Only the tip of the needle should be lying in the foramen, middle half of the foramen. Then go with this pulse radiofrequency ablation. Pulse radiofrequency ablations for 120 seconds is usually not helpful at all. I have seen this. If you are performing it for extended pulse RFA, 240, then it is good, okay? Always use the contrast to see this needle, see this nerve spread, and you can use this 2 cycle of extended pulse RFA for this, okay? So that's all from my side. And every one of you is welcome. That is at AIIMS Gorakhpur. And definitely it's going to be great if you all are coming to us there. घूमने भी जाना है वहाँ से तो कहीं जा सकते हैं. On the right side you can see this special attractions over there. Thank you.
Thank you, Dr. Ravi, for your beautiful presentation.
Thank you, sir. We appreciate how you transformed tough concepts into something painless to follow. Now, our next speaker, I would like to invite Dr. Sai Jenny for throwing some light on QL block. Dr. Sai Jenny, ma'am, is a senior consultant in pain and palliative care associated with Fortis Escorts Hospital, Sarvodaya Hospital and Research Center and ESI Medical College and Hospital, Faridabad. She has a special interest in chronic pain, regenerative medicine, and cancer pain, and has contributed with several publications in indexed journals. Welcome, ma'am.
Good morning. Today we'll be seeing the quadratus lumborum block, which is a very good myofascial plane block useful in both acute and chronic pain. So first about the quadratus lumborum muscle. It's a very important muscle which takes its origin from the iliac crest and the iliolumbar ligament and travels superiorly and inserts into the inferior border of the 12th rib and the transverse processes of the L1 to 4 vertebrae. It helps in lateral flexion and spinal stabilization, and it fixes the 12th rib, thereby increasing the efficiency of the diaphragm during inspiration. This is important because when our patient complains of pain, he exactly complains during these actions. And here we see the anatomy. So here this is the quadratus. This is the quadratus lumborum muscle as marked, and anterior to it is the psoas major muscle, within which is the lumbar plexus. This is one thing we have to keep in mind. And here we see the origin to insertion. So it is right from the iliac crest and the iliolumbar ligament. So the pain of the quadratus lumborum muscle, it is felt at these regions and right up to the inferior border of the 12th rib. And here, when this is important because when we look at the MRI, we will find the quadratus lumborum just adjacent and lateral to the paraspinal muscles. So quadratus lumborum block is a myofascial plane block, and it is given in all the facial planes surrounding this muscle. The important part about this block is it provides both somatic and visceral pain relief, and we'll see how. And it was first described by Blanco in 2007. And dual block in chronic pain, it is mostly the quadratus lumborum myofascial pain syndrome, in which is now, where is this quadratus lumborum myofascial pain syndrome seen? Mostly in ladies or any patients with prolonged sittings or sitting jobs, especially the software professionals in these days, morbid obesity, patients with a pelvic tilt. Now, if a patient comes to us with chronic low back pain and he also has an antalgic gait. Now, if you look at the biomechanics of this patient, though he may have a hip, knee, or spine cause, this gait is going to cause the pelvic tilt, upward tilt of the pelvis, which is going to make the quadratus lumborum muscle go to spasm. And this is mostly seen in patients with weak glutes and hamstrings, which we'll see later. And this causes a secondary quadratus lumborum myofascial pain syndrome. Then also in patients with congenital spine deformities like scoliosis. And in our area, in our geographic area, we have a lot of pulmonary cogs. Now, in these patients, after prolonged cuffing, they have a subcostal myofascial pain for which they suffer for quite a long time. And in this, quadratus lumborum block works like a miracle for them. Also in abdominal malignancies as a surrogate or proxy block to celiac plexus and splanchnic blocks. And in chronic post-surgical pains, as we saw, most of the abdominal wall is covered by this muscle. So post-LSCS or ventral hernias. Then looking at the pain map of this muscle pain, we can see that the trigger points and pain areas of the primary quadratus of the pain very nicely. So coming to the block itself, it's a facial plane block as we saw. The drug spreads through the thoracolumbar fascia, it reaches the paravertebral space and then acts on the ventral rami of the spinal nerves. Now, high concentration of sympathetic fibers are also present in this area, and hence it also covers the visceral pain. Now, this schematic diagram shows that when we give an anterior QL block, so it goes through the anterior layer of the, middle layer of the thoracolumbar fascia, which is now continuous with the endothoracic fascia, and this one goes to the paravertebral space and through the vertebral foramen beats the nerve roots. We put the ultrasound probe. This is for the upper part of the QL muscle. When there is pain in this area, subcostal area, we put the probe covering the 12th rib and up to the L1 transverse process longitudinally, and we get this view where we get the 12th rib and caudad we get the first L1 vertebra transverse process. So in this, the hypoechoic muscle that we see here is the quadratus lumborum, and just below that would be the diaphragm. And this is the anterior part, which is the thoracolumbar fascia, which is again in continuation with the endothoracic fascia. So we can do an anterior QL block at this level also. And this will give us, this is at the level of the lateral arcuate ligament. Lateral arcuate ligament is the transversus aponeurosis takes a turn when it goes anteriorly to posteriorly. That is the lateral arcuate ligament. This is seen as a thickening. So when we see this, we can give a QL block out of plane or in plane and anterior to the QL muscle. And this works very well for subcostal pain. Thank you.
Thank you, Dr. Shah, for your beautiful presentation and elaborate, versatile application. And we have learned a lots of things from your.
Thank you.
The time is very short. They are not allowing for question. At the end of the session, I think there will be one question from the audience.
Sure.
Just one.
Thank you. So there are many approaches. Lateral position is the classic one, but sometimes when I do along with back pain, I do it in the prone position. Sorry? Yes, sir. Even, so the beauty of the block, it can be done in supine, it can be done lateral, and it can be done prone. So if you go further back from the tab block, you're going to get the posterior QL block plane. So you can give it. When the patient is supine, we go laterally, and we see the end of the obliques, and then you see the quadratus lumborum, and the QL plane, posterior QL plane, the tap plane is continuous with the posterior QL plane. And if you give the other one, the transversalis fascia block, that is continuous with the anterior QL plane. So we can, even a high volume tap block or transversalis fascia block can cover the quadratus lumborum plane, anterior and posterior. So anything else? And also even the intramuscular QL4, that also works as good as the posterior QL block. So that can also be given.
Dr. Sai, there are many evidence who says that steroid cannot be used in the muscles.
No, ma'am. I use clonidine because most of the patients for which I give QL block, they need temporary relief, and especially this 25 mic seat side with 5% dextrose and LA. No, rarely. Thank you.
Thank you.
Thank you. Sir is the Director of Pain Care Center, Pantai Hospital, Kuala Lumpur, Malaysia. Currently, he is working as a Vice Chairman of Asian Society of Regenerative Medicine and Immunotherapy. His areas of interest are fluoroscopy, US-guided interventional pain procedures. Thank you, sir.
Thank you, Chairman. Hello, everyone. See you again. Okay, so I think this is a topic everyone's very familiar. I think it's the ongoing, more changes, more technological advances. You know, we're going to see more newer things coming up. So let's see what are the changes we're looking at. All right. So there's no disclosure on my side. Okay, what is fluoroscopy? Right. So we know fluoroscopy is basically X-ray imaging. First discovered in 1895 by Professor Willem Roentgen. You know, Roentgen is the unit we use for X-ray. And the first X-ray image in 1896, and you won a Nobel Prize in 1901. In the past 2 decades, fluoroscopy has revolutionized pain management interventions because of a very high resolution images of bones and joints. And with more improvement with understanding of the imaging, the anatomy, and the pathophysiology of pain, pain physicians are much better placed to accurately diagnose and treat the pain generators. All right. So advantages of fluoroscopy. We all know that it gives you a very high quality image, provides clear, detailed images of the bones, soft tissues, which can be crucial for needle placement. Depth visualization, superior for deep or complex anatomical areas, following a better guidance during interventions. Widespread acceptance, many practitioners are trained in fluoroscopy, making it common choice for spine interventions. It definitely is a gold standard, especially for cervical lumbar epidural, and can perform real-time epidurogram, which is what is a major advantages, and see contrast spread, which you cannot see in ultrasound, right? And inability to recognizing intravascular spread by ultrasound as seen in fluoroscope. This is another important landmark. You can see intravascular spread. Like for example, if you're doing a cervical epidural, right, you need to have a very clear imaging to see the contrast dye flow. You can see the contrast coming out from the nerve roots, right, and you can see the spread of the anterior epidural space, the line. So this can only be seen in X-ray, can never be seen in ultrasound. Right, for example, if you're going to use a trigeminal ganglion block, right, you go to this foramen ovale, you need to see that only an X-ray can tell you the location of the needle trajectory. All right, so what are these advantages? Right, very important because X-rays carry radiation. And radiation exposure is a serious effect because you involve the ionizing radiation for both patient and staff. Remember, there's something called scatter radiation, and it's you must take full precaution for fluoroscopy, especially those who are doing interventions, because you see this hand, it is very common, I tell you this is especially people who've been using, in fact, I understand even Gable Rex hand has become almost like this, because too much radiation exposure without proper protection, right? So cost and accessibility, it's definitely more costly. You need more gadgets. You need more, lead-proof walls, more expensive equipments, lead gowns, right? More expensive, and you need more facilities. And limited real-time feedback. What it provides is real-time imaging. May not show soft tissues. It's not as dynamic as an ultrasound. So what is ultrasound then? Ultrasound basically is a sound wave imaging technique. All right, main use to see soft tissues and to guide our injections. Advantages, mainly no radiation. You can see real-time imaging and portables getting smaller and smaller, right? What are the main advantages? Because you can see real-time imaging. Provides immediate feedback during procedures, allowing for dynamic assessment of anatomy and needle placement. And absolutely no radiation, safe for both patient and practitioners, right? Very cost-effective, generally less expensive than fluoroscopy. Does not require any specialized facilities. And the most important thing is the portability, right? You can carry it around because it's getting smaller, easier to use in remote areas. Okay, as you can see all the dynamic changes. If you're going to inject into the shoulders or, knee joint, ankle joint is very clearly seen, right? And you can use it for abdominal, you can see very clear images. Disadvantages, remember ultrasound is a learning curve, it's the operator dependence. The quality of images and success of the procedure can heavily rely on a skill. So it's how you're going to get self-train, do more, train under people who can teach you well. And there's limited depth penetration. People are obese, may not be seeing the structures because of the sound waves, because of the anisotropy, right? And anatomical limitations, difficult to visualize certain anatomical structures, especially obese patient. And in case of extensive scarring. Also, the other thing is you must have a proper, the hand, your coordination of hand. You hold the hand, probe in the left hand and guide the right hand. All this needs a lot of dexterity. What's the drawback? Again, fluoroscopy, again, we want to discuss a bit more. Radiation hazard, right? But evidence soon after discovery of X-ray, right? What happens is this radiation can cause cell injury and cell death, right? It has various side effects, but not limited to skin injury, including burns, alteration of DNA causing somatic mutations, right? And radiation-induced leukemia cause high radiation exposure, right? So in 1994, the US FDA issued an advisory warning all healthcare facilities of the potential for radiation-induced burns to patients from prolonged fluoroscopic procedures, right? Although the intervention pain not mentioned, but I think we have to be careful because we are using more and more, okay? What are the safety to look after in fluoroscopy? It's very, very important, this one. Minimize tube current. Remember, you have the tube generating the radiation has to be always away from you, and the downside. Keep the kV. kV is the voltage high, and the MA as low as possible. Keep tube as much away and the image intensify as close to the patient as possible. Collimate the area of interest. Wear aprons, eye shields, thyroid shields, radiation protective curtains over the side operating tables. Okay. Stand as far from the tube to avoid scattered radiation. You must also remember try to protect the patient as well. Do not shoot too many times. Intermittent, always intermittent, never continuous. Continuous only used for in cardiac cases, but our pain cases only is intermittent. And always have a dosimeter. It has to be checked every year. And train operators, like example, this is what we need a full protection gown, right? And spine sonography, well, consists of a unique set of challenges owing to bony acoustic, shadowing, and limitations of resolution. Nevertheless, it can provide a good, accurate point of care, okay, diagnostic interventional imaging. So, although medical ultrasound, no risk of radiation, right, but more of skill, okay, where you can still use it for spine, especially when used for interlaminar, transformer, and choroidal epidural injections, but you cannot see the contrast flow, so that limits the usage, right? And talking about intraarticular facet, although you can see the facet joint, people who are trained can use it, but still you need a fluoroscope to be more accurate. Okay? Ultrasound as a diagnostic tool is an evaluation of aberrant anatomy of the ligament flavum, may provide insight into unexplained dural punctures during interlaminar epidural injections, right? So nowadays, the future is all using hybrid. So ultrasound evaluation scoliosis is a cost-effective, reliable monitoring method for young patients who have significant radiation exposure from frequent imaging. So these are what we're using in the moving forward. So some quick studies. They've done a comparative study in ultrasound fluoroscopy for back pain. Right, this was a paper published in 2023. They found that there's no much difference between ultrasound and fluoroscopic guided injection for reducing back pain intensity. But what they found is, obviously the fluoroscopy has a better preference, okay, in terms of functionality. Then you look at ultrasound versus fluoroscopy for lumbar transforaminal epidural injections, right? 80 patients were targeted, right, with low back pain, randomly assigned. So the success of ultrasound guided was 85%. Again, this was very operator dependent. Then we also have a compare paper between ultrasound fluoroscopy with choroidal epidural in low back pain patients. They found that fluoroscopy remains a gold standard for choroidal epidural injections. Ultrasound assisted procedures demonstrated comparable to pain relief, disability, and minimize adverse effects. Ultrasound guidance can have promise in future technology, but I think you still need to have a hybrid technique, right? And you can also use it more for SI joint injections, where you compare X-ray and ultrasound. They found that ultrasound guided SI joint injections with fluoroscopy confirmation has similar accuracy and efficacy to fluoroscopy alone for SIJ. So this is gaining more traction. More people are using ultrasound for SIJ injections. And there's even a paper published by Kailash Kothari, so it's quite a way back in 2016, I think. Yeah. Okay, so again, when you're doing spine work, especially when you do lumbar spine, you have to have fluoroscopy is the gold standard to see a position of the needles, right? So especially when you're using SIJ RF, okay, you have to have all this fluoroscopy, right? And again, when you do complex spine cases, right, you cannot substitute this with the ultrasound, right? So you can see this patient doing a C1, C2 intra-articular injections. This is for cervicogenic headache. Okay, so this is a quick summary, and it gives you a very good comparison between fluoroscopy and ultrasound, right? You can see, like I mentioned before, everything is spoken before, right? So again, ultrasound conclusion: the choice between ultrasound and fluoroscopy in spine intervention depends on specific clinical scenario, the experienced operator, and the required precision. Ultrasound advantages for its safety and cost effectiveness, while fluoroscopy is preferred for detailed image and especially in complex cases. So combining both modalities is a better option to consider, especially while performing complex interventional pain procedures in the head and neck. You can see me, but obviously you can see I'm a bit in the wrong position because the machine in front, I cannot put my ultrasound on the other side, so I need to bend myself back, although it's not a good posture because I'll end up having back pain. Okay, but that's the future using hybrid. All right, so that's going to be the future pain physician, all right? This is coming. the robots are going to replace us. So maybe our skills, we need our skills. Okay, thank you. Right.
Thank you, indeed.
Thank you, sir. Your expertise shown through. Thank you for guiding us. Now let's come to the next session. We now hand over to Dr. Jasnu Topal, sir, for the session on interventions in CRPS. Dr. Topal is the director of Mitigate Pain Clinic, Nagpur, specializing in neuropathic and musculoskeletal pain, recipient of Young Pain Physician of the Year 2024 award. He has 18 publications and notable contributions, including a book chapter on pain management. Welcome, sir.
Thank you for the nice introduction. Okay, so my topic for today is interventions in CRPS. Initially, I will be focusing on the bit about the introduction, and then more focus will be on review of literature about MIPSs. So CRPS has been known since more than a century and was first described by Surek as Sure's dystrophy. After that, in literature, there are more than 72 nomenclatures. And it was quite confusing, so ISP made consensus meeting in 1993 in Orlando and coined the term complex regional pain syndrome. And they defined it as a collection of locally appearing painful conditions following trauma, which chiefly occurs distally and exceed in the intensity and duration than the expected clinical course of the original trauma, often resulting in considerable restriction of motor function. Usually, only one extremity is involved, and the incidence is about 5 to 26 per 1 lakh population. And women have more preponderance, about 4:1 from female to male. Clinical features are variable. Important is there should be continuous pain, but there can be combination of sensory dysfunction, vasomotor or pseudomotor dysfunction, and motor and trophic changes can be there lately. It is usually preceded by trauma or surgery, but not necessary always. And mostly it appears like glove-like appearance in arm and sock-like appearance in leg. There are n number of differential diagnoses depending on the presentation at the point of time the patient is presenting to you. And based on that, you need to investigate the patient just to exclude your differential diagnosis. There is no specific test to diagnose the CRPS. However, n number of tests have been described in literature which are primarily used for scientific research. So it was quite difficult based on everything to diagnose the CRPS. There was no diagnostic test. There are no specific clinical things. So initially ISP in 1994 described criteria popularly known as ISP criteria, which were then inconsistent and have had a low diagnostic rate. So after that, Budapest criteria came into scene and was validated by ISP in 2012, which says that there should be at least two things. One is continuous pain disproportionate to the inciting event, and patient should have at least one symptom in all of the category and one sign in two or more of the categories of sensory, vasomotor, pseudomotor, or motor and trophic changes. So coming to the conservative management, goal of the conservative or MIPSs is to improve pain relief, physical function, and psychological well-being, and to help patient to regain the quality of life. The mainstay of treatment is physiotherapy, which can be supported with pharmacotherapy, psychological support, and occupational and vocational rehabilitation. Among pharmacotherapy, depending on which part is involved, whether it is only pain and inflammation, whether there is involvement of vasomotor or motor dysfunction, pharmacotherapy can be modified based on the presentation at the point of time. When the conservative management is not working, then we go to the MIPSs. There are n number of interventions which can be done for CRPS, including most commonly sympathetic interventions, then peripheral nerve blocks, and sometimes we need to go for central neuroaxial blockade and neuromodulation. So coming to sympathetic intervention, these are historically most commonly done, are important for the diagnosis of sympathetically mediated pain. Sometimes CRPS can be independent of sympathetically mediated pain. So these interventions might not work in those patients. We need to keep in mind that. The success rate usually depends whether is higher in patients who have mechanical and thermal allodynia. However, if patient has anxiety, it can negatively affect the outcome. So a study published in 2003, it was found that the outcome were better if amitriptyline was given along with the sympathetic blockade. Stellate ganglion block was also studied for CRPS1 patients in 25 patients. And the authors found that there was inverse relationship between the hand perfusion and the duration of CRPS symptoms. And there was a positive correlation between the efficacy of stellate ganglion block and how soon it was initiated. In another study published in 2000 it was retrospective analysis of 86 patients, and they found that radiofrequency ablation for stellate ganglion was successful in 14.7% of the patient, but 4.7% of the patient showed worsening of symptoms. So whenever we are intervening with these sympathetic interventions, we need to keep in mind that there can sometimes be worsening of the symptoms. Then coming to lumbar sympathetic block, it was found that cutaneous toe temperature, when increases more towards the core temperature, it gives indication towards the successful sympathetic block. Then about the outcome, in a retrospective study, it was found that the duration and degree of pain relief was not associated with the pre-procedural temperature. And in that, the authors also mentioned that the success of sympathetic block doesn't go hand in hand with the success of spinal cord stimulator. There were conflicting results whether the chemical neurolysis should be used or radio frequency should be used for lumbar sympathetic. And number of studies have variable results. However, it was found that there were, in most of the studies, it was found that there was no statistical different outcome between RF and neurolysis. But the neurolysis is associated with the more complications like neuritis. So RF treatment is preferred over the neurolysis. Also, botulinum toxin injection was tried with sympathetic blockade, and it was found that the it gives a prolonged duration of pain relief when Botox was added to the local anesthetic for lumbar sympathetic block when compared with the only local anesthetic. Also, botulinum toxin have been tried with 75 units, and it was found that the increase in temperature was higher in botulinum toxin than the control group, which was local anesthetic group, and pain relief was also better. Botox was used in 20 to 190 units and was found to have direct analgesic effect in patients with chronic neuropathic pain. And coming to the neuromodulation, and neuromodulation can be done in various ways, as we all know about most commonly spinal cord stimulator, peripheral nerve stimulator, or DRG. And data demonstrate that the pain reduction or improved quality of life and function and reduction of the opioid is associated with the neuromodulation techniques. However, it should be kept in mind that peripheral nerve stimulator is only possible when there is involvement of single or two peripheral nerves only, and it is less suitable for CRPS1. So coming to the evidences for spinal cord stimulator, evidence suggests that it is effective in chronic neuropathic pain of FBSS and CRPS1. In CRPS, it attenuates the T cell activation, improves the peripheral tissue oxygenation, and decreases the anti-angiogenic activity, which results in the endothelial dysfunction and improved blood flow. DRG stimulation was studied in a pooled analysis, and it was found that in CRPS1 patient or causal GR, the reduction of pain intensity was about 4.9 and 4.6 respectively. In another study, which is accurate study, a very renowned one, where authors found that the percentage of subjects receiving more than 50% pain relief and treatment success were greater in DRG in patients who are receiving DRG stimulator and compared to the spinal cord stimulator. So also it was found that the DRG stimulation demonstrated better improvement in quality of life and psychological disposition. Subjects using DRG stimulation reported lesser postural variation in paresthesia, and there was reduced extraneous stimulation in non-painful areas, indicating that DRG stimulation provides more targeted therapy to painful parts of the lower extremities. So might be we can move from spinal cord stimulator to DRG in coming years. The peripheral nerve stimulation, not very well studied, but there are few studies which may mention that the 43 patients have used the permanent stimulator implant and had lasting and good success. In another study published in 2007, it was said that over 60% of patients had a significant improvement and lifestyle following the implantation. But it should be noted that 40% patient had a failure rate, and it is significant in real clinical practice. Then coming to the peripheral nerve block, brachial plexus block has good outcome to tolerate the physical therapy. It blocks the sympathetic nerves around it, and it can be used if the sympathetic blockade is failure. So brachial plexus block, interscalene block was studied with the stellate ganglion block, and it was found that interscalene block was at least as effective as stellate ganglion block for the treatment of CRPS. Axillary block was also studied for CRPS, and it was found that the patient-controlled analgesia provides very good outcome for CRPS-1 patient for upper limb. Also, the clonidine was added in that, and clonidine has been found to have very good outcome with the 300 microgram dose or 700 microgram dose, but the higher dose have a higher rate of sedation. In one of the case report, it was found that the early treatment with the continuous epidural analgesia gives promising outcome in patients with CRPS. Intrathecal administration of the drugs, obviously you have morphine, baclofen, and ziconotidine, which is FDA approved for intrathecal administration with the IDSS system, and bupivacaine can be also given, though it is not still FDA approved. In 15 patients studied for the IDSS, it was found that the intractable pain of CRPS, arachnoiditis of the spinal injury, and chronic back pain of unknown cause, the patient had significant relief with IDSS. Intrathecal bupivacaine infusion was also studied in CRPS-1 patient in a case report, and it was found to that alleviate the refractory pain, but it affected neither the associated symptoms and signs of CRPS-1 nor its natural evolution. And hence, the intrathecal treatment cannot be recommended in preference to other pain treatment regimes of CRPS-1. In patients, in intrathecal baclofen was studied, and it was found that the dystonia, pain, disability, and quality of life all improved with intrathecal baclofen infusion and remain efficacious at least for one year period. In another study where the intrathecal efficacy of baclofen was studied, and authors found that there was significant improvement in pain at least for 6 months. And after this period, the scores level reduced despite the further improvement in dystonia and continued intrathecal baclofen dose escalation. Ziconotidine also studied, but as not available in India till now, so let us keep it. And intravenous regional anesthesia has long been studied, and guanethidine was the first drug which was studied. Now it is not recommended to use, but other drugs like lidocaine and clonidine has been found to be beneficial in most of the studies. So this was all about the adult patient, but what about the pediatric patient? Data for pediatric patient is quite less. The recently published literature review in 2024 found that n number of interventions can be tried in pediatric patient, but overall there was a lack of high quality evidence, and nothing can be specifically recommended one intervention cannot be specifically recommended over the another intervention in pediatric population. Coming to the clinical practice algorithm, which was given by World Institute of Pain, when your conservative treatment fails, start the psychological support. You should administer sympathetic block. If sympathetic block is positive, we can go proceed with the radiofrequency ablation. If sympathetic diagnostic block fails, then central neuraxial block or peripheral nerve blocks can be tried. If both sympathetic blocks and central neuraxial or peripheral blocks are not useful, then we can go for the spinal cord stimulator. In another consensus study, which was published in 2022, they have also given their own interventional treatment algorithm, and where they have suggested that minimally invasive treatment like sympathetic, IV regional blocks or somatic blocks should be tried first. If those are not working, then epidural or plexus catheter placement can be tried, or neurostimulation and intrathecal drug delivery system can also be tried. If those are not working, though the evidence is not very good for sympathectomy and it can be tried, motor cortex stimulation is still under the study. So these are all experimental things. The level of evidence which were given by WIP in 2018 says that we have moderate evidence for spinal cord stimulator and DRG for lower limb CRPS. We have weak evidence for thoracic block with local anesthetic and triamcinolone, as well as IV ketamine. And we have very weak evidence for peripheral nerve stimulation. And sympathetic blocks with local anesthetic do not have any evidence. Also, intravenous regional block with guanethidine must not be used, but local anesthetic and clonidine can be tried as an experimental basis. So to conclude, considering the complex pathophysiology of CRPS, there is no gold standard treatment for it. Depending on the presentation, we can consider for the treatment of it. Try with the simpler, lesser invasive, lesser dangerous, and lesser expensive interventions first. And if they are not working, we can go for more invasive, more experimental, and more expensive techniques. These are all my references. Thank you.
Thank you, sir, for your different modalities, discussing the different modalities of treatment. And there is shortage of time. I think there will be much more questions.
Thank you, ma'am.
It will be discussed after some time.
Thank you, sir. I think after the precise lecture from Jasnu, sir, on the interventions in CRPS, all our doubts on CRPS interventions are vanished. Now, let me welcome Dr. Amarnath Reddy, sir, to give lecture on greater and lesser occipital nerve interventions. Welcome, sir.
Good afternoon, everybody. I thank Dr. Gautam Das sir and the scientific committee of ICRA for giving me the opportunity to this academic feast. And I don't take much time. I'll try to finish off in time or maybe less. My topic is regarding the occipital nerve intervention. And greetings from Hyderabad. This is the hospital where I work. It's a slide changer. Okay. So just before getting into the block per se, we just know what are the common indications for occipital nerve interventions. As we all know that occipital neuralgia is one of the most common indications for occipital nerve blocks. Apart from that, there are so many other interventions, so many other conditions where this block is of very much useful, like cervicogenic headaches, even in conditions like migraine headaches. Yeah, and most importantly, even in it works sometimes wonders in cluster headache where it is refractory to most of the other medications. And also we see sometimes even in post-dural puncture headaches, even if the patient is failed with the epidural blood patch, then this comes for rescue for doing bilateral occipital nerve blocks. And also we see in whiplash injury and even in osteoarthritis of the neck, these blocks can be of helpful because sometimes this can cause osteophytic compression of the occipital nerve causing occipital neuralgia. So next comes to the definition. What do we mean by occipital neuralgia? The ISP definition of occipital neuralgia or Headache Society definition is defined as unilateral or bilateral episodic shooting or stabbing pain in the distribution in the posterior part of the scalp in the distribution of either greater, lesser, or third occipital nerve. It's not just greater occipital nerve. It can be either of the three, but usually 90% of the cases, the greater occipital nerve is the main contributing factor. And in less than 10% of the cases, it can be either due to lesser occipital or third occipital nerve. And in simpler terms, occipital neuralgia is defined as neuropathic pain arising from either GON, TON, or lesser occipital nerve. And in fact, this has been described almost like 1.5 centuries ago, like in 1820 by Benito, a Spanish surgeon. Just briefly, I'll touch upon the course of the greater, lesser, and third occipital nerves, because this actually helps us in identifying the location and guiding us the proper guided interventions, especially when we are using the ultrasound. As we all know that GON arises is a C2 dorsal, arises from the C2 dorsal ramus. Once it comes out between the C1 and C2, it wraps around the inferior obliquus capitis muscle and pierces and it lies between the semispinalis and the obliquus capitis inferior muscle, and it pierces the semispinalis before becoming superficial. It lies in the trapezius muscle and pierces the tendinous junction and becomes superficial, lying medial to the occipital artery and supplying the posterior part of the scalp, predominantly on the medial to lateral 1/3 aspect of the posterior aspect of the scalp. And coming to the lesser occipital nerve, it arises from the superficial cervical plexus, from the ventral ramus C2, C3, and it wraps around it comes posterior to the sternocleidomastoid and pierces and becomes superficial, supplying the lateral aspect of the scalp. And similarly, third occipital nerve, it's actually the superficial middle branch of the C2, of the C3, and it supplies it innervates the C2, C3 joint and also supplies the middle aspect of the scalp. I just want to touch about the trigeminal-cervical complex. We all know that we often give occipital nerve blocks even for atypical facial pains and also for cervicogenic headache pains. The rationale behind is the convergence of the trigeminal and the C1, C2, C3 nerves in the trigeminocervical nucleus, in the caudal aspect of the trigeminocervical nucleus. So that is the reason even in trigeminocephalalgias, we often do the occipital nerve blocks for managing refractory neuropathic pain. And also, as I mentioned, cervicogenic headache also is a referred pain coming from the back of the neck and referred as a headache in the scalp. And GON compression, greater occipital nerve compression, as we know the course of it, the course of the nerve, we know that it can get compressed at any of the 4 points in its course before it becoming superficial. The most common site of compression is at the level of the aponeurotic junction of the trapezius, and also sometimes at the arising of the nerve underneath at the inferior border of the obliquus capitis inferior muscle. And this forms the rationale for doing hydrodissection and also for dextrose prolotherapy. And similarly, the lesser occipital nerve can get compressed at the aponeurotic junction. And this is a beautiful cadaveric dissection showing the lesser and the greater occipital nerve, and you can see a connection in between. So sometimes that's the reason why we often combine both the greater occipital and the lesser occipital nerves for managing occipital neuralgia, though we often believe that it's only the greater occipital nerve, because sometimes because of the connections between the two nerves, it can cause patchy block. And I'll just touch briefly about the suboccipital triangle, because this is also the very important structure lies there, the vertebral artery. Sometimes while doing an ultrasound scan, we often go a bit proximal and see the C1 nerve, which is actually the suboccipital nerve, thinking as a great occipital nerve. That is the reason always having a proper swan anatomy is very important, because the vertebral artery stays close by to it. And C1 nerve is predominantly the motor branch. It supplies all the rectus, obliquus capitis inferior, superior, rectus capitis posterior major and minor muscles. And third occipital nerve is also very easy to block, and it's quite superficial. It arises, it lies at the junction of the C2, C3 facet joint, and even on fluoroscopic guidance, it is easy to block by hitting at the junction or at the superficial aspect of the articular pillar. And the risks, I'll just skip, as we all know that it's quite a safe block with very minimal complications. Mostly like we often see that the patient can become sometimes while doing bilateral occipital nerve block can have a vasovagal syncope. So always be ready to have a resuscitation equipment when doing these blocks. And traditionally, we have been doing before the ultrasound era, using the landmark guidance, because as in the superficial and the distal aspect, it is very superficial and very easy to palpate the occipital artery. And as we know that anatomically it lies medial to it, we just feel the occipital protuberance go 2 centimeter lateral and 1 centimeter down and palpate the artery and inject around the medial aspect of the artery in a fan-shaped manner. And similarly, and if you draw a line from occipital protuberance to the mastoid tubercle mastoid process, at the lateral 1/3, we can block the lesser occipital nerve. But being a pain physician, we have to be, we are more of a precision interventionist. So we need to always do perfect blocking because sometimes we often know that anatomical blocks require larger volumes, and also sometimes there is some failure rate of 5 to 17%. So this is the reason with ultrasound guidance, the success rate is close to 98 to 100% depending upon the user experience. And position, it can be done either in the supine, in the prone position with the head flexed, or even in the sitting position depending upon your comfort level and also the patient comfort level. I usually do most of my nerve blocks in the sitting position as it becomes easier for the better ergonomics and patient comfortness. But only make sure that sometimes if the patient is having giddiness, have an IV lens ready with the IV lens secured. And this is the main important zona anatomy we have to understand when doing the while doing the greater occipital nerve block. This is a boat-shaped inferior obliquus muscle. But sometimes identifying the C2 bifid transverse process might be difficult. So why usually like my simple trick is just to put the probe towards the mastoid process and try to look for the obliquus captus inferior muscle rather than struggling to find the bifid C2 spinous process. Because in the volunteer scanning, it might be much easier, but when in the real patients, you might really struggle to find out that bifid spinous process. And once you see, you can see most of the time a hypoechoic structure surrounded by a hyperechoic connective tissue, that is usually the greater occipital nerve, and sometimes you can see a pulsating veins beside it, vascular structures beside this. So try to use the Doppler before doing the dissection, and you can either come from medial to lateral or lateral to medial. There's no clear consensus on which is best or better. It's up to the user experience. I usually prefer to come from medial to lateral. The advantage is sometimes I even can block the third occipital nerve during the course while entering into the plane between the semispinalis and obliquus inferior muscle. And of lately, people are talking more about dextrose prolotherapy. But when I looked at the literature, there is no clear consensus of the concentration what we use for dextrose prolotherapy. And it ranges for anywhere from 5% to 22.5%. And in this, they use 15% dextrose with 2% lignocaine. They use around 3 cc at each nerve. But even the volume varies so much that in the recent article by Dr. Stanley Lamb, he used almost like 20 cc of 5% dextrose on each side. You can see the volume difference. And his technique is a bit different. He uses an in-plane approach at the distal aspect of the occipital greater occipital nerve. And coming to the pulse radiofrequency ablation, again, most of the time we often do the pulse RF refractory occipital nerve blocks, or even the blocks last for a shorter duration. Again, there is no clear consensus regarding the duration of cycles, and also the duration of the number of the length of the duration we need to do the pulse radiofrequency. Usually it ranges from 120 to 360 seconds. And usually most of the studies, what I have gone through, they have shown the results of anywhere from 3 to 6 months improvement in the pain scores. Yeah, this is a recent systemic review done at at the hospital where I work, Toronto Western Hospital, and they published last year. They shown that the quality of evidence is very low quality evidence on the analgesic benefit between the pulse RF of GON and of in chronic migraine headaches. So we need better quality studies to have a clear consensus on this. And there's another study which shows that rather than going for a repeated occipital nerve blocks with local anesthetic plus or minus steroid, pulse radiofrequency gives a better, longer relief. And coming to the role of Botox, everybody knows that Botox works by muscle relaxation and also having nerve block signaling. Again, there is some evidence to show that Botox has its role, especially in relieving the pain if due to the muscle spasms, but not in all the cases. And again, the number of units Botox can be used varies depending upon the musculature, and also it ranges from 5 to 100 units. Some people usually directly inject Botox into the occipital, obliquus capitis inferior and also the semispinalis muscle, and all. Some people use at multiple points where it is the inferior, greater occipital nerve at the distal aspect of the greater occipital nerve and the distal aspect of the lesser occipital nerve. And again, recently the interest is growing towards peripheral nerve stimulation for occipital neuralgia. Again, this is a very expensive procedure, and I know we don't have any much equipment in companies available here. The one which we used to use in Canada or even in US is the Sprint system, which is quite helpful because it negates the need for putting a spinal cord stimulator or going for a spinal cord stimulator for refractory occipital neuralgias. And even the evidence is not great for those things too. And cryoneurolysis of greater occipital nerve. I don't have much experience on I don't have experience on doing on this greater occipital nerve, because again the results show that it's only having short-term benefit, and if you see the size of the probe, it's quite big and it's quite uncomfortable for the patient. So it's better to do a pulse RFA or even do a diagnostic, local with steroid. And like PRP getting into everywhere, I just looked into the role of PRP for greater occipital neuralgia. Some claim that PRP is a magic drug, it works wonders, but in this, when I looked at the literature is very scarce, and even there is very low evidence for the use of PRP in occipital neuralgia. So overall, in this systemic review, in the last year I checked, this is the systemic review for meta-analysis for occipital nerve blocks. They show that occipital nerve blocks under ultrasound guidance with local anesthetic and steroids have level 2 evidence ranging efficacy from 6 weeks to 3 months. So it depends whether you want to repeat the blocks once again when the patient comes back, or you want to try for a pulse radiofrequency ablation, and there's no clear consensus yet, and it's up to the end user preference. And the chemical neuroablation, again, there is no consensus regarding this, though it has chemical neuroablation has been used in many other neurolysis procedures, but coming to the greater occipital nerves, there's no consensus for the use. I did look at only 2 studies, that too, one is a case report and one is, those 2 are the case reports. They found relief up to 9 months. Yeah, in summary, occipital nerve blocks are one of the effective treatment modalities for occipital neuralgias and very easy to perform even in migraine conditions. But coming to the choosing the kind of intervention, there's still a lot of evidence gaps. If you want to go for a continuous thermal RF or even a pulse RF, there's no clear consensus as of today. That's what I can say. And ongoing research and high-quality studies are yet to come to give a clear understanding on the further interventions, what we can choose. Thank you for your patience hearing.
Thank you, sir,
and
for your wonderful
I would like to,
presentation.
being a part of the organizing committee, I would like to invite you all to the ICRPAIN, 40th ICRPAIN at the beautiful city of Hyderabad in the month of February. Welcome you all. Thank you.
Thank you, sir. One thing I want to add, because for all the pain management, you have discussed everything, but there is also importance for the awake craniotomy and for the reduce of the pain during the operative period.
Yes.
That is a separate issue, but
awake craniotomy, we need to cover all the scalp blocks, almost like 7 blocks on each side.
One of the part of the scalp block is the greater and lesser occipital block. It is very important, and also to reduce the amount of the analgesic perioperative period. If you give the greater occipital nerve blocks associated with the other peripheral scalp blocks. Okay, thank you, sir.
Thank you.
Thank you for the impactful lecture, sir. Knowledge is the best intervention. I think you'll all agree with me. So let's welcome Dr. Samarjit Day, sir, to deliver exactly that on publications in pain medicine, consideration, trends, and future directions. Sir is consultant and in charge of pain medicine, unit department of anesthesiology, AIMS. Let's welcome, sir.
Good afternoon. I think I should not be the block between your lunch, but this was the topic was given to me, scientific publications in pain medicine. So actually it was a discussion between me and Das sir that what topic should I take, and I chose this because this is very important. Most of us are after the needle and the image in plane, out of plane, and we keep forgetting that we also need to publish to get the recognition that your procedure or the intervention should be going globally. So no disclosures to make. I come from the beautiful AIMS Mangalagiri, so I bring greetings from them. First of all, why should we publish? Why are we sitting in this hall and listening to the lectures? And going back again with a lot of memories, but with no reports, no scientific content. So this content has to be published in the literature so that when you die, after 25 years, after 30 years, after 100 years, people read your work and know that somebody like you was there who has actually done something in pain medicine. So for disseminating knowledge, for building on previous work, getting academic recognition, like people like me who are working in institutions, they will not give me promotion if I don't publish. Innovation and problem solving. Every day, Das sir will come up with some idea. One of us will come up with some idea. But if you don't publish it, nobody will recognize it. For getting funding and grants, again, institutions like us, if we have good number of publications, they will give us grants. Most importantly, policy and decision making. So the bureaucrats will not understand the in-plane technique of hydrodissection. They will understand how many percentage of the public is suffering from back pain. So for policy making and decision making, you need to come up with good quality papers to convince them, which is very difficult. So if I project the global trends in pain medicine publications, if you see, I have put India, it is in green color. We are striving towards the excellence, but not enough. Why not enough? Because most of us in this hall, we don't care about publications, right? So we want to read the papers, but we don't want to publish the papers. So it's time to change the seat and take the driver's seat for publication. You see China, Germany, Japan, UK, they all are ahead of us in pain medicine publication per se. In India, we do have good quality publication, but they are not enough. So maybe down the line in 5 years or 10 years, we should try to bring India up. And having said that, what should we publish in scientific journal? So some novel findings, if we get some new interventions, some original research, yes, and some methodology should be included. We have all the patients with us. We see some 100 patients in OPD, but we have very limited data because we don't give the time to the patient, but we don't record the data. So we need to record the data. And guidelines and consensus recommendation of the societies also can be published. And most importantly, to contribute to the field of pain medicine, we must publish. So what should be included in the manuscript? If we want to submit a manuscript, what should be included? So in a very brief manner, I have put it in the slides. So first of all is the title and the authorship. Like if you decide to publish something, you need to think about the title. It's like the attire you wear. Yesterday night you have decided what morning what will you wear, right? What is the color combination, whether it goes well with this or not, right? Most of us. So the title is like that. Everybody will read the title first. If they do not like the title, they will not read the article. So 2 seconds of their lifetime they'll take to read the title, and they will search also those keywords in your title if they are there regarding that topic. So a comprehensive title, it may have the following important keywords, like general, indicating the area and the specialty of the article it belongs to. Intermediate, referring to the specific disease or condition. Specific, referring to particular test or intervention. Having said that, this is one of the examples of the title which seems to be almost complete. Effect of spinal cord stimulation on quality of life and opioid consumption in patients with failed back surgery syndrome. We have the general area, low back pain, intermediate, specific disease, failed back surgery syndrome, and referring to particular test or intervention like your spinal cord stimulation. They have also actually put up the primary objective of the study, like what is quality of life and opioid consumption. So this gives us an impression that what we are going to go through or read through the article. Abbreviations should be avoided, right? GON, ICN, all those things should be avoided. Some journals also require some short running title, and these days publication has become more standardized. We have International Committee of Medical Journal Editors. Whatever guidelines they have given for authorship criteria has to be followed before submitting the article. And we also, these are done to prevent the ghost authorship and honorary authorship, right? So, मेरा नाम डाल देना यार last में, please. ऐसे, अरे मेरा दोस्त है. So all those things are there. So we need to take care of those. And some journals, they require authors to declare their contributions as well as conflict of interest. So if you have submitted papers to journals, you will receive something called conflict of interest or some sort of this to declare it. So what are the important considerations for writing a manuscript? First of all, you need to think about the topic, build up the concept that I want to write or on this topic. And you have to choose the article type. Your study belongs to which article type? We have original article, we have case report, we have case series, and all those things. So we need to familiarize with the instruction to authors. Every journal, they have their specific instruction to authors, even though they are more or less similar. And we need to have a coordinated team. Alone, I can write an editorial or a case studies or a case report, but not an RCT. So you need to build up a team. These days, teams are being built up to do systematic review and meta-analysis. We know that. And meta-analysis holds the maximum evidence in the field of, in the medical field. So preparing a skeletal framework for the manuscript is very important, and delegating time for thinking and writing in regular intervals. We cannot do it in 1 week or 1 month. It takes time. Parts of the manuscript, the first part is, again, after the title, if the person is interested in reading our paper, they will read the abstract. So abstract is the brief overview of the contents. It also has various parts like background, aim, material, method, results, and conclusion. So there is a word limitation for every journal. Generally, it is 250 words because people would not like to read longer for abstract. And there is, below that, there will be keywords. So these are 3 to 8 keywords which actually will be being searched. So that also should be there in your title. Then comes the main manuscript body, which follows a IMRAD protocol, that is introduction, material and methods, results, and discussion. So introduction, again, is a section which sets the tone of your article, and it has to be the general background of the condition, what is known so far, and a brief description of unknown aspects. why have you thought to write about it or done a study about it? And your primary and secondary objectives should preferably be occupying 10 to 15% of the manuscript. After introduction, we have the material and method section, very important. We need to declare what type of study it is. There are various types of study. I will not go into the details, and we need to specify whether we have taken ethical approval or we have registered the RCT or the study in CTRI or not. And we need to mention the inclusion and exclusion criteria. There are various online guidelines available for various studies. Like for RCTs, we have CONCERT, we have for observational studies, we have STROBE, for systematic review and meta-analysis, we have PRISMA. So we need to follow those guidelines to get qualified to submit, not to accept, to submit. So material and method section, we'll have study design and setting. You have participants, inclusion and exclusion criteria, mention of ethical or CTRI approval, informed consent, the generalized flow on or the protocol of the study, the data collection details, sample size calculation, and the methods of data analysis. After that, we will jump onto the statistical analysis, to do or not to do. So there is an option to do it yourself. If you are too much enthusiastic or very good in statistics, generally we refer to a statistician, because many a times these RCTs, cohorts, and case controls are a little complex, and it's better to get the expert on board and get it done, right? Coming to results section, you need to again mention the sample size, basics, characteristics. The demographics has to be mentioned. The main results, again, the results section should closely reflect the material and the methods section. So you need to actually correlate. And also secondary results should be provided separately, and this section should be written in past tense. So whenever we get the articles submitted to us, we will see all sorts of tenses. So it's not only the methodology that matters, also the English which is being written in the manuscript. Coming to discussion and conclusion, discussion section that provides the interpretation of the results. What I have found in my study and what others have found in the study, right? The first paragraph will summarize the main results in 2 to 3 lines or maybe up to 5 lines. And then subsequent paragraph should review the results in the context of available literature. So you cannot write the stories of Ramayana and Mahabharata. So let's say if I have found that pain reduction in knee pain, so for one particular intervention, so what others have found also has to be mentioned, right? If we have found comparable results, fine, we are happy. If we have found otherwise results, we need to defend ourselves. We will have our conclusion or explanation for that. And it's not that we always have to find the similar result what others have found. Otherwise, literature would not develop. Negative studies are welcome these days because we know that a lot of ghost studies are being done. So it is always welcome to do the get the negative results also, whatever is properly done. Need to mention the strengths and the weaknesses of the study, because building on that, the next studies will come up. An interested author would read this section very importantly, because they will know that what is shortcoming in this, if I add this, whether this would help to build up the evidence or not. And ends with a conclusion with not more than 1 or 2 sentences. Your conclusion should match your title and primary objective, right? References are the very, very important part, because we get, nowadays it's very easy because we have EndNote, Zotero, all those things, which actually will save your references as a serial number. The commonest styles used are Vancouver and APA style. But again, the journals have their own references selection. We need to do the acknowledgements, because only 5 people cannot do the study. If you want to acknowledge a company, if you want to acknowledge an institution, you can do that. At the end, you need to declare the conflict of interest. As I said, there is a separate form for that. And plagiarism in language is very important. So these days, AI has blessed us with a lot of power. So you can write a manuscript asking ChatGPT. But sadly, we also know that this is being done. So the journal has their own method to identify this. So role of AI in journal management, this I have put it today morning, I thought I'll put it because when the author can use the AI, the editor also can use the AI, right? So we know that whether it is being written by AI or not, we can actually find out. But other than that, what AI helps us is like to find out the content enhancement for your article, the peer review assistance. Many times our reviewers are very busy in practice, in personal life, so we keep disturbing them. So they can help us in this editorial workflow, yes, tracking the manuscript across the submission. They will help us with ethics and integrity, again, detection of data fabrication, duplication, and inappropriate image reuse. This is very important because we never give credit to the image we take from somebody or some books. So having said that, I'll go back. So after that, so this is whatever I have talked about is the hourglass structure of manuscript. So it starts with a broad literature review in the introduction, identifying the knowledge gap and the research question with primary objective and the secondary objective. Then comes the results, the research answer. Because what question you have asked, you will get the answer, and then comes the results, analysis, and the discussion. Very important slide for all of us is the peer review process. It is to be understood that the editorial team works very hard to get your paper published until otherwise. So this is the peer review process. So when you run with your manuscript, so these people are waiting to stop you. This is the commonest feeling. It's not like that. So there are various stages where the peer review process, when the author submits, the first instance itself, it can be rejected because it may not be at the scope of the journal, right? Then it will be sent to the reviewers. Reviewer may not like it. So reviewer will give some comments, depending on that can be rejected, or maybe some corrections are asked, and after the corrections, it can be addressed by the editor. It can be rejected again if they are not in proper corrected form. If not, then it is accepted. So to accept from the submission, this is a long process. So many a times it happens that why my paper is not being accepted. So this is because these are the processes has to be followed as per journal protocol. And after that, after acceptance to production, again, this is the production media. So it's not in our hand. So again, that also takes time. This is the hierarchy of evidence. So my suggestion or request is if you wish to wish to do or contribute to the evidence, you may start with case series or case reports, but they do not help us in generating evidence. Try doing some RCTs, and then probably after that, meta-analysis and systematic reviews. So having said that, what is the scope of research and publication in pain medicine? It's immense. So we have pain physiology, pain epigenetics is coming up in a long way, receptor-based pharmacotherapy, nanotechnology, molecular, and whatnot. More importantly, I would say the epidemiological research is more needed because it will help us getting more attention towards the policymakers to bring changes, recognize pain as a specialty, also to advocate research funding, and easy to do. We have exclusive pain journals. I have put Indian Journal of Pain here because it was recently Scopus Index, so I request all of you to submit your papers to Indian Journal of Pain, giving it a try. We have a lot of strategies to improve. We are not perfect, and we need to do some capacity building. Such a big conference should include a session on how to write a paper, how to submit a paper, right? It's my request to the organizers. Publication mandates, we have in our FIPM curriculum that you should have one publication. Collaborative research networks we need to build up. Funding and infrastructure, again, is one of the most important part is given to the institutions. Probably the societies should come up with more funding for improving the research in pain medicine. We need to focus on relevant areas which is pertinent to India. Probably cancer pain and interventions, low-cost intervention techniques, and because evidence-based integration of regenerative therapy, all those can be tried. Journals and visibility, we have our own 1 or 2 journals in India for pain. Probably we can actually improve the quality and get a global visibility. This I have already shown. Thank you so much. These are the 2 very close to heart journals. This is Indian Journal of Pain, and this is Journal of Musculoskeletal Pain and Ultrasound and Pain Medicine. So we are trying to improve the journals. It cannot be done without your help. So please submit your papers to these journals so that we can actually improve the journals. Thank you.
Thank you, Dr. Shamukjit, for wonderful presentation. Now.
Thank you, sir. Thank you for this insightful lecture. Now I invite all the speakers of this session on pain and interventions and more onto the dais for the question and answer session and photograph. Dr. Shalina Chandran ma'am, Dr. Gaurav Sharma sir, Dr. Ravi Shankar Sharma sir, Dr. Amarnath Reddy sir, Dr. Sai Janni ma'am, Dr. Gopinath and Raju sir, Dr. Jeshnu Topal sir, and Dr. Samajit sir.
Hello. Any question from the audience? Any doubts to be clear? Okay.
Yes, sir. Sir, it's extraforaminal, sir. Yes. Yes. We do not. Yes, we do not.
So it is extraforaminal.
Yes, extra.
Any question?
Sir.
It is sent to 2 or 3 reviewers. But what new trend I am seeing, when you comply to the request or the suggestions to the reviewers, you get another set of questions by the new reviewers. So you satisfy them, and third time you get 3 new questions, same were satisfied the first time. So you keep changing your manuscript, and in the last, what happens? I give you my example, that I was writing a paper in which a volume was defined. By decreasing the number of the text, the actual volume was removed from the main text. And then on the, you see, here we can tolerate all those things, but when it goes to the international level, they criticize it very badly. So how to deal with that? And do something to prevent this?
So actually, see, if the reviewer is giving a comment based on scientific evidence, and you have an answer to that with this suggestion of scientific evidence that no, I use this volume because this study has shown that this is useful, I don't think it's an issue. But if your case is unique, probably we would look into as a separate case, like why it has happened, definitely. But generally what we do, we send it to 3 to 4 reviewers. Every reviewer will not accept it. So the reviewer crunch is one of the, it's an, what to say, epidemic. We can't find reviewers, okay? And it has happened to you also, I'm sure. I have sent you and you were not available. And I understand that because of the personal reasons also, probably the reviewers cannot respond. So that happens because we are not having reviewers, enough reviewers. Probably we are trying to get on board of all the, even young people also we are including these days. So that problem has been addressed, if I am not wrong, but if it is there, we will definitely look into it.
Sometimes what's happening, sir, some of the reviewers give their comment. Like we have invited 5 reviewers, and 2 of them has already given the comment. And the third reviewer, what he does, whenever we have sent you for the first revision, he gives comment at that moment. So we have to include that. Yeah, that's the main issue.
Any more questions?
report and all, you don't need IC approvals. You can straight away submit it. Also, we have a lot of publications from private clinics. For private practitioners, for Indian Journal of Pain, we started images in anesthesiology, in pain medicine. One section is there because we did not want you to write a long, you don't have time, right? As far as RCT is concerned, for studies, there are local IC bodies. You need to contact in your state or the area. In that area, there will be local IC bodies. If you can pay something, there is something called registration of those local ICs. Your clinic has to be registered there. They will give you some set of documents which comply to that. And you can actually do under their guidance. So I think, where are you from? Bangalore, there are very good number of local IC bodies. You can get in touch with them. Another suggestion is you get collaboration with some private medical college, get some co-PI or co-investigators from their institute, and you can actually submit your RCT or the study in their IC.
Otherwise, you can do case series, case reports, and review articles.
I work in a corporate hospital. Their policy is any procedure has to be through a daycare admission and to be done in a procedural room. So it's not a pure OT, but it's a kind of a C-arm and a sterile table. Basically, we have a cath lab also. So sometimes most of the procedures I do in the cath lab. No, personally I don't. Especially for cervical epidurals and other patients, I do keep epidurals, but not for these kind of patients. But if I feel that the patient is too anxious or if any previous history of any syncopal, then I try to be on a safer side, I put an epidural. But I think some people will put get a second IV line in every patient actually.
I do even for trigger point injections, everything, because when they have vasovagal, that time it's difficult to get a vein also.
I think that all the questions are over, and now I am concluding the session and then proceed to the lunch break. I think so. Oh, you will continue. Sorry. The scientific session will be continued. Okay.
Yes, ma'am. Thank you.
should we venture into the future? Shadowing the shadow.
Hello.
দিয়েছি দেখ রাহুল স্পিকার না হেডফোন হবে স্পিকার না হেডফোন না না হেডফোন হবে ইপি ইপি না বাজাইনি কিছু দাঁড়া রাহুল ওখান থেকে বাজা দেখি ঠিক এখানে করবো কি করে? এবার বাজছে না তো? না হ্যালো 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 এটা কম আছে। হ্যালো যা 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 না আমি দিচ্ছি। হুম ইয়ে আছে না?
হ্যাঁ খুচরো দাও।
দেবে দুজন খাবি দেবে না? বেশিক্ষণ তাড়াতাড়ি আসবি। এই শোভনের ব্রেক হয়েছে? কি আবার আবার লাগাবে?
Yes, celiac plexus neurolysis. Celiac plexus is the largest visceral plexus and is located deep in the retroperitoneum over the anterolateral surface of the aorta. The origin, around the origin of the celiac trunk. It is also called as the solar plexus because it has a very big size. It serves as a relay center for the nociceptive impulses that originate from the upper abdominal viscera from the stomach to the proximal transverse colon. This is the structure or anatomy of the celiac plexus. It lies anterior to the aorta at the level of the T12 and L1 vertebra. It is found near the origin of the celiac trunk just below the diaphragm. Posterior to the stomach and pancreas and superior to the kidney. These are the relative relations, anatomical relations, which is situated retroperitoneally in the upper abdomen. So these are the components of the celiac plexus. It contains celiac ganglion. The afferent fibers, mainly these are the organs which the fibers innervates like pancreas. Fibers of the celiac plexus innervates like pancreas, liver and gallbladder, stomach, spleen, kidney, small intestine and adrenal glands. The pain originated from these organs. These are covered by the celiac plexus blocks. The efferent fibers, that is sympathetic fibers, arises from the greater, lesser, and the least splanchnic nerves, mainly originating from the T5 to T12 spinal levels. Synapse is the celiac ganglion before innervating abdominal organs. The parasympathetic fibers are also there. They passes through the celiac plexus without synapsing, continuing to the enteric nervous system of the abdominal organs. So, about talking the celiac neurolysis. The first person who has given the concept of the neurolysis by the chemical agent who was the in the 20th century, and the Lewton, the name of the scientist was Lewton. He published the first paper that we can use the chemical substance to neuralize to ablate the nerves. Then the main history that began in 1914 when German surgeon Maxi Kappes first described the technique as a form of surgical anesthesia for the abdominal procedure. First publication, celiac plexus block by Kappes in 1914. This was given first for the surgical anesthesia. Initially, it was initiated as surgical anesthesia, but this concept became failed, and finally, this neurolysis of the celiac plexus came for the abdominal pain, for the management of the abdominal pain. So the main indication, chronic pancreatitis, treatment of visceral poor localizing abdominal pain, diagnostic block, pancreatic adenocarcinoma, cholangiocarcinoma, abdominal visceral pain syndrome, upper abdominal malignancies, retroperitoneal malignancies, and hepatobiliary malignancies from the hepatobiliary system. As usual, like other contraindications, there are absolute and relative contraindication when we are going to do any interventions like absolute or coagulopathy, severe local or intra-abdominal infections, bowel obstructions, increased risk of the perforations, where we have to not touch the patient for the celiac plexus block. The relative contraindications are abdominal aortic aneurysm, aortic thrombus, eccentric origin of the celiac axis, large intra-abdominal mass, or patients of the terminal stage like Hughes ascites. These are the main equipments which we are using for the celiac neurolysis, by both techniques, fluoroscopic and ultrasound. There are many approaches for the celiac plexus neurolysis. The retrocrural approach, the anterocrural approach, transaortic approach, and the transvertebral disc approach. So the most commonly approach used is the retrocrural approach. There are many studies who has proven this, that retrocrural approach is the most used approach. But some studies also says that transaortic technique is also very good and very has efficacy. So transaortic, a variation of the anterior approach, needle passes through the aorta to reach the plexus, rarely used mostly, but this technique required the high skill of the pain physicians. The trans-intervertebral disc approach, this is also not very common, but I am usually using this trans-discal approach in my setup. The other one is the very important and the latest, that is ultrasound guided approach. As the new pain physicians who are coming in the field, they are mostly towards the ultrasound techniques. So the ultrasound is more safer as compared to fluoroscopy because it is able to show the vessels, vascular structures very clearly. And by the ultrasound, we can use the very precise, very accurate position, location of the celiac plexus. So this is the most useful and very important and very upcoming technique of the celiac plexus block. How to do? The intervention is performed under X-ray guidance. In my setup, I am using mostly the fluoroscopic guided. So the patient is placed in the prone position. Intravenous lines are kept. The monitors are attached to the patient. You have to be prepared for any drastic problems. So C-arm is placed in AP position and it is tilted C-arm oblique in the chordate position for squaring the T12 and L1 vertebra. Place the C-arm ipsilateral oblique to evaluate transverse process of the spine and keep the needle there. And then insert the marking of the needle is at the anterior border of the L1 or T12 vertebrae. Then give the dye. This is the dye. This is the dye pattern. And the important thing is that the margin of the dye do not go beyond the margin of the vertebra. So this is a patient who is having CAGB and is supine in position. And the video is not very good, but I am doing the intradiscal procedure. And this is the two bilateral site. And we have given the dye. Then after that, we have given the 10 ml absolute alcohol with the Zylocard. The main complications in this procedure is the local pain, rectal injury, hematoma, discitis, neuritis, and intraneural injections, cauda equina syndrome, and infections. The post-procedural management is most of the patients, they are having this hypotension. So you should be prepared for the hypotension. First, before taking the patient in the OT, you have to infuse 500 ml or approximately 1 liter of the fluid to the patient. And these patients are also fasted, so you have to be prepared for to manage the hypotension. And in the post-op, there is sometimes I have seen the patients with diarrhea, but this is treatable. So there is a paper which I have published. We have done 30 patients in both group, and I have used the multiple concentrations of this amount of the alcohol. And I saw that the more amount of the alcohol when I have given, the result was more as compared to less amount of the alcohol. There is another study who shows that transaortic celiac plexus neurolysis with low volume of alcohol is safe procedure. This has published by the Dr. Anurag Agrawal up to 6 months. And this is also very important because in the ultrasound guided, we are very accurate and we are very precise. So the amount of the local alcohol is less as compared to other process. There is another study who proves that ultrasound guided and fluoroscopy assisted posterior approach you can also use. There are many publications which proves that ultrasound guided celiac plexus nerve is effective method for reducing pain of upper abdominal cancer. So these are the fluoroscopic and ultrasound guided procedure of the celiac plexus. So those celiac plexus is a very large plexus. So the accurate position of the celiac plexus is not very well known. This can vary according to the patient to patient. This can vary depending upon the disease of the abdominal cavity. This can vary upon the spreading of the tumor, or the local anatomy may be disturbed due to the malignancy in the abdomen. So third one, cryoablation, which these videos and these publications I have seen from the Gautam Das sir. And the cryoablation is also a new technique which came in the light very early, but it has got many publications and many approach towards the cryoablation, because the cryoablation gives the large area of the ablation of the nerves due to the this technique. So celiac plexus is a large plexus, and by the cryoablation, we can cover almost all the fibers. So the efficacy of the cryoablation is more as compared to the previous fluoroscopy and ultrasound guided. So advantage of the cryoablation, this approach offers a well-targeted, effective and safe alternative to the chemical neurolysis, especially in complex clinical situations, like when the tumor is increased in the size or the anatomy of the celiac plexus is distorted. Side effect profile is diarrhea in 5% cases, but it is treatable. And there are many publications, that is CT-guided cryoablation of the celiac plexus. This also has a very good result in the abdominal cancer. There are other publications like percutaneous computed tomography guided cryoablation of the celiac plexus as an alternative treatment for an intractable pain cause. This has also showed that it is an effective alternative to NCPB for palliative treatment of celiac plexus involvement. There are many publications. When I was searching the articles to present this topic, there were many publications which I have seen for the cryoablation. So of the upcoming time, this may be placed by the cryoablation of the celiac plexus. I have also seen that cooled RF is also published for the ablation of the this celiac plexus. But in the cooled radiofrequency ablation, the needle of the cooled radiofrequency ablation is too thick, and it can produce this trauma to the adjacent structures. So these are other publications which favors this cryoablation and ultrasound-guided celiac plexus block. The future outcome, what we want? We want significant pain relief, reduced opioid dependence, improved quality of the life of a patient, and repeatable if needed. So this is the advantage of the celiac plexus. In cancer patients, it is palliative, aiming to improve and comfort to the patients. And the possible complications or limitations, temporary side effects which can be treated. So seeing the side effects, we cannot leave the celiac plexus block, and we have to relieve the patient from the pain. Incomplete pain relief may be happen in 20% patient. Procedure related risk may be happen, which as usual, this can be happened with any procedures. So advantage of fluoroscopy and advantage of ultrasound are as I have told. So in the future, outcome of ultrasound-guided celiac plexus block is generally favorable for the well-selected patients, especially those with upper abdominal malignancies or chronic pancreatitis. The procedure can offer safe, effective, and repeatable pain control. Both techniques are effective. Ultrasound, radiation-free. Ultrasound is radiation-free, bedside, real-time, soft tissue guidance, and which is particularly benefited in the cancer pain or ICU settings. Fluoroscopy is also good, but it has its own side effects like radiation. And ultimately, I'm going to say that cryoablation is a new technique which is coming up for the celiac plexus block. Thank you.
Thank you, Sarita ma'am.
Thank you, ma'am, for the wonderful presentation. Q&A session will be after the all speakers have ended.
One special announcement. 40th ICSP Con will be held at Hyderabad. We are excited to tell you that there is a counter outside Hall B where you can register with a discount. So please do register in it. So let's move on to the next session. It's my privilege to invite Dr. Debashish Jatwa, a highly respected pain and palliative care specialist, who will be delivering his presentation on WHO ladder, is it still relevant? Welcome, sir.
Good afternoon to my respected chairpersons. Good afternoon to the people who have come to listen. So I have been given a topic which is very old and cliche of a matter. WHO ladder, is it still relevant? Okay. So what is WHO ladder? We can call it WHO ladder. We can call it WHO analgesic ladder. You can call it by any name. It's a guideline for pain management developed by WHO in the year 1986. Remember the green one. It is for cancer pain relief. Okay? Remember this. It provides a 3-step approach to prescribing pain medications based on pain intensity, for starting with non-opioid analgesics, then gradually to mild opioid, then to strong opioids in the 3rd stage. As the pain intensity increases, it gradually increases. So this is one of the ladder. We have seen the stepwise ladder. I have board of it. So I've got this new picture. I hope you like this picture. Now, what are the key principles of the ladder? It is intensity based. That is given on the pain number. That is on the numeric rating scale. If the pain is severe, you start with the higher ladder. If it is moderate, you start from the middle point. At the level corresponding to the patient's pain. Adjuvants. Adjuvants have been mentioned in every step of the ladder, as you have seen in the ladder just now. So adjuvant is a very important part of this ladder. Mainly for neuropathic pain. So neuropathic pain is also included. Around the clock dosing. So you have to mention the time when you are giving the dose. And you have to cover it up for the 24 hours. You cannot say that BD or TDS. That is the most important part of using this ladder. You always write the time. Not BD, TDS or QDS. Oral route is preferred. So it is mainly to give the medication by oral route. By the individual. Dosing should be tailored to each patient's specific needs, recognizing that a standard dose is always not effective. So some dose may be effective for A, that dose may not be adequate for B. So according to patient, it has to be corrected by you. Constant concern for detail, that what is happening, whether the pain is decreased or not, how much it is decreased. So you have to regularly review the patient, constant detail for the patient. Distribution of medication over a day is established, ideal to provide a written personal program to the patient. That you have to take these analgesics or these adjuvants, you have to guide it and talk to the patient. And finally, the flexibility. Ladder is a guideline. Treatment can be adjusted based on patient's response. In some cases, severe pain, it may be appropriate to start at the top of the ladder. So there is no fixed rule. Previously, when it was just said, 1986, then it was said that you have to start from the bottom. Then it was modified a little bit, that you can start at any place, any step. Now let us talk about the history of the ladder. Why was it programmed? Part of a vast health program termed WHO Cancer Pain and Palliative Care Program. It was aimed at improving strategies for cancer pain management throughout educational campaigns, creating shared strategies and developing a global network of support. And the document was translated into 22 different languages. Okay, it was translated 22 different languages. Now I have highlighted some portions. Purpose of limited number of relatively inexpensive medications. The target was to give inexpensive medications to a large amount of people. Legitimize the use of opioids in treatment of cancer pain. So that people can argue that we have to give opioids, we have to purchase opioids. That was the main target, legitimize the use of opioids. Encourage numerous worldwide teaching campaigns on the use, benefits and side effects of narcotics in the treatment of pain. And this is the important part where the criticism will be deferred. Ladder emphasizes medication using the least invasive route possible. Oral ladder. Now evolution, as this ladder has been used, we have all the pain physicians are sitting here. So we use this ladder as a base. And thus the ladder has broader spectrum of diseases. Degenerative disorder, musculoskeletal disorder, neuropathic pain disorder. To all these conditions, we are using this ladder. And now comes the criticism. It is highlighted that the ladder oversimplifies the complex and individual nature of the pain, do not adequately address individual differences in pain tolerance or response to medication. I have said that you can start from the beginning or end. So I don't know how this comes, but it has been in various books and various articles, it has been written. Often difficult to accurately assess pain intensity when using the approach because it relies heavily on patient's self-reporting. Opioids are typically prescribed at step 2 of the ladder without considering potential risks associated with their use, such as addiction or overdose. In India, this doesn't come because we are not getting adequate opioids. So overdose in India is out of question. The Americans are using as an overdose. They are giving opioids in everything, in dental pain also. So there comes the problem of overdose or opioid abuse. Here it is not. Lack of evidence-based research to support its efficacy and effectiveness in providing adequate pain relief for cancer patients. Original model has been expanded to include a fourth step or other approaches that incorporate non-pharmacological methods, intervention therapies. Now let's see the models. This was modeled by this article, Mr. Yuan Yang and Italy. He prescribed the model chronic non-cancer pain. You see, we are used to the model, this right-sided model, where it is in the step 4, that is intervention pain comes at step 4. But he says that intervention pain should come at step 3. I think most of you were not aware of this model by chronic non-cancer pain model. So various models are there. We are awakened with this model step 4, where you give nerve blocks, epidural PCA pump. But someone is suggesting that it should be given a step 3. Then we go to strong opioids. See the fallacy. There's other models also. This is another model. These are given by the physiotherapists. They say, why should we not be included in the ladder? So they have given this model, acupuncture, massage, TENS, everywhere. First step, second step, third step, fourth stage. So they should give acupuncture, physiotherapy, occupational therapy, NSAID, everything in every step. So they want this model. And then Dr. Cuomo, he suggested this final model. I cannot make anything of this model. This is a trolley model. You can pick up any tray from the trolley and you can start from there. There's no end, no beginning, nothing. Whatever you feel, you can do. So there are 4 models, as you have seen, which have been proposed, and WHO has not accepted it. So these are the modifications. Psychological support, you can start from there. Intrathecal therapy, you can start from there. Non-opioids, you can start from there. Anywhere you can start. You open a drawer and start giving it, whatever you feel is needed. So what is the relevance of this WHO ladder? Most cancer pain accounts for one of the top 5 reason pain accounts. Most cancer pain can be treated effectively through progressive use of analgesic medications. Previously, it was shown that it has been used to control around 70 to 90% of pain in patients with cancer. But today, this percentage has been questioned. It has been brought down to 70 to 80%. 70 to 80% is a huge number. If we can decrease pain of 70% patients, that's a huge number, I think. So where is the non-relevance of this ladder? Fundamental concept that it is essential to have adequate knowledge about pain, to assess its degree in a patient through proper evaluation, to prescribe appropriate medications using least invasive route possible. So all the models, that interventions, that is not in the ladder. Ladder never said about invasive route. It said it should be for the least invasive route, mostly oral. As many patients will receive opioids, it's essential to balance the optimum dosage with side effects of the drug. Moreover, opioid rotation can be adopted. Patients should receive education about the uses and side effects of medications to avoid misuse or abuse without compromising benefits, and without complaining or criticizing or various giving so many models. Everyone has a model of his or her, 4, 5, 6, 7 models. I think the line should be WHO analgesic ladder remain a foundational treatment for chronic pain, upon which clinicians can add new modalities or societies can add new modalities, and they can follow that. So this should be a baseline upon which we can modify. Now, just a reminder, this step ladder model is only for cancer pain. As you can see at the top of it, freedom for cancer pain. It was made for cancer pain, no pain another. Not for chronic non-cancer pain. So whoever models have suggested, please remind it is for cancer pain, and we can modify on it. Now this is our sir. He used to say every time that morphine is the panacea for treatment of cancer pain, and never use opioids to treat chronic pain. If you are using opioids for chronic pain, you are not diagnosing the problem. You are not diagnosing. We should never use opioid for chronic pain, and this WHO ladder is only mainly focused on using opioids and how to use opioids, how to rotate opioids. So our Subroto Goswami, our revered said, this is a picture, and this is the 2 things he used to say always. So these are the references which I got this article form. I've formed it. And so my end statement is, more research is needed to better understand how this approach can be improved to provide effective and safe pain relief. Thank you. Thank you, organizers, for inviting me. Thank you.
Thank you, Dr. Jatua, for your nice presentation. We will take question after, at the end of the session.
Thank you, Devashish sir, for making us climbing the ladder again. Thank you so much, sir. Now, coming to the next session, I would like to invite Dr. Devdipta Das sir, who will be putting light on opioid rotation in cancer pain, when and how. Welcome, sir.
Very good afternoon to my respected chairpersons and my seniors, juniors, and colleagues. So today my topic is the opioid rotation in cancer pain and strategy. This is my medical college, the newly constructed medical college. This is a Jhargram Government Medical College. This is of age of only the 4 years. And I am doing here the Department of Anesthesiology and Pain Medicine. So why the opioid rotation is needed? Because there are lots of opioid drugs and mode of it is tablet form, transdermal form, IV form, subcutaneous form, every modes are available for a multiple of drugs. So proper guideline is needed to choose and to elevate the pain of the patient in a soothing manner. So understanding the cancer pain principle of opioid rotation, how it is rotated and why it is to be rotated, clinical implication, challenges obviously, and few recent advances. Now understanding the cancer pain, it is already discussed. This is the two types of pain, neuropathic and nociceptive pain mostly. Mostly covers the pain, opioids only cover the nociceptive pain and also the neuropathic pains with added of the adjuvants, and few opioids drug also capable of treating the neuropathic pain also. So why it is needed to be rotated? Because regarding the assessment and opioid tolerance, is the big things. That's why the opioid dose, if you use this in the single dose of opioid or single modes of drugs, so it getting the larger doses over the time. So you have to rotate to minimize the side effects and its drastic effect on the patient. So still the opioids are the main treatments in the cancer pain. It is no doubt, and it is already discussed by Dr. Jatua sir. It is the WHO step ladder and the National Comprehensive Cancer Network guideline also opioid and opioid. So proper management with the opioids is very much needed. See, it is already discussed. I'm not getting into details. So these are the drugs. If you see, the lots of drugs are there. Lots of drugs, and all the drugs have multiple doses. If in tablet form, it may be in IV form, in transdermal form, or in subcutaneous form. Almost multiple modes of can be taken. So proper guidelines would be there, and proper way of rotating from one opioids to another opioid is necessary. And no doubt the morphine is the drug, the mother drugs of the opioid for cancer pain. And it is now the principles. Because opioid rotation is the change of opioid drugs or route of administration with the goal of improving outcome. It may be due to the intolerable adverse effect, due to the poor analgesic efficacy, or due to drug-to-drug interactions, or patient may be not able to take the one route, also the another route is to be given. The clinical status of the patient with the multiple comorbidities may be occurred, different pharmacokinetics, and the drug bioavailability. Because in few the remote areas, maybe the morphine drugs, morphine oral tablet may be not be available. So you have to convert to the transdermal patch or buprenorphine patch. So availability of the opioid drug is very important in the developing countries like the India. So clinical implementation. Two important terminologies is the morphine equivalent dose and the morphine equivalent daily dose. These to be priorly to be noted because before the going into details of the opioid rotation. So MED is the clinical tool used to convert a patient's opioid regimen into an oral morphine equivalent. So what is equivalent? The equivalence conversion factor I am going into later. And MEDD is the MED into the medication strength per unit with the conversion factor, equivalence conversion factor. These two terminology will come into the every part if you start opioid rotation. So here this is the opioid rotation, has is the role of the equianalgesic tables. Tolerance has to be considered, cross tolerance has to be considered. So before changing to the another opioid, so cross tolerance, due to cross tolerance, the doses should be decreased. It is a factor. Now have some mathematics, because this is the what is the answer of this? Because this answer is to use the cross tolerance and decrease the dose. And another is a very easy question. And this is one other equation. What is the role of what is the value of x? It takes time. Okay, I'm not going into the, don't waste time. So this is, before going into details, the basic is the morphine titration. Is everyone will about it. Okay, it is the American Cancer Society is all commonly we are doing 2 mg or 2 mg IV every 2 minutes. It is short duration of time, either 4 or 6 hours, and it is to be multiplied into the factors for calculating the 24 hours IV morphine. And when the 24 hours IV morphine we have get, will be converted to the 1:2 or 1:3 ratio to get the actual opioid tablet doses requirement, oral morphine requirement for the patient. This is the way I can evaluate the patient's morphine requirement for starting a morphine for the patient. This is a very common article and very most cited article from, it is from where the opioid equivalence chart is mentioned. And after it, almost lots of modification has been done. And very recent modification is that, it is 2025. This is the equivalent opioid dose conversion chart. And using it, we can use from one opioid to another opioid. How? I can see. So this is the formula, and this is the formula when the mathematical equation has been given. So this is the equation as the cross tolerance has to be decreased by 30 to 40%, and the breakthrough pain dose have to be decided. The total 24 hours dose by 10 to 20% has to be prescribed as a breakthrough pain. Let's say example, this is a conversion from morphine dose from the morphine to fentanyl patch. So this is the conversion, and how will you goes into the what morphine transdermal patch requirement for the patient. If we ease the equation, we can go into the details of a simple chart. So if a person having the oral morphine of 30 to 90, straightforward, you can give the transdermal fentanyl patch of 25 and so on to say 50, 70 and 100 microgram patch also. Now, for after fentanyl, another important drug and very discussed drug is the methadone. Methadone is a very unique drug because methadone has a capability to handle both the neuropathic and nociceptive pain. That's why this is the beauty. But apart from the beauty, has a black part also, because it will be very cautious. Because for using a methadone, proper clinical knowledge to be taken and proper pain clinician to be prescribed the methadone. Not everyone else can use the methadone, because in COPD patient or having the alcohol, methadone has to be cautious. And very important, the prolonged QTC. If the patient having the prolonged QTC, it should not be used. And methadone conversion table is unique because if we see the equianalgesic table, there is a linear model, from fentanyl to opiocodeine to morphine, hydromorphone, all, but this is not a linear. If you see, if the morphine equivalent dose, morphine daily dose is less than 30, the conversion ratio is 2:1. Apart from if the morphine requirement is almost 300 to 500, the equivalent morphine conversion ratio goes up to the 12:1. So this is not a linear. That's why the morphine to methadone or methadone switching is very, very critical and should be used in very cautious. So selecting the opioid alternatives, the patient factors to be considered, pharmacological property, and common alternative opioids which we have the options, because all of the opioid option you have not got the option to use it. So how to change from one opioid to another opioid? The common studies are there. This is the common stop and go or rapid conversion technique. Here, if this two study is doing same things already, so the morphine to methadone. Abrupt discontinues the first line and 3 identical dose at 8 hours interval. This is the rapid conversion technique. This is the progressive method, dose same as the previous one, but first line opioid given at the 50% of first line opioid, not stop abruptly here. Because here it is given 50% of the previous dose on day 1, 25% on day 2. That's why on the 3rd day it will stop. So abrupt stop, we're not giving the first line of opioid here. That is the difference. This is the 3-day switch. Here, this study the morphine to methadone. If the MEDD is less than 300, same the conversion 10:1, and if more than 12:1. And it is reduced, first line opioid should be reduced by 1/3, and the next replaced by 1/3 of the equivalent of methadone. So simultaneously first line and second line both are to be simultaneously started. This is the German model also. It is to be again abrupt discontinue 5 to 10 ml methadone every 4 hours till 72 hours. And this is the another methods. I'm not going into details. This is the another methods also. This is also method, and outpatient titration as another method. There is a 3 guidelines: EAPC, European Association of Palliative Care, American Society of Clinical Oncology, and ESMO, European Society of Medical Oncology. These will prescribe, these are the common guidelines before doing into the opioid rotation. This is already discussed, and this is giving in a nutshell. Few studies, opioid switching for this has used the morphine as the first line. Inadequate pain control and intolerable side effects. This is a very good level. This is also improvement in the sees in improvement in 50% cases, with time of dose stabilization takes around median 3 days. And this study also 50 to 80% success rate, dose stabilization from 2 to 5 days, and evidence is lacking on rotation. It is a 6/10 Amster. This study giving the rote of buprenorphine patch from fentanyl or morphine. This is displayed 1:1.3 or 75:1. This is already discussed, and already these are the studies for in opioid rotation. I'm not going into details. These are the challenges already discussed. Dose titration, supportive care has to be simultaneously performed, close patient observation, dose titration needed. Patient-specific factor, obviously, in the cancer patient in the late stage, the cognitive status, age consideration, and multiple medical comorbidities to be considered. And this is the monitoring. This is the emerging therapy. It has to be headed by the adjuvant therapies and targeted therapies. So in conclusions, these are my already discussed, not going to waste of time. And thank you for organizing the ICRAPAIN, for giving me the opportunity to discuss a very good topic, vast topic. And lastly, I'm discussing the Save the Date 13th and 14th December this year, because my medical college, Jharkhand Government Medical College, will going to host the state conference of this is the WBSSP Con on 13th and 14th December. So registration already started, and if you scan the QR code or this is website, if you get the brochure and the registration link. Thank you.
Thank you, Das. So after step ladder, this is rotation of opioids. So next topic, the question answer session will be after that.
Thank you, Dr. Das, for your informative and comprehensive presentation. Now, please join me in welcoming Dr. Manish Day, a renowned pain physician with expertise in interventional cancer pain management. And he will give lecture on when to think of interventions in cancer pain. Welcome, sir.
Good afternoon, everyone. Thanks to the organizers for giving me the opportunity to present this topic. So my topic is on when to think of interventions in cancer pain. So I will just discuss three cases and then come to the basic discussion and then what to do in those three cases and what can you think of. So first is a 63-year male patient complained of severe burning pain around the perineal region, along with inability to sit properly for the last 6 months, received 5 cycles of palliative radiotherapy, but he has been diagnosed, after being diagnosed with locally advanced anorectal malignancy, which is not treatable surgically. So he didn't have much pain relief. All conservative treatment have failed to reduce his suffering, including the opioids, morphine, that as per the WHO pain scale, pain ladder. So case 2 is a 35-year-old female who is having gallbladder malignancy with liver and peritoneal mets, along with severe abdominal pain in the epigastric region and ascites in the last 4 months. Pain is not relieved with morphine, 200 milligrams per day. And she has been transferred to palliative care for further management and with a life expectancy around of 1 to 2 months. And third patient is a 43-year male who is complained of abdominal pain of severe intensity with radiation to back, unable to lie supine, which aggravates his pain. Sleep is disturbed, and he is diagnosed with a metastatic pancreatic cancer with poor prognosis. He has been started with chemotherapy, palliative chemotherapy with additional morphine and adjuvant analgesics, but his health deteriorated without much reduction of his pain and suffering. So pain is what the patient says hurts. So that is what pain is. The definition is already discussed everywhere. It's a somatopsychic phenomenon. It's modulated by mood and morale of the patient, and the meaning of pain to the patient himself. And the classification is neuropathic and nociceptive, and the mixed pain. These are the types of mixed pain we have: bone pain, critical limb ischemia, and cancer pain. So here, for our discussion, is cancer pain is a mixed pain, and it's ongoing tissue destruction. And there is cancer-related. It may be post-surgery, it may be post-chemotherapy, it may be post-radiotherapy as well. And from the types, it may be visceral, musculoskeletal, neuropathic, or a combination of the three. So for persistent pain, the meaning of persistent pain in cancer is, I'm incurable, I'm going to die. So this is the patient's own version of the cancer pain patient who suffer from this deadly disease. So this is the intensity of pain as per rated by WHO. According to the WHO pain ladder, this has already been discussed. I will come to that. So cancer pain is actually happens in 55% during treatment, 40% after curative, and 66% in the late stages. 38% of all cancer patients have moderate to severe pain. And WHO letter has been effective in 70 to 80% of patients, as mentioned by Dr. Jatua, and inadequate analgesia is seen in 10 to 30% of cases, for which the 4th step was proposed, and that is the interventions. So, and this is the central theme of any cancer pain patients, which is including physical, psychological, social, and spiritual part of pain, and this should be taken in account in every case of cancer pain management. And this is the way we approach the patients, that what is the need of adjuvants in addition to morphine, need of interventions in some specific scenarios, and need of a good night's sleep. That's what we want to do to reduce the pain. So we educate the patient, then manage the patient by relieving at night, relieving at rest during the day, and relieving on movement. And so what is interventional pain management? So this is defined by the discipline of medicine, which is devoted to the diagnosis and treatment of pain and its related disorders, so application of interventional techniques to manage acute, chronic, persistent, intractable pain. And these include minimally invasive procedures by percutaneous precision needle-guided placement of drugs in targeted areas, along with some surgical techniques like endoscopic discectomy, intrathecal infusion pumps, and spinal cord stimulators. So the indications, the topic of the day today, that is when we'll do for interventions in cancer pain, what have been stated. So cancer pain is refractory to traditional opioid pain management. Patients having significant dose-related opioid side effects like constipation, nausea, vomiting, coexisting comorbidities, precluding the use of opioids like opioid abuse disorders, and those patients who had prior benefit with specific interventional procedures for pain management. And these are the procedures what we can do for cancer patients, like musculoskeletal pain procedures like trigger point injections, epidural steroid injections, middle branch blocks, intercostal nerve block and neurolysis, vertebral augmentation, procedures for visceral pain, and urexular analgesia. And when we'll not do, so this is the same for all the pain procedures: coagulopathy, thrombocytopenia, local infections, systemic infections, severe allergy to contrast agents, and tumor presence in the procedural pathway, risking further tumor seeding. And also there are few contraindications which we see practically. These are theoretically, which is seen. So these are the interventions: celiac plexus, superior hypogastric plexus, and ganglion impaired block. And it's already been discussed: celiac plexus for upper abdominal pain, superior hypogastric for lower abdominal, or pelvic and perineal pain, we go for ganglion impaired. And these are the recommendations. That is level 1 evidence and grade A recommendation for neurolytic celiac plexus block for pancreatic cancer, and epidural intrathecal opioid infusions for refractory cancer pain. And again, this is a strong and moderate grade of recommendation for celiac plexus neurolysis and splanchnic plexus blocks. These are all in researches found in studies. So for case 1, coming to the practical scenarios now, when we deal with patients after going through the theory and the researches. So first patient, we went for a diagnostic block, first the ganglion impaired, who was suffering from severe perineal pain, unable to sit. And after that, the patient has a good pain relief. He was able to sit and do his daily activities, and we went for a diagnostic block first, and then the next injection, we go for a steroid. So RF can be an option for ganglion impaired who have positive responses to diagnostic ganglion impaired blocks. So for this patient, we selected for the intervention based on the aspect that he had that functional disability of inability to sit, even after adequate dose of radiotherapy and available treatments were given. So functional ability, what we targeted in this patient. For second patient, so do we go for the celiac plexus block or not? So this was the question. The patient had a life expectancy of 1 to 2 months, and he has severe ascites, and he had deteriorating health condition along with palliative chemotherapy. So we don't want to go for any kind of intervention for these kind of patients. So this is the practical scenario, which is not mentioned in the books. We have to assess patient-to-patient basis. And third patient who had severe pain, which is refractory to the, and also one thing I forgot to mention, there's the last patient. We have to go for the total pain, as we see for all patients. For total pain, if the patient is not having pain relief by 200 milligram morphine in the previous case, and in those cases, we have to explore the psychological, the social, the spiritual reasons, and we have to treat accordingly. Otherwise, the pain will still be refractory. We have to give pain relief even the patient has a life expectancy of 1 to 2 months. And third patient is a fluoroscopy guided. We went for a fluoroscopy guided celiac plexus block and neurolysis, because that patient had good life, around life expectancy of more than 6 months, but he had again the functional disability. He's not able to do his daily activities, so suffering from pain. So the pain itself, the percentage was reduced around 50 to 60%, but the suffering went a lot. The suffering, the patient was unable to lie down supine, and then not able to walk and everything. So those areas we focused on and gave the celiac plexus neurolysis with good results. So for this patient, we went for that. And again, this similar patient can be done under ultrasound guidance, but I'm more comfortable with the CRM guided procedure for celiac plexus. And for ultrasound guided procedure can also be done depending on the patient can be lying, able to lie prone, or the patient is not having that much ascites. In those cases, we can go for ultrasound guided as well. So what are the limitations? Why the overall pain interventions in cancer pain is low in number overall compared to non-cancer pain? This is the main reasons. That is increased cost. First of all, the patient has already been spent a lot on the aspects of the radiotherapy, chemotherapy, surgery itself. And the dynamic nature of pain, the patient's cancer pain itself is a huge burden, both on social and the psychological aspects, and the poor performance status, and patients receiving chemotherapy. And in the same time, it should not be used as a last resort after multiple failed attempts at opioid therapy, and it should be an integral part of the management, which includes medical, psychological, supportive care, and it's a holistic approach. We have to approach the patient and see what is the more dominating nature of the pain. Is it the physical, is it the psychological, is it the social, and what are the functional ability, and what is the life expectancy of the patient. So all these things have to be considered. And coming to the conclusion, it's a multidisciplinary approach. It should be done after discussion with the medical oncologist and the radiation oncologist and the surgical oncologist as well, and to identify the source and mechanism of pain, appropriate patient selection for the proposed intervention, very important, discussion of the risk and the benefit and the overall prognosis. And the goal is not to eliminate the systemic use of the analgesics, rather to serve as a part of the comprehensive approach. After an intervention, the dose of morphine suddenly doesn't come down drastically. You have to gradually taper down, but yes, it is a comprehensive approach. It's not the only approach that will remove all other medicines that the patient was already on. And the target is basically the patient's satisfaction with the quality of life. What is the patient is unable to do? What is the suffering that he is being complaining of? That is the main part, rather than only the intensity of pain that we focus as per the WHO pain ladder and the interventions. So this is the, thank you. Thank you.
Thank you, Dr. Day. We will take question after at the end of the session.
Thank you, Dr. Day, for that insightful session. Now I am honored to introduce Dr. Amit Dua, Professor and HOD, Guwahati Hospital, an interventional pain management expert. Please welcome Dr. Dua to the dais for his presentation on ganglion impar block. Welcome, sir.
At the outset, I thank the ICRA team and the chairpersons for inviting me here. I'm Colonel Amit Dua. I'm HOD anesthesia and a pain physician at 151 Base Hospital, Guwahati. Greetings from my hospital to everybody. We know we are at the fag end of the cancer pain session, but I still feel one of the most important sessions is cancer pain, always. For a chronic pain physician or a palliative care physician, we need to manage cancer pain. A lot of my part has already been covered by previous speakers, so I'll be talking very relevant things. So where did the name ganglion impar come from? Ganglion, we know, is a group of neurons or neuronal cell bodies in the peripheral nervous system, and impar is a Latin word which means unpaired or azygous. So it very clearly says that it's the only unpaired sympathetic ganglia of our body. And another name of it is Walther's ganglia, because it was first described by Dr. John Jacob Walther in the 18th century. He was a German anatomist. So the location, as I already said, it's a large sympathetic ganglia formed by the fusion of the two prevertebral sympathetic chains. It lies ventral to the sacrococcygeal junction or in front of first or second coccygeal vertebra. The location can vary. The size is very small, just 4 mm. That is why we tend to miss it many times during our interventions, and it's lying in the retroperitoneal space. So the contents, the efferents are somatic and sympathetic nerve fibers from the perineum, rectum, and genitalia, and the efferents, being a sympathetic ganglia, the efferents are purely sympathetic and nociceptive, because nociceptive fibers are being carried by sympathetic ganglia or the sympathetic fibers here, and they supply to the perineum, anal region, and the internal pelvic organs. Somatic efferents to the same efferents, to the same areas also go via this, but they don't stay there. So it is mainly a purely sympathetic ganglia which supplies the perineal organs and the genitalia. So it is very, very important to understand this part of the anatomy and a little bit of the autonomic nervous system before we actually go into doing this block. The block is actually not very difficult, but to understand the anatomy and physiology of ganglion impar is more important than the block itself. Then we have a higher chance of success. So why do we do a ganglion impar block? To alleviate the chronic and cancer sympathetic mediated pain caused in the same regions where it supplies. The drugs which we can use, local anesthetic and steroids, we can use radiofrequency ablation, and we can do neurolysis. Since we are talking about cancer pain here, I'll be talking more about radiofrequency ablation and neurolysis. Actually, neurolysis is something which we need to do when it comes to cancer pain. Contraindications, we all know, local or systemic infections, coagulopathy, distorted anatomy. So the two most common approaches, there are many, many approaches which have been said in the literature, but the most common approaches are the lateral or the transsacrococcygeal approach. The lateral approach was described by Plancarte in 1990. And it's a very interesting approach. Patient lies in the left or a lateral decubitus position. A 22 gauge 3.5 inch needle is bent 25 to 30 degrees, as shown in the pictures next to it. You infiltrate the coccyx with local anesthetic, go through the anococcygeal ligament, and you place your C-arm in a PA position to the table. Insert the needle anterior to the coccyx through the anococcygeal ligament. You can see in the picture below The needle is coming through the anococcygeal ligament and comes to the anterior side of the sacrococcygeal junction. The concavity is posteriorly till it reaches the sacrococcygeal junction retroperitoneally. Then you give the dye, confirm your position, and once you're there, you can give the drug. The issues very commonly and very obviously seen is that you can penetrate the rectum or the anal canal, and it is said to be safe. The one finger should be in the anal canal just to make sure you do not penetrate it. So it is something which is not used very often nowadays because there's a much easier technique available, much easier, much faster technique available, which I'll be talking about. So now coming to the transsacrococcygeal approach, which was described by Wem and Sebersky in 1995. Very simple, very effective approach, very rare to miss it. Patient is in prone position, C-arm is in AP. We mark the sacrococcygeal junction and the midline. Very, very important step. Many a times we feel that the ganglion impar block is done only in lateral position, but before we turn the C-arm lateral, we must make sure that we have identified the midline. So that is why this picture shows that the person performing the block is making sure that he is in the midline. Then you turn the C-arm laterally, infiltrate the skin over the sacrococcygeal junction, bend the needle 10 to 15 degrees just to make sure that if your point of entry is little away from your target, you don't have to come back to the skin again. You can just manipulate your needle while you're still inside, and you can do a successful block. So these are the 3 steps. Usually we enter through the sacrococcygeal junction. There are usually ligaments, posterior and anterior sacrococcygeal ligaments. You need to pierce both of them, and you need to, the moment you enter anteriorly, you need to stop there because you want to prevent entering into the rectum. The moment you come here, you give some amount of dye. Reverse comma sign is a very commonly used term for this. You make sure again in the AP view that you are bang in the midline. You can see here, I have taken the AP view and my dye spread is bang in the midline. Only once I'm sure of this will I give my drug. So for a diagnostic block, you can give a local anesthetic or a steroid. When you have to go for a neurolytic block, you can use phenol, you can use alcohol, depending upon what is available to you and what you are comfortable with. Coming to radiofrequency ablation, not very frequently used for cancer pain, but yes, for chronic pains, you do want to use radiofrequency ablation. Many a times people combine RF ablation along with neurolysis with chemical neurolysis. So in the RF ablation, you have to go through sacrococcygeal junction the way we were doing with one single needle, and another needle is passed either between S5 and S4 and S5 or between C1 and C2, whichever space is better and wherever you are comfortable anatomically. Once you pass the needles, you confirm again with the, make sure that you are in the midline, confirm with the dye spread, and then you can do a conventional radiofrequency. You can go up to 70 to 80 degrees for 90 seconds and do a neurolysis there. So these are the usual techniques. So now coming back to the anatomy part, if you know ganglion impar is a purely sympathetic ganglia, and we do not have any gray rami communicantis coming there. Very, very important points needs to be understood. Last half a minute I'll spend upon them. The last gray rami communicantis starts from L2 and ends at superior hypogastric ganglion. So many a times, even after doing a ganglion impar block, the patient may still have some residual pain. That is when people recommend that along with ganglion impar, it is a good idea to do a superior hypogastric block also, because the gray rami have ended there. It is only the white rami which are, the white rami have ended there, only the gray rami, which is the postganglionic fibers, are the ones which are coming to the ganglion impar. So we might miss a little bit of the sympathetic supply, which is coming from the L2 level if we don't do the superior hypogastric block. So in cancer pain, many times it is recommended that you should combine the ganglion impar block with the superior hypogastric block. It is really handy and it is very effective. I have finished. Any questions, I'll be happy to answer. Thank you.
Thank you, sir. Questions we will take at the end of sessions.
Thank you, Dua sir. That was an excellent lecture. Now we'll move on to our next session. Dr. Abhiroop Naik, a pain specialist with a focus on chronic pain, cancer pain, and MSK ultrasound. He will focus on stellate ganglion block in post-mastectomy lymphedema. Welcome, sir.
At the outset, I'd like to thank the organizers for giving me this opportunity, and with permission of the chairpersons, I'll start my presentation. Okay, so mine is a stellate ganglion block in the post-mastectomy lymphedema. So, and I'll be covering all these topics. So, I'll present a case where a 60-year-old female who actually presented at the OPD with a right upper limb pain and edema, and she gave an history of this right-sided modified radical mastectomy, and there was an axillary lymph node dissection. And after all the pharmacotherapies and physical therapies, like the conventional ones, there was not much improvement. So with the history and all, we come to a diagnosis of post-mastectomy lymphedema in this patient who had a history of breast cancer. So for this breast cancer, the incidence, there are 1.7 million new cases getting added every year, and the post-mastectomy pain syndrome occurs in around 25 to 60% of these patients. And also breast cancer related lymphedema has an incidence of around 20% among these breast cancer survivors. And the risk is much higher where the lymph node dissection is being done rather than where the sentinel lymph node biopsies are done. So this is just an image showing the lymphatic drainage throughout the body, and this is particularly the lymphatic drainage from the upper limb to the area where the things are affected due to surgery during the breast cancer surgery. So what's the pathophysiology of causing all this lymphedema? Here, because of the surgery, the lymphatic system is compromised, right? So the interstitial fluid transportation to the blood, this gets reduced, the lymph gets static there, and the protein accumulates within the interstitium. This leads to the increased colloid osmotic pressure, and the fluid is driven into the interstitium. And this actually leads to all this inflammation and adipose tissue hypertrophy, the fibrosis, the indurations and disfigurements, and this leads to the clinical symptoms of lymphedema. This is also the same thing, which is a diagrammatic representation of the here. There's a disruption of this lymphatic drainage. So this is a picture of one such patient who presented with this pitting edema in the arms. And so there the patients, they present with arm fullness, inflammation, and reduced range of motion, skin changes, and also not only the physical part, but the psychological part is affected. They get depression, the social isolation, and lowered quality of life. So the treatment should be holistic. And we also do this lymphoscintigraphy test where we can see, this is done to judge the state of the lymphatic system and predict the prognosis. They see whether there's delayed, asymptomatic or absent visualization of lymph nodes and whether there's presence of any dermal backflow. This is just a representation of that. And here we show how we actually measure. We actually measure 10 centimeters above and below the elbow crease and compare it with the contralateral side. So this is there are stages of the lymphedema. There are 4 stages: latent, early, moderate, and severe. And all these patients, they are given a lymphedema breast cancer questionnaire, where there are 18 questions, each having scoring of 0 or 1, either yes or no. So this helps in the evaluation of the patient and her conditions. So treatment options, the conventional ones are the complex decongestive therapies, the manual drainage of the lymph, and also the compression bandage, the pneumatic compressions, pharmacotherapy, and also there are surgical treatments. Now our discussion is regarding stellate ganglion block. And this is just a few images of the manual lymphatic drainage and the bandagings. So there are a few literatures showing the effectiveness of the stellate ganglion block for this breast cancer related lymphedema, but the mechanisms are not quite clear. However, the stellate ganglion can actually auto-regulate this peripheral lymphatic vessels. The collecting lymphatic vessels, they are actually innervated by the sympathetic and parasympathetic nerve fibers. So whenever the sympathetic nerve fibers in the collecting nerve vessels, lymphatic vessels, they release these neurotransmitters which actually cause the contraction of these lymphatic vessels.
So whenever we give this stellate ganglion block, it causes the relaxation of the veins and thus leads to the accumulation of the interstitial fluid to be released into the venous system. And also, whenever the opioids, whenever the corticosteroids are added, that can actually help in the immune modulation. There are a few literatures. Actually, Swedberg first introduced this stellate ganglion block therapy for lymphedema, and there's Kim et al. Who showed that the volume of the affected arm is reduced after 3 consecutive doses of such stellate ganglion block, which they use 4 ml of 1% lidocaine and 1 ml of, that is 40 milligram of triamcinolone. Then also Chow et al. In their studies, they revealed this thoracic sympathetic block in patients of this lymphedema. They may be effective in decreasing the arm circumference. Further studies where the Kim et al. They showed the decrease in circumference of patients where the cervical stellate ganglion block is used. And Park et al. They also showed that the 3 consecutive stellate ganglion blocks when given for these patients, they have their effects, and there are more effect when there is addition of corticosteroids. They actually finalized that around 4 ml of 0.5% bupivacaine when mixed with 40 milligram of triamcinolone, that gave the good effect. Further studies by Hardy, they showed that stellate ganglion block was given but did not give adequate dermatosympathetic because of the Kunz fibers. The effect was not adequate. So need to keep this in mind, because whenever the T2 and the T3 nerves, they get their fibers attached to the brachial plexus, the effect might not be as desired. And also further studies where they showed Park et al. They showed that stellate ganglion block is as effective as the conventional therapy and can be an alternative to that. So coming to the anatomy, this is the depiction of this stellate ganglion, where the sympathetic part of the sympathetic chain, basically the inferior cervical ganglion and the thoracic, first thoracic ganglion, they combine together to form this. If I may, so it is actually formed in front of the C7 and the T1 vertebral bodies, formed by the fusion of the inferior cervical and the thoracic ganglions. And then it also lies in close proximity to the longus colli muscle. Here this is longus colli, and if when we show it, this will be the stellate ganglion. Yeah, this is the stellate ganglion. Okay. And also the stellate ganglion is in close proximity with various neuromuscular structures, vascular structures also. So here it's also in close relation to the vertebral artery and the vertebral veins. So just a cross section of the same thing. So here we have the longus colli muscle. This is a cross section at the C6 vertebra, and the sympathetic plexus just lies in front of that, below this fascial plane, and we have all these neurovascular structures around it, which are important. So how to give the block? Earlier people used to do it blind, then came the era of fluoroscopy, then the ultrasound. Now we can also use this hybrid technique when combine the best of both these worlds. Okay. And so indications other than this, we are also used for the various kinds of pains, vascular insufficiencies, refractory ventricular arrhythmias and all. Contraindications like all other, like coagulation disorder, pneumothorax or pneumonectomy of the contralateral side, and several other relative contraindications are also there. For USG, we need the ultrasound and the drugs, and there's a position. This is not a female, but this is for any other stellate ganglion block. So supine with neck extended and head turned towards the contralateral side. The USG guided needle entry from lateral to medial. Again a cross section where the USG probe is placed there, and the image is here. It's depicted with. Important is the C6 and the C7. So C7, there's anterior and posterior tubercles. The vertebral vessels are protected, but C7, since the anterior tubercle is not there, the vessels are exposed, and we need to be cautious. So same thing, just So here we see that this needle is entering, this is at the level of the C7 vertebra, right? So this is the colli, this is the sympathetic plexus. We have our exposed vertebral arteries and veins there. We come lateral to medial. This is the needle and we start injecting the drug, gradually increasing drug volume as depicted here. Okay. So for the C-arm, when we use a fluoroscopy, patient lying supine, the AP and lateral views, we see the needle positioning. And we use this radiopaque dye to confirm the positioning where the spread of the dye will be along the fascial plane. The complications or the maybe Horner syndrome, not a complication but a side effect which actually shows whether the block is at the right position or not. Other than that, because of the numerous neuromuscular structures, hematoma.
Isn't there any, have you encountered
No,
this
no,
the chemical discitis?
No, I have not encountered never discitis or any inflammation to the disc, because the precaution which I was taking, that before removing the needle, I used to wash the needle with normal saline or Gylocard, 2% Gylocard.
Okay, but will it not dilute the alcohol then?
Pardon?
Will it not dilute the alcohol to celiac plexus? If you are washing, like if you are injecting, you are using already 70% alcohol, and then
I am using 100% absolute alcohol, so I can dilute with 5 ml of this Gylocard. Because if you are giving the alcohol so much concentrated form, there is intense pain in the abdomen.
Yeah.
So initially, I used to give 5 ml this Gylocard initially. Then after that, after some times, means within minutes, I put the alcohol. So there is no pain.
Okay, and then you again infiltrate normal saline.
Yeah, to washing the needle, this is very important step, to wash the needle before removing the needle, because you are coming through the disc.
Yeah, thank you.
I have a question for Dr. Devadipta Das. You mentioned rapid titration.
Yes.
Do you practice that? I mean, to all, in fact. Do you practice rapid titration?
No, rapid titration is not practiced. Especially one-third, stop one-third and previous for consecutive 3 days. We commonly, in our setup, in my setup, we commonly another 3 days.
You go for
setup.
only oral titration.
Oral.
Okay. Another question to Dr. Jatua and Dr. De, that you both mentioned WHO ladder and intervention. So what you do in real life?
Okay, now this is a very important question. Tata Medical has recently published a book of 1,500 cases. They have tried to give block to them. They could give block cancer patients, only 2 to 3 patients. And we have been trying to give block to cancer patients, ganglion impaired block, celiac plexus block. For the last 6 months, I have enrolled 40 patients, of whom only 6 patients have turned up for the block. After getting morphine, they generally say, we are very happy. We do not want anything block, any more injections within us. We have got so much injections during chemotherapy. We don't want, sir, any more injections. Give us morphine. We are very happy with that. So that is the practical thing which I have seen. Now, Dr. Monish.
Dr. Dua, in your setup, do you find that this WHO ladder?
I do use WHO step ladder, ma'am, as they are saying that you usually use conservative management first, unless the pain is very severe that you can't do without, like a pancreatic pain. They say celiac plexus block sometimes can be the first modality of treatment. Ultrasound guided celiac plexus block in many institutes is done as an OPD procedure nowadays. If the patient presents to you with very severe pain, then you go on to step 4 first and then come back to step 1 or 2. But in most of the cases, since the cancer pain will take time to get into that severity mode, you start off with morphine If the patient is happy with morphine, you don't need to do intervention. It all depends upon the severity of pain. This is what is my take on it.
Now, I have a question for Dr. Naik. Dr. Naik, at what stage of lymphedema, in which stage do you offer delayed ganglion block to the patient?
So basically, in our institute also, any post-mastectomy patient, when they come, we generally go with the conventional therapy like bandaging techniques or the manual lymph drainage. But then if it is around, the patient is not comfortable with the pain, not happy, irrespective, it is maybe subjective also. Even with that, even in stage 1, stage 2, whatever be the stage, if the patient demands it, if it comes from the patient, yes, we are happy to go, ready to go with the intervention, we do it. It needs to come from the patient.
And the studies that you have presented,
yes.
Have they combined the conventional methods also along with delayed ganglion?
One study did. They compared both and showed both are equally effective. That's what they showed. The circumference reduction.
They have compared, but
compared.
have they combined both of them?
They have not combined it, but then yes, that's obviously a prospective that can be done.
So delayed ganglion block as a monotherapy may not be effective, isn't it?
I'm not recommending that also. It's only when they are asking for it if they're not happy. Anyways, we'll go for the conservative only. Since this is an intervention, it must come from the patient that I need the intervention.
Something more.
We can't impose that on the patient.
Thank you.
Dr. Apirup, I want to ask you, so when you give this delayed ganglion block, you counsel them that they may need repeated sessions, because the study said they gave 3 blocks,
yes,
after
definitely.
which they started feeling better.
Definitely. All studies have shown that day 0, 2 weeks, 4 weeks, so the 3 blocks needs to be given and they are counseled.
And only after the 3rd block you start seeing some...
No, studies have also showed if we are adding corticosteroids, even after at this point of the 2nd injection, there are improvements.
So after the 2nd block, you start seeing improvement, and the improvement is in the form of reduction in the circumference of the arm. Okay, and once you give all these 3 blocks, they are comfortable for how long?
So as of now, the follow-ups that the very little follow-ups that we have, I have as of now up to 6 months. They're happy with it.
And they wear that sleeve, that tight bandage.
They do that. The conservative part is going on.
Okay, thanks.
Thank you.
Yeah, continuing with the same, repeated stellate ganglion or thoracic RF?
Thoracic RF is a higher category, like more greater intervention.
Yeah, but if you consider cost effectiveness, then repeated stellate will be more costlier. If we consider complications or side effect of the procedure, the more number of times you are putting the needle into the patient, more chance of side effects and complication.
Yes.
So what's your take on that?
So I have not personally given any sympathetic thoracic T2, T3.
Okay, because in my practice, what I regularly do is instead of going with repeated stellate, I prefer thoracic RF, but it has fair chance of failure. Like diagnostic intervention might not work in at least 20-30% cases in my patients.
So what's your call? You go for thoracic only?
I prefer thoracic. If thoracic doesn't work, I might try stellate ganglion, but chance that if T2, T3 doesn't work, then SGB might not work.
Right. Okay. No, not required. Either.
I prefer thoracic. If for some condition it is not possible, then I go for
It is all depend on the practice, who practice that.
It's about your skills and expertise. Somebody might be more experienced with stellate, somebody might be with T2, T3.
Regarding the guidelines, I think the guidelines is just to say that this is the method, you have to follow it. But you have to make tailor-made according to the patient. It's not hard and fast that you should use the ladder and that for the treating the patient. It is up to you how much you have to use, how you have to something add to that. And next, just addition to all those who are giving celiac plexus, transdiscal, prone position, supine position. There is one, since I am in a corporate, we have endoscopists. So they are preferring, if it's a failure to do all the procedure with the transdiscal are there, then endoscopy guided celiac plexus is wonderful. It's give a better idea and visualization of celiac plexus. So if it's not proper from your side, you can refer that patient to endoscopy. That's my message. Thank you.
One question for Dr. Day, sorry. So like the CA pancreas case, which usually come, they are kind of having the very low expectancy at that stage. Sometimes the oncologist or someone brings the case to us, and everything has been tried. They are like emotionally deranged also, and financially also they are in their last stages. And coagulopathy would have already set in. It's not possible to do a celiac plexus block for them. What is the protocol you follow? Often I go for a patch or something like that because they don't want to come anymore to the hospital setting. What is the principle you usually follow when only 1 or 2 months expectancy is there?
So it's all about the pain intensity, the functional disability, and what is our target. So whenever a patient comes with CA pancreas with all these comorbidities, coagulopathy, severe disability, so we have to assess 2 things. One is the ECOG performance status, and another is the WHO pain ladder. And as per the pain ladder and the performance status, we have to titrate. We have to give the actual medicines, that is starting from the paracetamol, then the atropines, then the morphine. And if morphine have some availability issues, yes, we can go for a buprenorphine patch, but again, that is not that much effective compared to morphine. So we always prefer a WHO pain ladder approach along with the ECOG performance status for any intervention.
So there's also another scale called palliative performance scale. So if you follow that scale, you're saying 1 to 2 months, you can exactly almost 90% know, say, what is the life expectancy of that patient. From the palliative, you follow the palliative performance scale, you give the options to the patient, what options he or she has, and then let them choose. That is the best way. And you continually give them psychosocial spiritual support. That is the most important. Means if you are going to end of life care, so end of life care constitutes all these things, and also you have to start at 1 or 1.5 months later bereavement care. So you follow the palliative performance scale. It will guide you thoroughly how to do, and always take the patient's opinion, what they want to do. Give them the options, let them choose. That will help you more. Thank you.
Thank you. Thank you so much.
Thank you.
Thank you to all our esteemed judges and speakers for this wonderful session on cancer pain. Now we'll move on to the next session, How I Do It.
Our How I Do It session brings together the masters of pain management to share their secrets, techniques, and expertise. Our expert faculties will take us through their step-by-step approaches, sharing the nuances and tips that make all the difference. To chair this session, I would like to invite our esteemed chairs, Dr. Sudeshna Thapa, pain physician and anesthesiologist from Nepal Pain Care and Research Center, Kathmandu. Dr. Archana Yadav, consultant pain and anesthesiologist at Nepal Police Hospital, Kathmandu. And Dr. Pyale Mandal Basak, specialist in neuro rehabilitation and interventional pain management. Now I would like to invite Dr. Snehal Panchal, in charge of pain and palliative clinic at Holy Spirit and Bhakti Vedanta Hospital, onto the dais for her presentation on tendo Achilles calcification barbotage.
So good afternoon, everyone. First and foremost, I would like to thank everyone who is sitting here, because this is the last session, and I guess there is too much of academic bombardment since the past 2 days, and I'll try to make it as simple and as fast as possible so that you can proceed with your further programs. So actually the topic given to me was, firstly at the outset, I would like to thank Gautam Das sir, Dr. Sushpa, Dr. Smriti and the entire team for arranging such a wonderful conference and giving me an opportunity to present my case. This is of course a video presentation. So it was on tendoachilles tendinopathy. So it's also called as Haglund's deformity. It's an abnormality of the bone and the soft tissues in the foot where there's an enlargement of the bony section of the heel where the Achilles tendon gets inserted. Can you play it? Yeah. So I have tried to make it with some music and as a video so that it doesn't sound very boring. So the predisposing factors are, first is foremost, it's idiopathic. It can be idiopathic, there can be no cause. There can be certain genetic cause. These are patients who have especially high foot arches because of the tilting of the heel backward into the Achilles. They can have, there can be predisposing factors, there can be injury, proper footwear, over practice, like repetitive stress, altered biomechanics, which with subtalar joint malalignment, and increased weight, which adds to the mechanical stress. And what are the signs and symptoms? So there is a noticeable bump, so which is an enlarged prominence at the back of the heel. There is heel pain, constant pain, okay? And there can be some redness and swelling. And why does this happen? There's continuous friction between the soft tissue at the back of the heel and the shoe, and which can cause the bursa to be inflamed, okay? And there are certain differential diagnoses which are common for the back of the heel pain, which is tendoachilles tendinitis, retrocalcaneal bursitis, retroachilles bursitis, plantar fasciitis. So physical examination includes bursa, tendon, calcaneus examination, functional tests. There are certain functional tests like hopping on the toes, X-rays to identify a bony protrusion, ultrasound which helps us in identifying the pathology of the bursa, and MRI can be used, but I think ultrasound itself is fine. So this was a lady who had come to me. She was a 48-year-old female and she complained of pain in the back of the heel, and you can appreciate. This is the marker. Okay, so there is a nice spur and there's some calcification there, okay? She had tried ultrasound and physio. So this is a bump, okay? It's called as pump bump because this is the pump muscle and then there is a bump here, okay? Okay, this is a wrong slide, sorry. So we did the PRP later. So this is how the patient was painted and draped. Because it was a hard calcification and I knew I wouldn't be able to do myself, so I had a radiologist friend who helped me to hold the probe. It started with, we just used a sterile technique and I gave the local anesthetic injection, okay. So you feel for the bump and just above it, I injected some local. Okay, so you aspirate and inject some local anesthetic. Okay, then so you can see the needle coming here. Okay, so this is the needle, which was a 16 gauge hypodermic needle, 1.5 inch. We started insertion inside after giving the local, and this is a nice bump which you can appreciate. Okay, so it was a little difficult, but we could manage breaking the calcification. So sometimes if they are not soft calcifications, it becomes very hard to break it. Of course, this was not so hard. So you can see we could nicely break the calcification. We tried to do some barbotage, saline barbotage also with it. So you have to check, keep on toggling the probe and check it, because sometimes we feel you may have broken the calcification, but some part could have been left behind. Okay, so you can see it's almost getting done. So there's something at the tip left, yeah. There's some amount of bursitis also here. Okay, so this is saline barbotage I started doing. There was some part still left. See, when we changed the position, we could appreciate some part of the spurs still left. One sec. See, some part was still left. So again, with the saline, I tried to do barbotage, okay. So you reconfirm, or you can make the position axial again and check it again. If you feel some part is still left, you can again, repeat the same technique. Okay, now it's looking a little fine. Okay, yeah. Yeah, see, we could break it actually very well. Yeah. So I routinely use these Tubex kits. These are the PRP kits. So we collected around 20-25 ml of the blood. We put it in the chamber and then put it for the centrifuge. So we usually use a double spin method. So after the first spin, we actually okay, and then you rotate and get the PRPs concentrate up, and again put it for the second spin. So this portion, the PRP gets collected usually. So second spin. Okay, and okay, so the supernatant, which is plasma, which is removed, and then the PRP is collected. Okay, it's sterile precaution. This is the long needle which we use. Yeah. So I had told him to give me a little more volume because I could see some bursitis also there. So I was planning to inject a little there. So he gave me around 3.5 ml. So this is the plasma which was collected, the PRP. And then again, under X-ray vision, okay. Yeah, so okay, you can see some fluid being injected here. Yeah, see you. Okay, thank you very much.
Thank you. Thank you, Dr. Shnehal Panchal, for the wonderful presentation. We will keep the question answer sessions at the end of the session.
Thank you, ma'am. Next, we have cryoneurolysis of peripheral branches of trigeminal nerve. For this, please welcome Dr. Smruti Rekha Hota, pain physician associated with Relief Spine and Pain Clinic, Sambalpur, and Daradia Pain Clinic, Kolkata.
So, good afternoon, everyone. Today, I will be presenting cryoneurolysis of peripheral branches of trigeminal nerve. So, these are the terminal branches of the trigeminal nerve. As you know, the facial pain, particularly trigeminal neuralgia, is the most excruciating pain condition. And here patients describe is at electric shock-like and stabbing pain that completely disrupts the quality of life, and we know it as suicide disease. While medications are the first line of treatment, many patients either fail therapy or develop any side effects or remain partially controlled. That is where interventional technique become vital. So to understand the interventions, we must revisit the anatomy of the trigeminal nerve. I will not discuss much. As we all know, there are three branches, main branches, V1 ophthalmic, V2 maxillary, and V3 mandibular. Here, our target for the cryoneurolysis are those divisions which are through percutaneous interventions, like supraorbital and supratrochlear branch of V1, and infraorbital and zygomaticofacial branch from V2, and mental and auriculotemporal from V3. We should know the branches, and accurate anatomical knowledge is vital for the procedures, as cryoneurolysis targets them precisely without damaging deeper structures. So what is cryoneurolysis? It is the controlled application of the extreme cold, usually between -60 to -80 degrees Celsius, and that is delivered through a cryoprobe. That cold forms an ice ball around the nerve, and it causes Wallerian degeneration. Importantly, the epineurium and perineurium are preserved here. That will allow the nerve to regenerate over 3 to 6 months. That means we achieve a long-lasting pain relief without any permanent nerve destruction. So why we choose cryoneurolysis? Because cryoneurolysis mainly useful for trigeminal pain, and it can all be also helpful for the only peripheral branches. Suppose mental nerve is involved. So why to do a more invasive procedure if we can access through the peripheral branches? So firstly, it is very minimally invasive and it can be repeatable. Secondly, unlike the chemical neurolysis or RF, it doesn't raise deafferentation pain or crosstalk or any permanent numbness. And third, it provides a middle ground between the conservative and pharmacological treatment. So what are the indications? Classic trigeminal neuralgia, where pain is localized to a single branch, like mental neuralgia, infraorbital neuralgia, or supraorbital supratrochlear neuralgia. Then post-traumatic trigeminal neuropathy. For example, after dental extraction, inferior alveolar nerves are affected. So that's where we can do mental nerve block. And then post-herpetic neuralgia, where involving the trigeminal branches, like supraorbital, supratrochlear are most commonly involved. And chronic idiopathic facial pain with localized peripheral triggers. In carefully selected patients, the results are very gratifying. So contraindication, of course, not everyone is a candidate. It includes active local infection, coagulopathy, and unrealistic patient expectation, those who are expecting 100% pain relief. A good pre-procedure counseling is important, that's why. Then, now technique, the patient position. And all the three, these are facial intervention, that's why patient position is commonly lying supine position, head either in neutral position or slightly extended, and under anatomical landmark guidance or preferably ultrasound. But nowadays landmark technique is almost obsolete. That's why we prefer ultrasound, and we identify the target nerve. Then local infiltration is done, And cryoprobe is advanced percutaneously adjacent to the nerve. And one more important thing, you should not go deeper into the foramen. So we are not targeting the deeper branches. We are targeting the nerve that exiting through the foramen. So here, cryoneurolysis, what is the process? It is the freezing and defrosting that started at a temperature of minus 70 to 80 degrees centigrade and for 3 minutes or 180 seconds. And tip of the probe achieve a cooling temperature of maximum minus 78 degrees centigrade. You can see the ice ball formation as a posterior acoustic shadow under ultrasound that I am showing next. So we should be familiar with the cryoprobe. So it is a probe. You can see for the peripheral branches, we use a 2 millimeter of the cryoprobe. And that 2 millimeter cryoprobe can form a lesion of up to 5 to 8 millimeter of size. It can maximum 1 centimeter lesion we can create through the cryoprobe. So no need to touch the nerve also. Even if we keep the probe adjacent to the nerve, we can create a lesion of 1 centimeter. So this is the cryo machine, and you can see the lesion, that is the ice ball formed through the probe. What are the advantages? The most important, minimally invasive. We can repeat as many times as we do want, and there is no risk of deafferentation pain and preservation of normal sensation even after recovery. And one most important is immediate pain relief in the OT table. And limitation is the effect is temporary, that require precise location. And yes, now RCTs are coming, but still limited. So you can see the probe position. This I have taken from my mentor, Dr. Gautam Das, and these are the procedures that I have done in Daradia Pain Clinic. So for the mental neuralgia, you can see the probe position exactly over the mental foramen, 2.5 centimeter lateral to the midline, and at the center of the chin. And infraorbital neural nerve, you can target just below the infraorbital rim, inferior orbital rim. So these are the 3 cases that I have performed with Dr. Gautam Das sir. And here, a 45-year-old gentleman that has severe infraorbital neuralgia after dental extraction, and medications was ineffective. He was losing weight due to pain on chewing, not able to eat his food. We performed the ultrasound-guided cryoneurolysis of the infraorbital nerve, and that lasted for 5 months. And you can see the position of the probe in that female. You can see the location of the probe. It's not gone deep inside the foramen. It is just at the entrance of the foramen. And you must be seeing some blood vessels also along with the nerve. It goes. You must be thinking, what about the nerve? If it got damaged, nothing to worry. Blood vessels, they may got frozen, but collaterals may form. So damaging the blood vessel is not an issue. Then second case, this is a 67-year-old male with past medical history of diabetes and hypertension, presented to our clinic with persistent sharp-shooting electric shock-like pain in the left jaw. And the pain started 7 years before the initial presentation, where he was diagnosed with mental neuralgia. That pain was also severely impaired, and the patient's quality of life, he is also diabetic and hypertensive, I forgot to mention. You can see the probe position, and the probe tip is kept adjacent to the foramen, and you can keep it 1 mm, 2 mm above the foramen also. And how the mental foramen looks under ultrasound guidance, it will look like a breach in the continuous bone. So okay, you can see the breach, and just where you can see that breach, you just put your probe above that. And there is mental artery and blood vessels will be also there. You can check through the color Doppler. And you can see the ice ball formation in the third picture. And this is another case, 62-year-old female with persistent left-sided forehead pain for 8 months. And it was described as burning, stabbing, and electric shock-like with allodynia, to touch over the left supraorbital and supratrochlear regions. History revealed an episode of herpes zoster ophthalmicus 10 months earlier, after which pain persisted despite resolution of the skin lesion. On examination, there was tenderness over the supraorbital notch and supratrochlear region with hyperalgesia and sensory changes along the distribution of ophthalmic division, and visual acuity was preserved. Diagnosis was PHN that involved supraorbital and supratrochlear nerve, and the patient had failed trial of all the neuropathic pain medications. Now you can see the position of the probe. Supraorbital, it is just at the supraorbital rim, that foramen, and when you move medially, when you move your probe medially to the supraorbital foramen, you can find the supratrochlear foramen. So at one time you can proceed both the block or both the ablation. You can see the post-herpetic lesion is there. And either we can go from medial to lateral, but for supraorbital and supratrochlear, the same direction, you can see the probe position, and it is very superficially at a depth of 0.5 centimeter or 5 millimeter. So this is how we perform the procedure, and all the three patients had a good pain relief of minimum of 3 months duration. So please give me 2 minutes. Outcomes. So what outcome we can expect? The most studies report immediate pain relief in 70 to 90% patients. Duration of relief that ranges from 3 to 6 months. And since the nerve regenerates, procedure can be repeated without cumulative damage. For example, in one case series of infraorbital neuralgia, 80% of patients remain pain-free for at least 4 months with repeat cryo providing similar relief again. But in case of RFA, you might have noticed the first radiofrequency ablation of the trigeminal neuralgia. The second time when we repeat it, there may or may not be that much relief. And then in future direction, looking ahead, the role of cryoneurolysis is expanding, and there is growing interest in combining cryoneurolysis with regenerative injections like PRP to enhance its recovery of the peripheral nerve, and with better USG probe, precision targeting of even smaller peripheral branches will be routine. And I believe cryoneurolysis will soon become a standard step in interventional pain ladder for any trigeminal nerve peripheral branches pain. Thank you so much.
Dr. Shruti Hota, she needs no more introduction. It was a very insightful, nice presentation. We'll keep the question answer session at the end of this session, and we hope we have so many questions to ask her.
Thank you, ma'am. Now I would like to welcome Dr. Anamol Haq Milton, consultant at Spring Hill Hospital, Bangladesh, and faculty at Daradia Pain Clinic, Kolkata, to the dais for his session on vertebroplasty.
Thank you, distinguished chairperson and dear audience. Thank you for your kind presence, because the second day and after the post-lunch, it is very difficult to continue your hearing. So thank you. Without any delay, I will try to start my lecture. So today, I have a lecture regarding the vertebroplasty. Though it is a high-end procedure in contrast of pain physician, but it is a very rewarding procedure to watch, because when actually you do one vertebroplasty with a immobilized patient can mobilize after the procedure. So it is a very, very grateful patient party also, and you are also feeling very good. So there is no disclosure and there is no conflict of interest regarding my presentation. So if we see that in vertebroplasty, it started at 1987. First, it did over the cervical hemangioma. So after 10 years later, there is a publications in USA, and after 7 years later, it was approved by the FDA. And all over the world right now, a lot of vertebroplasty, kyphoplasty have done under the pain physician. So it's nothing, it's just cementing. It's cementing over the floor like when a building is made. So it's a cementing over the vertebral body when it is breaking. So usually we we use the polymethyl methacrylate over the vertebral body, and it make hardening the fracture area, and it causes the hardening, and all pain are gone. So before that, actually, we have to know the vertebral fracture classification. So grade 1, grade 2, and grade 3. So grade 1, 20 to 25%, usually we do without any kind of problem if the posterior cortex is index of the vertebral body. Grade 2, up to 40% fracture, we also do the vertebroplasty in this patient. But after 40%, that's mean the grade 3, that is very critical. But those are practicing for the couple of years, even those are completed more than 100 cases. So they also do if it fracture more than 40% also. So osteoporosis, it's a silent disease because we know that after 50, almost every 20% female, 25% female, even the 20% male are actually suffering the osteoporosis. But if we have not scanning our spine and the hip, we never find out this problem. So we can find out our problem with the DEXA scan. So this is a silent disease. Okay. So if we see what is the scenario in USA, in 1.5 million people, they have actually suffering, and over 50% of them have a have a vertebral fracture. So most of them needed the vertebroplasty within 1 to 2 months. Okay, so hospital admission near 1,500,000 people over the year. Okay, so if you see the epidemiology, so it's depend on the multifactorial, like a lot of incidents, a prevalence is there, risk factor is there, and especially the non-modifiable, like the age and sex. So we know that in female, osteoporosis is more than the male, and outcome and burning, because it is a high-end procedure, sometimes patient not go for bearing the cost. So this is also a issues. And prevention and gap up. So we have need to, before the fracture, if you just exclude that patient of suffering the osteoporosis, so you have to correct this osteoporosis with the supplement of the vitamins, vitamin D, and patient should work, because we know that after 30, actually, deposition of the calcium inside the body, only one theory is there, that is you have to work out, you have to run, then only the calcium are deposit within the vertebral body, all over the body, and it is hardening, and it gives the support in your rest of the life. So epidemiology, almost we know that it's around the 40 to 45 to 50% in case of the female, and male around 25%. And problem is there, the prevalence gradually increase with the age. So if we see after 75 years, so near 90% female have prone to develop the osteoporosis as well as the osteoporotic fracture. So patient selection, this is very, very, very important for which patient you want to do, which patient you want to not to do. So single level is very important. Sometimes you can do the second level if you have enough experience and you have a exposure, very better exposure. And always you see the X-ray, but there is a fracture level in the lumbar 4 or 5 level, but there is no pain at the adjacent level. So never do this vertebroplasty, because many patient I saw, patient have a fracture, 3 to 3 area, there is a fracture, but only one vertebra is painful. So only do this area which vertebra are painful. So you have to go for the demarcation to the vertebral area which are very painful, that is your targeted area to go for the vertebroplasty. So, and it should be the recent fracture. If it is the old fracture, so there is a sclerosis is there, some bony formation is there. So sometimes these are not painful. So always avoid. Even if you try to give semen inside the old vertebra, there is already sclerosed. So sometimes it may be the refracture also. So it should be it should be kept in mind either it is a recent fracture or not, or this fracture already sclerosed or not. It should be always judgmentable. And noise sclerosis, this is the important. And another one things, that is patient selection. Those patients no need to the vertebroplasty. So one is the, if the fracture, so most of the time these fracture line are healed. So this patient should be avoided. And another is you need to do exclude these few things. There is the spinal canal stenosis. Why? Because if it is this spinal canal is stenos, if you go like if you give the cement, some of the leakage are in every time. But when actually there is the stenosis there, so that time it is a very crucial thing. If it is leakaged, and it may causes the cord compression of the lower limb. Okay, so either there is the any disc herniation, facet joint, SI joint pain, you have to exclude these things. So finally, there is the mainly the three criteria. One is the painful fracture vertebrae. It should be within 4 to 6 weeks maximum up to 3 months you can consider. And in the MRI, you should find out there is either fracture or not, and it may actually calculate these things. Either I should go for this or not. And always palpate the percussion. It is correspond the fractured area or not. This is the very, very, very important part. Now, how does the actually vertebroplasty or vertebral augmentation reduce the pain? So number one is the stabilization. So fracture, when there is the fracture, so it is the unstable. So when actually you give the cement inside the bones, so it's become stabilized. So it's stabilize the fracture. And second one is the heating. So when actually you mixture the powder with the liquid things, so there is some heat is generated. So in just you make a ball. So inside the ball or center of the ball, if you measure that, it's around 80 to 90 degree of temperature. So when we push this cement inside the body of the vertebra, so it created the heat inside the body of the vertebra. So we know that there is some nociceptor is there, some myelin sheath is there, so they are actually burned, they are actually ablate, and this nociceptor are, when it is ablate, it cannot carry any kind of pain. So hitting the nociceptor and burning this nociceptor and reduce the pain after doing the vertebroplasty. Now, what are the indications? So common indication is the osteoporosis. So primary, secondary osteoporosis, and another is the trauma like the road traffic accident, like the fall from the height, and sometimes there is the symptomatic microfracture. Suppose have a history of some work, and every day there is some microfracture and it is gradually unstable. And some neoplasm is there, like the multiple myeloma, hemangioma. Now, absolute contraindication, where you should avoid these things. There is the healed osteoporotic fracture. That's mean patient have a previous history of the osteoporotic fracture, but now it is healed. So never do these things. So when actually you want to give cement inside the bones, so it is refracture. So you have created these things. So you should avoid these things. And asymptomatic stable fracture, if any kind of allergy of the PMMA, and sometimes there is the any type of the coagulopathy, and prophylaxis of the osteopenic patient. Patient still not developed the osteoporosis, even there is no fracture. Only the osteopenia is there, so no need to early intervention, or without any problem, you have never do the vertebroplasty to this patient. So, and if patient have a previous history of the discitis, not previous history, present the discitis, osteomyelitis, epidural abscess, even patient have a cardiopulmonary disorder, and some relative contraindication like the significant compression of the spinal canal stenosis. If there is stenosis, because almost 30 to 70% cases there is some leakage. So it's mainly the venous leakage. But if there is any fracture in the posterior cortex, so it is leakage. If it is already stenosed, it causes the cord compression. So like the back pain or non-fracture and greater than the 1 year, and vertebral body compression if more than 90%. So initially you do up to the 40%. So when actually you do few cases like 50 cases or more than, then you can consider up to 70-80% fracture. But always judgment, either I can give any benefit to the patient or not, it should be the judgmentable. And if there is the tumor extension in the epidural spaces, it is a relative contraindication. So right now, what are the benefits after doing these interventions? So the longer pain relief after doing this procedure, fracture is stabilized, and it is stabilized within the 24 hours to 48 hours, and decrease the risk of the comorbidity and improve the mental health also. So before the procedure, we need the few pictures. So one is the X-ray. If patient have a previous X-ray, so it should be compared with this. Either there is the fracture or not, how many height are actually gone, you can compare. And always do the MRI, especially the T1, T2, and ST MRI, you can compare either there is the bony edema or not. And another one very important thing is there is the posterior cortex is intact or not, and the pedicular, especially the medial pedicular line is intact or not. This is very important. And also do the BMD, either patient is osteoporotic or not. So counseling is very important. Always take the written informed consent from the patient and explain the procedure and explain the all complication to the patient, because it is a high-end procedure. Sometimes it may causes the cord compression, though it is not so high, rate is not so high, but it should be always talk to the patient. So anesthesia. So most of the time actually I avoid any kind of anesthesia, including the sedation and analgesia, because I can talk with the patient. If patient feel any kind of problem, patient inform me immediately, I can take any kind of action. So what I did in my practice, we know that we use the Jamshedi needle. It is a 13 gauge needle. So it is a large diameter needle. So first I have put my 22 gauge needle, and I have give the plenty of local anesthesia through the whole path, and also give the plenty of anesthesia like a 1% lignocaine at the posterior part of the pedicle where I am screwing and where I am drilling. So I give and I have wait for the 1 to 2 minutes. After that actually I have put my Jamshedi needle and go through the pedicles. So monitoring, it is very important. You have to monitor the standard ASA monitoring system, including the all OT setup, including the like if needed the any intervention, any intubation, you have also ready for this, and always needed the IV antibiotic before the procedure. So here actually I show how actually I have do these things. So here we know that's the pedicle. So in the pedicle, in the AP view, you can see it is look like the oval. So I have to turn like 5 to 20 degree, up to 20 degrees. So that time actually I can see this is the mostly the oval shape. So when we can see the oval shape, we have actually cut it in the 4 quadrants. So upper and superior part is the targeted area. Why not the lower part? Lower part, if I targeted the lower part, so that time when actually I enter through the pedicle, so that time actually I miss the, if I miss the pedicle, so below the pedicle heart is this, there is exiting nerve. So it causes the injury to the exiting nerve. Okay, so why I am not in the medial part, I am in the lateral part, superior lateral part. If I target in the medial part, so when actually I travel from lateral to medial through the pedicle, so that time I can breathing the medial part of the pedicle. So when actually I breathing the pedicle, that also very closer to the interthecal sac as well as the exiting nerve. So it causes the damage of the nerve. Okay. So here is the transition. So sometimes there is the upper part is a fracture, sometimes there is the depressed fracture, sometimes there is a lower part fracture, sometimes there is fracture. So you have to planning when actually you see the MRI and as well as when actually you see the X-ray. So what is your trajectory plan? You have to see these things. Okay. Now there is a 4 condemns. So I have make a 3 line here and 3 line there. So my entering point is this 1 and 1 cutting line, and after that cross these things, and finally I have entered the cutting line of the 3 to 3 area. So here very important is the medial border, because the medial border is very important. If I breach this medial pedicular line, so it causes the damage and it causes leakage the cement within the canal. So it is a very dangerous part. Okay. So always keep your needle just within the medial border of the pedicle. This is the main part of this intervention. Otherwise, it is very easy. You can do without any kind of hesitation. So here, this is the first part. There is the pedicle, you can see. So I have cut it in the 3 lines. So this is the lateral pedicular line, this is the medial pedicular line, and this is the medial pedicular line. So just I have touched the superlateral portion of the pedicle, and you can see in the lateral view, I have just the posterior part of the pedicle. Okay. So when actually I enter almost the 50% of the pedicle, so that time it touches the middle pedicular line. Okay. Never cross this. If it is touches the medial border, so that's mean in the next step you have bridging the pedicle. This is the very important part. Okay. So when actually I have touched the posterior border of the vertebral body in the lateral view, that time I can see I have just touching the medial pedicular line. So this is very, very important. So this part is the important in your setup. Okay. So here you can see this is how I am entering into the vertebral body, and my final needle position, it should be the just junction of the anterior 1/3 and posterior 2/3, and my cementing, it should be cover only the anterior 2/3, not the posterior 2/3. Why? When actually we come to the posterior 2/3, so that time actually chance of leakage is so high. So better to avoid these things. So I have actually mixing this powder with this liquid, when actually you keep this mixing within the ice ball, so it give you the longer time to hardening this cement, because you have to take multiple syringe and you have to push and you have to take the picture. So it takes around 5 to 7 minutes. So you have to take time. You can increase your solidification time use of this ice. Now you can see this is, I have feeling the upper part, then gradually almost I have feeling the anterior and the middle part. Okay, is the AP. Now you can, after this image, you are so enjoying these things. This is another picture. There is another article is there. There is the in acute painful vertebral fracture, you can go for intervention as early as possible. Just give me 3 minutes to conclude. So during the cement delivery, this is very important. If no flow, that's mean your cement is hard. Your cement mixing is hard. You need some liquid. If it is so like liquid, so what happens? There is a multiple venous plexus around there. So most of the cement goes to the venous area. So you make it as the paste. So in the morning we are using this paste, so it look like the paste. It's not so hard, it's not so liquid. So complications occur almost in every patient, but major complication usually if you follow the wall steps usually never happen these things. So minor complication, usually there is small cement leakage, it is asymptomatic, and almost 25 to even 90% cases actually we have encountered these things. And the venous plexus embolism, it is but mostly asymptomatic. And the perineural neuritis is there, small lung embolism is there, sometimes the bleeding, pneumothorax, and sometimes the pedicular fracture. If pedicular fracture is there, so that is very, very crucial things in your part, because if it is leakage in the medial side, it causes the compression of the cord. So it is a very dangerous thing. But it's no need of any kind of surgery also. Major complication. So if there is a large leakage with a canal stenosis. Why canal stenosis? Because we know that most of the time actually we do these kind of intervention over like 60, 65 years or 70 years. So they are already compromised with the canal. So there is a small canal. So if it is leakage, large amount of the cement, it causes the cord compression. Immediate need the surgical intervention and decompression of the same, of this part, okay? And sometimes the lung embolism, if it is so liquid, so if it is a large cementous go inside the lungs, it causes the like the large lung failure. So here is a few picture you can see. This is the posterior. Always I tell that MRI is a very, very important. If needed, you also do the CT scan, the 3D CT scan of this particular vertebral body, 3D CT scan. In the 3D CT scan, you can see either the posterior cortex is intact or not. There is posterior cortex is leakage when actually he give this cement. So posterior cortex is leakage, so cement comes within the canal. So this is a dangerous condition. So here, the some cement are go up and down. So there is not big problem. So here you can see in X-ray, there is some cement comes to the lungs area. And in CT scan also there is a hyperechoic structure you can see. Here, this is a very dangerous things you can see. Already pedicular break and cement are goes to inside the canal. And this causes the cord compression. Okay, so it needs the immediate evaluation, surgery, and it should be removed these things. Here you can see both of the pedicular fracture and cement comes to the canal area and it causes the cord compression. Here you can see there is that only producing the track. Why it produces the track? Because we know that we have used the Jamshedi needle 13 gauge and it's around 10 to 12 centimeters. So inside the barrel of the needle there is also cement. So when actually we remove these things, sometimes if you push these things not inside the bones, so sometimes it created some cement leakage in this area. So you have to just pull and give the push, okay? So just 1 minute. So this is actually the some literature regarding how much actually improve these things. This is another literature. So very small video. After this video, I have concluded my lecture. So here you can see in AP. Here we are in the superior and lateral part of the pedicle. You can see the oval shape. And also in the lateral view, you can see we are in the just posterior to the pedicle. Okay, we are touching these things, but our needle direction is not at the same. So, okay, so here we have tried to enter more, and you can see this touching. Here already we have in the middle of the pedicle. Here we are almost in middle of the pedicle. Here we have touching the medial border of the pedicle, and we have touching almost at the posterior part of the vertebral body. We have entered, we can see here we are entering inside the vertebral body. We can see these things. So this level is very important. So when actually we enter, and then that time actually we have given small amount of cement, and this cement should be given under the running fluoroscopy, always given under the running fluoroscopy, okay? And after that, you have to take always on AP and lateral, AP and lateral. So every time you have to change your C-arm position. So after giving these things, just you have to push and you have to see, not feeling the posterior 1/3, just anterior 1/3. You have to feel this anterior 1/3. And it cover only the one side. So we have put another needle also, and then we will cover the next level also. Here you can see in the lateral view. So both sides of needle, we can see these things.
Thank you, sir.
Thank you.
It was very nice presentation, elaborative presentation. Thank you.
Thank you, sir. Now we have come to the last talk of this session. Please welcome Dr. Anjali Kumari, Assistant Professor at Kalinga Institute of Medical Sciences, Bhubaneswar, for the last topic of this session, median neuropathy.
Good evening, everyone. Thank you for ICRAPAIN and the Daradia Pain Clinic for inviting me to present a talk as a budding pain physician. So without any further delay, I would like to start. My topic for today's presentation is median neuropathy. A perfect diagnosis is the key to successful treatment. So nerve entrapment, particularly carpal tunnel syndrome, is a familiar term for many, but it's just the tip of the iceberg when it comes to conditions affecting the median nerve. So the agenda of my today's talk is to shed light on nerve's pathway and various points where it can get entrapped. So with this anatomical background in mind, a pain physician should proceed to evaluate patients with symptoms of entrapment neuropathy. So looking at the natural course of the median nerve, we see the median nerve, it originates from lateral and medial cord of brachial plexus. C5 to T1 is the nerve root value. In the axilla, there are no branches. In the arm, there's just a branch of the brachial artery. The relation with the brachial artery, when the nerve moves from proximal to distal, is first it lies lateral to the artery, then anterior, and then medial, as we all know. In the cubital fossa, which is a very important site, and usually we start the scanning from there, the nerve lies medial to the brachial artery and travels distally between the two heads of pronator teres. In the forearm, it gives off the anterolateral nerve, which is the motor nerve, and passes between the two heads of flexor digitorum superficialis and flexor digitorum profundus. In the wrist, it enters below the flexor retinaculum after giving off the palmocutaneous branch. So this, in short, is a diagram showing the course of the nerve. So based on this anatomical knowledge, we all know there are certain common entrapment sites where the nerve becomes superficial. So this diagram shows in short all the sites. So the first is the ligament of Strudus and bicipital eponeurosis, which is usually rare when patients present to us. The next point is the laceratus fibrosus and the pronator heads, the two heads of pronator teres, where the nerve can get entrapped. There's also the entrapment of the AIN, which is the anterolateral nerve, but in this case, it is a very typical presentation where only the motor loss is there and no sensory symptoms, as AIN is a specifically motor branch. The next is the carpal tunnel, which we all know is the most common, and the patient presents with the symptoms of classic carpal tunnel syndrome. So this picture, I think it's everybody's favorite, the beautiful median nerve in the carpal tunnel, which we have shown, and this is the pisiform level at the inlet of the carpal tunnel, the capitate and the hamate bone. So carpal tunnel syndrome, as we all know, accounts for approximately 90% of all peripheral entrapment neuropathies. The prevalence is 3 to 6% in general population. Females are more affected, almost thrice as compared to males. The diagnosis is based on clinical signs, symptoms, electrophysiological studies like EMG and nerve conduction velocity, and the high resolution point of care ultrasonography, which can be done by the pain physicians in the OPD itself. So this video, a very beautiful bifid median nerve we can see, and this is how I do it in our OPD setup. We'll go from the ulnar side and we dissect, the hydrodissect with 5% dextrose. We hydrodissect the nerve, both above the nerve as well as below the nerve. So this is a short video where I wanted to show you a beautiful bifid median nerve and how we are hydrodissecting it. So enough of this. So today's topic is not all that tingles is carpal tunnel. This I would like to enlighten with a case. It was a 50-year-old male who presented with a history of road traffic accident with right distal and radius fracture and underwent open reduction internal fixation. So this was the X-ray after he went surgery, post-surgery X-ray. After that, the patient, few weeks after surgery, the patient developed electric shock type pain associated with tingling and paresthesia over right lateral 3.5 fingers. The nerve connection study showed moderate neuropathy of right median nerve, which suggested carpal tunnel syndrome. So this patient was still at the orthopedician, and they started conservative treatment with high doses of pregabalin 150 BD, amitriptyline 25 BD, tramadol for the pain relief 50 BD, but there was no significant pain relief, and pain worsened. They planned the patient for surgical release and decompression of the right median nerve at the carpal tunnel, but still the patient did not get any relief. So at this point, the patient was referred to us, and in the MRI cervical spine also, which they had done, there were no significant changes. When the patient came to us, we took a detailed history, clinical examination, and point-of-care ultrasound examination was done, which revealed. So this is the video which I want to show you and guess the diagnosis. So this is the nerve. It is somewhere at the distal forearm. And as we can see, these are the two heads of flexor digitorum superficialis and profundus. So basically, the nerve was entrapped in a scar which was formed after the operation, which was overlooked by the orthopedician as no ultrasound was performed, and NCS was not able to locate the exact entrapment site of the nerve. It only gave a picture of neuropathy, but the site was not exactly predicted. So the diagnosis was post-operative scar entrapment of the median nerve at the distal forearm. So we proceeded with the intervention. We counseled the patient for hydrodissection, and this is how I do it. Again, from the ulnar side, we proceeded, and as the entrapment was because of the scar tissue, it was slightly difficult for the needle to penetrate, but somehow, slowly we did it without injuring the nerve, keeping in mind this was the thickened nerve. And slowly, we tried to get to space, and with small allocates of volume given, we tried to hydrodissect the space, and we dissected the nerve. So ultrasound-guided hydrodissection was done, and here we used 12.5% dextrose. I want to precise on this because it was a surgical entrapment, so we thought 5% dextrose would not be that much beneficial. So we gave a trial with this. 3 sessions were done 2 weeks apart. At 3 months follow-up, 40% pain relief could be obtained, which was not much significant, and RS scores were done pre and post procedure. So we further suggested the patient for a pulsed RF ablation of the nerve and surgical decompression release. Patient was not willing to proceed further, so we lost the patient to follow-up, but he had somewhat 40 to 50% relief, for which he was doing fine. So the take-home message from my today's talk is, not all median neuropathies are CTS, which we pain physicians are very fond of. Limitations of EMG and NCV studies, they only provide functional data, that is the latency, amplitude, conduction velocity, etc., but no visualization of the nerve or surrounding structures. So this fails to identify the exact etiology like ganglion, scar tissue, fibrosis, surgical hardwares, and many other pathologies. Here comes the role of MSK ultrasound, or we can say high-resolution ultrasound, which we can perform in the OPD itself. The advantages are localized, dynamic, non-invasive, and a very rapid evaluation. The point-of-care MSK ultrasound is why indispensable in modern diagnosis, and we should not forget about it. So as a last thing which I would like to say, we should combine the clinical features, electrophysiological studies, and also the ultrasonography for best results in patients like this. Thank you.
Thank you. Thank you for finishing it early. Thank you so much. So now is the time for the question and answer, only because we have taken a lot of time for this session. So only 1 or 2 questions to each speaker is allowed. Can you please come all the speakers to the dais so that question answering will be easier?
In this case, ma'am, we use tenable. Yeah. Because it was a surgical entrapment, it was a thickened scar. It was not like the normal carpal tunnel which we see, just a flexor retinaculum which has been entrapping the nerve. Because we use 12.5%. Yes, it is definitely you're right, but there are no. But what we tried to do here is, because there are certain research studies where they have seen hypertonic dextrose has more neuroregenerative potential when compared to 5%. Only problem is it's irritant. So what we did is we diluted it with a local anesthetic. Like the 25% dextrose, we mixed it with lignocaine and then we gave, so that the burning and the irritation would be less. But in certain studies, they have seen that if we go with the hypertonic dextrose in post-surgical entrapment issues, it is more beneficial. No, ma'am. We did it only because initially the patient had some relief, so we were hopeful. But after 3 sessions, when the relief was not more than 50%, then we advised the patient for a pulse RFA, which he was not willing because of financial constraints. Yes, that were ongoing. We had earlier, when the that, ma'am, we did not use. We only used the vitamin B12 supplements, which the patient was already taking, so that we continue. Thank you.
Can you please come all the speakers to the dais so that the question answering will be easier? Anyone has any, from the audience, any question to the speakers? I have one question to the Dr. Snehal Panchal. Yeah, you have shown a procedural video. There you have done with the hypertonic saline or normal saline? You did normal saline. So, the same procedure in the same sitting you have did the PRP. So how do you maintain, like, is there any dilution happen during the procedure?
I didn't inject too much saline inside. I just broke the calcific deposits. I put little normal saline and tried to aspirate. I couldn't aspirate much, so I didn't put more of normal saline. I just broke the deposits, tried to suck as much as I could, and because there was retrocalcaneal bursitis surrounding it, instead of putting a steroid inside the tendoachilles tendon, I found it more sensible to put PRP inside. Otherwise, peritendinous, I would have to put tendoachilles steroid, which I was not comfortable putting.
Any question? Dr. Shruti, there is a very nice presentation you had. Why during dealing with the orbital, like orbital branches, supra and infraorbital branches, did you face any? Because lesion is much more bigger, smaller, yeah.
What we feel, cryoneurolysis is the safest procedure. Complications are very rare.
Yes.
So we've never faced any complication. Other options, you can go for a pulsed radio frequency, you can go for alcohol neurolysis, but that is obsolete now. You can go for a local anesthesia and steroid injections. You can use soluble steroid. That is also one option.
Thanks to our esteemed chairs and speakers. As we conclude our today's sessions, I want to extend heartfelt thanks to all our distinguished speakers, moderators, and participants for your valuable contributions and enthusiastic engagement. Now I invite everyone to join us for the valedictory program.
A very good evening, respected dignitaries, esteemed faculty, international speakers, our brilliant fellows, and dear friends. I'm Dr. Charu, and it is my honor to welcome you all to the valedictory ceremony of ICRA 2025. Over the past 3 days, Kolkata has been the hub of knowledge, innovation, and collaboration. From groundbreaking talks on the MSK ultrasound and hands-on workshop and interactive case discussions, this conference has truly lived up to its theme, MSK ultrasound in pain medicine. And now, as we bring this wonderful journey to a close, we gather here to celebrate the success of this event, acknowledge the efforts of everyone involved, and look ahead with renewed inspiration. So let us take a moment and recognize and welcome the visionaries who has guided us throughout this conference. Please join me in welcoming Dr. Gautam Das Sir, Patron-in-Chief of ICRAPAIN. A big round of applause. Dr. Shirish Amatya Sir and Dr. A.H. Milton Sir, Scientific Chairperson. Dr. Shushpa Das Ma'am, Organizing Secretary. And all our faculty and distinguished guests who have made this event a grand success. Let's give them a warm round of applause. Okay, I would also like to call Dr. Smriti Hota Ma'am, Scientific Chairperson. And Dr. Hari Bodal Sir, Workshop Coordinator. ICRA 2025 has been more than just a conference. It has been an experience of learning and connection. Over numerous scientific sessions delivered by national and international experts, hands-on workshops that sharpen skills in ultrasound-guided pain interventions, insightful discussions on regenerative therapies, imaging, and new technologies, and of course, the memorable convocation honoring our graduating fellows. Each session has added a new dimension to our knowledge and has sparked new collaborations for the future. To share reflections on this journey and to officially thank everyone who made ICRAPAIN 2025 possible, I now invite Dr. Sushpa Das Ma'am, the Organizing Secretary, to deliver the valedictory address.
A very good evening to everyone present here. On behalf of the organizing committee of the 9th ICRA conference, ICRAPAIN 2025, it is my privilege to propose the vote of thanks. First and foremost, my heartfelt gratitude to all the chief guests and all the dignitaries who have come to join us for ICRAPAIN 2025. A sincere thank you to all our esteemed faculty members and speakers and chairpersons. Your insights were very valuable to all of us. And I would also like to thank all the delegates and all the participants for coming and joining us for this ICRA and for making ICRA eventful and happening every year. Now I would like to thank my organizing team. They're all here. I would like to thank the current batch of Daradia fellows and all my staff. They have been working hard, really hard for the last 1 month. And we've enjoyed the journey, but yes, there've been many people involved in making ICRAPAIN 2025 successful. I would like to thank each of our sponsors. I would like them to come on stage. I would like to thank Avanos. Anybody here, please come on stage. I would like to call upon stage Stryker. Anybody from Stryker?
Avanos team can come on the stage, and Stryker.
I would like to call upon stage Cipla Supracare 1 and Ciplo STEM.
Please come on the stage.
I would like to thank GE Healthcare.
GE Healthcare team, can you please come?
Sonoscape. Ajanta Pharma. And Recuse. Thank you.
In vitro, anybody from in vitro?
Okay. Thank you for all your support. We'll be having a group photograph.
Anybody from the sponsoring companies, please come onto the stage. Anybody? We invite all of you. Thank you all, thank you very much. Without support of the companies, a conference is not possible. So it is possible just because of your support, and we expect the similar support in our subsequent ICRAPAIN as well. So thank you all, thank you very much. Thank you.
Now I call upon stage Dr. Samarjit Dey sir for handing out the prizes for e-poster and for quiz competition.
This year's quiz was full of energy, excitement, and some very tough questions. Poster? Okay, okay. So let's move on the poster presentation awards. Every year, our poster sessions bring forward innovative ideas and valuable research, and this year was no exception. So here are the winners of ICRA 2025 poster presentation. Any guesses? So I'll announce first the second prize in faculty group first. Any guesses? It's Dr. Kirti Pawar, ma'am. A big round of applause for her. Can someone take prize on her behalf? Or someone call her, please. So the first prize goes to, any guesses? In faculty group. It's Dr. Madan Pawar, sir. Madan Pandian, sir. Sorry, I'm so sorry. It's Dr. Madan Pandian, sir. Can I have him on stage? He's gone, okay. So come to the non-faculty group. The second prize goes to Dr. Mamta June. Okay, we have one more prize. That's the third prize. And for that, any guesses? Dr. Shalina. She has left. And now the first prize in non-faculty group. Any guesses? It's Dr. Niveda. A big round of applause for her. So this year's quiz was full of energy, excitement, and some very tough questions, but many bright minds truly stood out. So there are 3 positions. Third position went to Team Baclofen and Team Etoricoxib. So Team Baclofen, Dr. Sai and Dr. Susan, please come on stage. And Dr. Shubhame and Dr. Bimlesh. Second position went to Team Amitriptyline and Team Carbamazepine. So Dr. Niveda and Dr. Deepanka from Team Amitriptyline. And Dr. Priyanka and Dr. Sri Lekha from Team Carbamazepine. Dr. Niveda, Deepanka, second position. And the first prize, first position goes to Team Duloxetine, Dr. Sunaina and Dr. Samir Basak. So, ma'am is there to collect the award from her. I would like to call, ma'am is coming to take the award for Dr. Kirti Pawar, ma'am.
Small announcement. Actually, we forgot it. So sorry for that. So there are some additional prize for the poster and the quiz competition. So poster presentation, so first, second and third prize, some additional prize from the Sonoscape company. So please, Dr. Mamta and Dr. Niveda come on the stage. And I'll be asking Sonoscape company to come. Yes, Kirti also come on. And yes. And now another prize from Avanas. Avanas? Okay. So, quiz competition, there are top three. Top three means because there are two group winning the second prize. So please come on the stage and the first prize winners. Quiz first and two second prize winners. Please come to the stage.
They have left. Dr. Priyanka and Dr. Srilekha.
And now it is the time to appreciate what Shushpa already mentioned, our hard-working fellows. So without that, this conference was really not possible. So they worked a lot for last 1 month, and you all have seen how beautiful was the quiz competitions. So credit goes to them. And all 2 days, all the hall was nice, so nicely, and again, all credit goes to them. So I'll be asking them to onto the stage. Please come and join. I also want to, I am inviting all the staffs of Daradia, again, who had worked whole night for the last few days and, worked a lot. In fact, one of them got fever, and still with the fever, she's here and working a lot. So I invite all of our staff on the stage and a little bit of token of appreciation for all our fellows and our staffs for their hard work. And for them only it was possible. Please come and join. And last two name, who actually behind all the staffs, my better half, and my daughter's better half. Where is Soham? So this time everybody is telling that this conference has some additional layer of colors, and that was possible for Soham. Where is Soham? Okay, so some certificates. Is getting certificates printed. Okay, first let us call the fellows. Sanjeev, fellow certificates.
So, Dr. Pavan Kumar Raya.
Dr. Priyanka. No, it's not.
Dr. Pushpak.
Dr. Pushpak. You can take the picture. Dr. Rupali. Dr. Suzanne. Dr. Mamta. Just take the picture. Dr. Hemlata. Dr. Suchi. Dr. Sailaja. Dr. Sailaja. Dr. Kathana. Dr. Deepak. Dr. Bindya.
Dr. Niveda.
Dr. Niveda. Let's take a group picture. Sanjeev Da. Okay, now I'll call upon all the staff whose hard work has shown the conference. Sanjeev Da.
Ritu. Now I call Moina. Moushumi, sorry. Shonali. Deep Shagor. And Monjur. My staff has been working really, really, really hard. I think as hard as our efforts, I think. So I thank all my staff. I'm getting emotional. Without you guys, I don't think we'll be functioning well. I would, Brojo Mama, he's like one of my family members. He's been here for supporting us. Please come on stage. I think a conference feels like a wedding going on in a house. At least at Daradia, we feel like that. It's a lot of hard work, but we have been having a lot of fun while doing it. I think at least I eagerly wait for the afternoon snacks when it comes, and I really like the chit chat that I have with all the fellows who are here, and also my staff. So yeah, for every ICRA, it feels like a festival at home. Okay, so we come to an end of ICRAPAIN 2025. Thank you, a big thank you to all who have been a part of the Daradia family and ICRA family. I call upon stage everyone present here in this hall for a group picture. And we have our past fellows sitting right here. Yes, please come on stage for a group picture.
So we have a special competition this year. It's like hashtag ICRAPAIN 2025. And the award goes to Dr. Santosh Dhakal.
I would like to thank everyone from the audiovisual team. Rita ma'am, please come for a group photograph.
Okay, so audiovisual people, the decorator people, the photography people, hotel people, all of them worked very hard, very nicely, in a very coordinated way, and that's why our conference went so successful. So without their help, without their support, without their hard work, it was not possible. So I'll be calling the full audiovisual team, photography team, Debu, your team, except one who will be taking photograph, please. So please be on the stage, all of you. All of you, please, audiovisual team also. Everybody on the auditorium, please join us. Please. Everybody, everyone. Zydus people, I was not seeing you. I have not called you. Please come us on the stage, please. No, what we can do? Plastic.
I saw that on your status. Nice. She gave that to नीचे चलते So 3 cheers to ICRA 2025. Hip hip. Hip hip. Hip hip. Woo.
Mic.